Okay. 5, 4, 3, 2, 1. Sir, we are live now.
Good morning, everybody. So we are starting the Cardiometabolic Update 2022. All of us know medical science is a rapidly advancing field where yesterday's fact may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. Continuing medical education is therefore a necessity of the medical profession, and this cardiometabolic update will address diverse aspects of cardiometabolic medicine to be delivered by a galaxy of speakers of national and international experts. The first session is on thyroid and heart disease by Dr. Pankaj Manoria. Can we have the CV slide? CV slide. Dr. Pankaj is a chief interventional cardiologist at the Manoria Heart and Critical Care Hospital, Bhopal. He has 10 years experience in the field of invasive interventional cardiology. He has several fellowships like FESC, FACC, SKY. His expertise in radial angiography and angioplasty, several publications in national and international journals, and he was past editorial secretary, Indian Heart Journal. I'll hand over the session to Dr. Javed. Dr. Javed, please.
Sir, good morning, sir. Good morning, all my friends. I welcome Dr. Pankaj Manoria for his very important talk on the thyroid and heart diseases. Sir, you all know that the thyroid and heart diseases are very commonly associated, but because of underdiagnosis or less diagnosis, they are not come into the fore. Today, Dr. Pankaj will be speaking on how the thyroid diseases, hyperthyroid as well as hypothyroid, affect the heart and what is the latest treatment on thyroid diseases. Over to you, Pankaj. You have been already told by Senior Manoria, sir, regarding your CV. Please, over to you, Pankaj.
Thank you, Dr. Javed, and good morning to all the delegates and the faculty members. I hope my slide is visible, and I'm audible also.
Yes, sir. Yes, sir.
Yeah. You see, thyroid and heart disease, they have a very strong correlation. Whatever mishap happens in the thyroid, it directly affects the heart. You can see, if you look closely, even the heart and thyroid resemble each other also. Thyroid affects the heart by number of ways. Thyroid hormone, it has a positive chronotropic effect, positive inotropic effect. That means it increases the LV contractility, it increases heart rate, it decreases peripheral vascular resistance, and it increases blood volume. So based on whether thyroid is on a higher side or lower sides, it affects through this pathways the heart or cardiovascular system of our body. So what I'll do is I'll share about 5 to 6 cases in which I'll show you how thyroid affected the heart and how we came to the conclusion that it is a thyroid which was responsible for all the cardiac elements in the body of the patient. Now, this is the first case. This was a 25-year-old female who had presented with shortness of breath, class 3, and her blood pressure was 100/60, pulse was 70 per minute, and echo showed a large pericardial effusion. Though there was not strong signs of tamponade, but the effusion was large. We aspirated the fluid, sent for analysis. The AD was negative. The proteins contents was high. We did a CT scan also. We didn't give us any clue as to what is the diagnosis, what is the etiology of this large pericardial effusion. Then we assessed the thyroid profile, and when we saw that TSH was 33 international units per ml, so clearly suggesting that severe hypothyroidism was the cause of pericardial effusion. We corrected the thyroid, hypothyroid, and with due course of time, the effusion settled and his blood pressure also improved. Lesson number 1 from this lecture is thyroid function test should be done in all patients of idiopathic pericardial effusion, because one of the major cause of large pericardial effusion is hypothyroidism. Effusion occurs in hypothyroidism. It's because of increased systemic capillary permeability and also disturbance in the electrolyte metabolism. The effusion is characterized by high protein and cholesterol content. It is usually large, but tamponade is usually rare in hypothyroid. pericardial effusion. Case number 2. This was a 65-year-old gentleman presented with palpitations, and he was in heart failure, class 4 symptoms, breathless. ECG showed fibrillation with fast ventricular rate. In fact, echo also showed a global hypokinesia. Ejection fraction was 40%. So we are dealing with a patient who's having a dilated cardiomyopathy and AF and with fast ventricular rate. Now, again, in this patient, we tried to find out other causes. Angiography was done, which was normal. Other causes were also ruled out, which were normal. And when we send this, the blood for thyroid profile, see the TSH was less than 0.1 and T3, T4 was raised. So this was a case of severe hypothyroidism leading to atrial fibrillation. He was stabilized. He was given antithyroid medicines, and his sinus rhythm was restored in due course of time with antithyroid medicine. Hyperthyroidism, increased thyroid, can cause increased heart rate, increased contractility, increased systemic and mean pulmonary artery pressures. It can lead to various arrhythmias. AF is the most common arrhythmias which is seen in hyperthyroidism. And these patients may have sinus tachycardia or atrial fibrillation. They present with palpitations, high output failure, also some systemic hypertension, wide pulse pressure. And these patients in hyperthyroidism, heart failure can be because of multiple mechanisms. One of the mechanisms, atrial fibrillation and tachycardiomyopathy. Other mechanism may be it can cause systemic hypertension, which in due course of time can lead to, first of all, concentric hypertrophy and then systolic dysfunction. Increased systemic circulation or high output state can also lead to LV dilatation and heart failure. So multiple mechanisms by which heart failure can be seen in hyperthyroidism. So the lesson from the second case is thyroid function test should also always be done in patients who presented with palpitations and atrial fibrillation and heart failure with no obvious cause. Third case, again, a very, very interesting case. This was a 60-year-old female who consulted me because of some alteration in the lipid profile. And if you look at this lipid profile, it's very unusual. You see the triglycerides are in thousands, 1341. LDL was not detectable. So there was some, it was very, very unusual lipid profile to seen. Now, we have seen that in some, whenever you encounter some unusual lipid profile, always assess thyroid, because thyroid dysfunction is one of the major cause of secondary dyslipidemia. And when we sorted out the thyroid profile, we found that the TSH was 60, gross hypothyroidism. And we know that hypothyroidism or thyroid, and we switched these patients, we started L-thorexone in this patient. And in due course of time, the lipid profile became normal. So this was a case of secondary hypothyroidism leading to secondary dyslipidemia. Hypothyroid patients can have dyslipidemia because of number of reasons. In hypothyroidism, there's a reduced activity of HMG choreoreductase, which can lead to reduced cholesterol biosynthesis. So you can get very low levels of LDL. At the same time, there's a decreased level of lipoprotein lipase activity. Once LPL activity is decreased, there's decreased clearance of triglycerides from the blood circulation, which can lead to very high level of hypertriglycerides. Such as our patient. You can see in our patients, the triglyceride was on a very higher side. This was because of decreased LPL activity. At the same time, LDL was on a very lower side because of decreased activity of the LDL receptors, LDL HMG choreoreductase enzyme. So LDL production was reduced. So you can get multiple variety of the different patterns of dyslipidemia, secondary dyslipidemia in hypothyroid patients. This was analysis done on 268 patients. They found that in hypothyroid patients, the predominant find is hypercholesteremia. You can get hypertriglyceridemia also, sometimes in normal lipid also. So lesson 3, which we have learned from this case, is hypothyroidism is the commonest cause of secondary dyslipidemia. So before starting hypolipidemic therapy, thyroid function test should always be assessed in patients who have unusual lipid profile. In fact, if you see the guidelines, the Indian thyroid guidelines, they say recommend all patients with elevated lipid levels should be screened for hypothyroidism. And screening for hypothyroidism is important in dyslipidemia in all patients with unexpected alteration in lipid profile. Moving ahead to the fourth case. This was a case of a 45-year-old female who had complaint of breathlessness, easy fatigability, vague chest discomforts, vitals was normal, echo was normal, CVP RFT was normal. He was having low voltage complexes. He was treated as coronary artery disease by some other physicians. She showed no improvement. She presented to us. We saw the ECG. She was showing bradycardia. There were low QRS complexes, especially in the limb leads, non-specific T-wave inversion. Somehow we suspected hypothyroidism. And when the thyroid profile was sorted, the mystery was solved. She was a case of severe hypothyroidism, which was causing all the symptoms of vague symptoms, restlessness, easy fatigability, chest pain, non-specific ST changes. She was treated at CAD, was given number of anti-anginal therapies. She was not improving. Once we started on L-thyroxine in this patient, she showed a dramatic improvement. There was changes. There is changes in the ECG also restored. The low voltage complex which we were seeing after a few months of therapy, the voltage became normal, and non-specific T wave inversions also reverted to normal. So mixed edema or hypothyroidism deposit within the myocardium, and because of this deposit of mixed edema, the ECG activity is not captured to the same extent. So you get low voltage complex because of the impedance. The mixed edema deposit cause a lot of impedance in the electrical activity. So you get very slow voltage complexes in the ECG. It decreases sympathetic activity. So you get bradycardia in these patients. It sluggish the contractility of the heart. The patient feels breathless and all the circulations are sluggish. So it causes reduced inotropy and chronotropy. Because of these all effects of hypothyroidism in the heart, patients perceive all these symptoms. Lesson 4 is thyroid function should always be done in patients who present with sinus bradycardia, low voltage complexes, non-specific T versions, and no obvious cause of symptoms of these patients, which is very, very common in our scenario. The case number 5, again a 55-year-old female who has some depressive symptoms, she was on antidepressive therapy. She presented to us with these complaints, and she presented to us for the management of hypertension. Once we measured her blood pressure, it was 130 by 106. So we were dealing with the case of isolated diastolic hypertension. She was started on amlodipine. His edema also worsened. Now, when she reported to us, we seeing the case of isolated diastolic hypertension, which is very, very common in patients of hypothyroidism. A thyroid profile was ordered, and TSH was more than 50 international units per ml. So BP became normal after thyroxine therapy. Amlodipine was stopped. All antihypertensive was stopped. Thyroxine hormone was given. Thyroxine hormone was replaced. It became normal thyroid profile. So with this therapy, her blood pressure became normal. Thyroid hormone can affect the blood pressure by a number of ways. In hypothyroidism particularly, because it causes increased systemic vascular resistance, you get specifically isolated diastolic hypertension, which is very common. So one of the main cause of isolated diastolic hypertension particularly is hypothyroidism, because hypothyroidism causes increased systemic vascular resistance, and diastolic hypertension particularly is main effect of increased SVR in patients of hypothyroidism. So we see in total scenario, the cardiovascular changes which we see in hypothyroidism, it can cause ECG changes in the form of low voltage complex and non-specific ST changes in bradycardia. It can cause cardiomegaly. It can cause pericardial effusion. It can cause increased diastolic pressures, increased peripheral vascular resistance. It can decrease myocardial contractility, decrease myocardial oxygen demand, and decrease cardiac output. Hypothyroidism, the lesson from the 5th case is hypothyroidism is the commonest cause of isolated diastolic hypertension. So before starting antihypertensive therapy, thyroid function test should always be assessed in such types of patients. In fact, hypothyroidism can extend coronary artery disease also. And patients with angina pectoris, if they have hypothyroidism, they have less symptoms. As they are less active, they have less peripheral oxygen demand. So their symptoms may reduce of CAD in the presence of hypothyroidism. This should also be kept in mind. Case number 6. I think this is the last case. This is a 55-year-old female who had atrial fibrillation 1 year back. She was taking amiodarone 200 milligrams twice daily, plus a diuretic and acetone for atrial fibrillation. Now, since last few months, she has developed easy fatigability, depressive symptoms. There's heaviness in her voice. Now, if patients on AF who is on amiodarone present with such symptoms, the first thing which should come in our mind is this can be in cause of drug-induced hypothyroidism. Amiodarone is notorious for causing hypothyroidism. His ECG echo TMT was normal. When thyroid profile was done, the TSH was raised and T3, T4 were reduced. So this was the case of drug-induced, amidon-induced hypothyroidism, which was responsible for all these symptoms. Amidon and thyroid functions, it's very complex. Amidon can cause thyroid dysfunction number of the ways, but the commonest abnormality of thyroid, which is seen on amidon therapy, is hypothyroidism. Majority of patients, though in some patients you may get hyperthyroidism, but in majority of patients you get hypothyroidism on amidon therapy. Lesson number 6 from the case which you have learned is thyroid function test should be done in all patients who are taking amidon for more than 3 months, because you never know that 1 out of 4 patients can develop hypothyroidism, which can cause various types of symptoms in our patients. So just to summarize, when to check thyroid functions in clinical practice: if you are seeing unexplained atrial fibrillation, unexplained congestive heart failure, unexplained pericardial effusion, isolated diastolic hypertension, patients on amidon for more than 3 months, unusual dyslipidemia, and also in critically ill patients. Always order for thyroid profile and whenever you see such category of patients. Finally, I'll end. This is my last slide, which what Professor Sussman said about 2 decades back: when the thyroid speak, the heart listens, and this is where this is true in today's scenario also. Thank you very much. Dr. Sumit.
Session is now open for discussion.
Okay.
Dr. Javed.
Sir. Thank you, Pankaj, for your excellent presentation. You have very clearly shown what kind of condition can create heart problem, and thyroid is one of them. And very clearly shown that all cases of the bradycardia, tachycardia, atrial flutter, fibrillation, all kind of arrhythmias and all kind of congestive heart failure has to be investigated for the thyroid function test. Very important lesson you have shown. A couple of things I just wanted to add. You have given the number of conditions where the thyroid function has to be tested, but I would like to add 1 or 2 more. All pregnant ladies, the thyroid function has to be tested, 1. And all senile patients, more than 60 years, 65 years, who comes to you with vague symptoms, without any significant cardiovascular abnormality, they all have to be tested, because senile changes affect thyroid function also, and some patients, senile patients, might require the thyroid supplementation. So very nice presentation. And I think I just want to know how frequently you check the thyroid function test once you start the thyroxine on the patient.
I think every 3 months it should be assessed.
Every 3 months, do you think it is sufficient, or
at least?
At least. And because sometimes the thyroid supplementation might require a titration.
Yeah.
Once you start with 25 or 50, then you think that it has to be added from something more. You have to increase the dose to 75, or you have to reduce. So 3 months time, I think, is sufficient, or less than that initially.
Ideally, every 1 month, I think is it. Ideally.
And once the patient is stabilized on the therapy, I mean, you can do once in 6 month time. I think that is what is recommendation. Very nice presentation. Anybody else who wants to ask question? I mean,
Dr. Pankaj, what is the incidence of CAD associated hypothyroidism?
Hypothyroidism as per se is not a risk factor of CAD, but these patients of CAD have hypothyroidism is very common. And what we need to see that because of hypothyroidism, their symptom may reduce, because they have consumption demand is reduced, their heart rate is reduced. Sometimes the symptoms in a CAD patient because of hypothyroidism may be reduced. We should always keep in this mind. And sometimes symptoms may overlap. Sometimes the patients of angina may not be because of angina, it's maybe because of hypothyroidism, these vague symptoms. So we need to look into both the aspects once we see hypothyroidism along with CAD.
I think the message from the last case is also very important. Drug-induced is not often a thought in our mind. So
Yes.
we have to revise the therapy every point in time,
Yeah.
so that we know whether it is a side effect of a particular drug. Very good.
Thank you.
I think
Pankaj,
one of the
Pankaj,
other.
I just want to ask Pankaj, I just want to ask one question from you. Suppose somebody has developed. Pankaj, are you with us?
Yeah.
Yeah. I just want to have one query. suppose somebody has developed the LV dysfunction because of the hypothyroidism, and you have started the thyroxine on him. What the literature says with this cardiomyopathy kind of situation or low ejection fraction reverses back?
I think the heart failure is more common in hyperthyroidism, basically. If you see, there are multiple mechanisms of heart failure because of hyperthyroidism. It may be because of high output failure. It may be because of associated hypertension. It may be because of tachycardiomyopathy. It may be because of decreased peripheral resistance. But usually we don't see in hyperthyroidism, if you correct the abnormality, the ejection fraction may become normal. It has been reported, may become normal. But it's more common in hyper than in hypo.
And I personally think that the earlier the treatment starts, the better the result outcome.
Yeah.
So early diagnosis is most important. You should have a very high index of suspicion and check the thyroid function test in relevant cases and start the treatment as it is needed, either hypo or hyperthyroid.
Yeah.
The other thing you must never forget is whenever you're making a diagnosis of statin intolerance, thyroid function must be done. Vitamin D deficiency and hypothyroidism must be screened before you label any patient as statin intolerant. That should never be forgotten. Dr. Dalal, any comments from your side?
No, I think they're right. That large number of the patients I see in my clinic, whether they're hypertensive or cardiovascular disease, have thyroid, usually hypothyroidism. In fact, it's so common that almost 50% of my patients say they are taking L-Troxin. So hypothyroid seems to be rampant in our country. And of course, always corrected, which is good. May I ask a question? At what level? Many times I see a patient who's not on thyroid treatment. What level of TSH would you start the treatment? Because sometimes it's 5, sometimes 7, sometimes 8. Somebody says start, somebody says don't start.
I think it's a very difficult question sometimes because often we see subclinical hypothyroidism also. Only TSH is raised, T3, T4 are normal. Sometimes I think I'm not sure exactly at what level we should say. It's a very difficult question. Nobody's sure.
10. Usual consensus is after 10.
10 because
it crosses 10. 5 to 10 is plus minus.
Plus minus is difficult.
Dr. Dalal, previously, I think many years we used to diagnose high output failure, which is a feature of hyperthyroidism, arm to tongue time, arm to lung time. Any test at the present state of time, suppose somebody wants to know this is high output failure, all these things, I don't know whether they become obsolete.
I think they're almost obsolete. I don't think I've seen any high output heart failure because of hyperthyroidism in a long time. So I think theoretically it is important. And of course, earlier we used to see it, but I think nowadays everybody checks their thyroid all the time. So I think it's easily picked up. In the past, it used to be missed.
Yeah.
So if there are no questions, we now pass on to the next session, which is on a very interesting topic, cardiac amyloidosis. Cardiac amyloidosis hiding in the shadows of heart failure and NPH, red flags for the cardiologist. The speaker for this session is no other person but Dr. J.J. Dalal. He has a large 40 years experience in the field of interventional cardiology. He was associated with several renowned institutions abroad, National Heart Hospital, London, Welsh National School of Medicine and University Hospital of Wales, UK, Queen's University in Kingston General Hospital, Canada, and since 1987, Dr. Dalal has helped to establish the cardiological departments and the interventional cardiology programs in leading hospitals of Mumbai, including the PD Hinduja Hospital, the Leelavati, the Wockhardt Hospital. He is presently the director of the cardiac sciences at the Koklaved Dhirubhai Ambani Hospital, Mumbai, and he has several honors to his credit. The Cardiology Society of India Prize for Distinction at DM Cardiology 1977, the Young Research Workers Award by the British Cardiac Society 1981, awarded Fellow of the Royal College of Physicians, London 2018, and Governor of India International Society of Cardiovascular Pharmacotherapy. With this, I will hand over the session to Dr. Dayasagar Rao. You are there? Or Dr. Yolika, you can initiate the session.
Yeah, thank you, Dr. Manoria. Friends, it is a great opportunity today that we are going to listen to Dr. Jamshed Dalal. He has been introduced aptly. but in Mumbai circles, he has got an affectionate name called as Jimmy. So from myxedematous deposit, now we proceed to amyloid deposit, and this is a condition much discussed in recent times. I hand over the mic to Dr. Dalal to enlighten us on cardiac amyloidosis. Dr. Dalal, please.
Thank you very much indeed. I'm going to talk today about a particular type of amyloidosis, which is the transthyretin amyloid. And the reason for which I'm going to talk about transthyretin is now we have a therapy for the transthyretin. That is what has generated the interest in diagnosing transthyretin cardiomyopathy. Now, cardiac amyloidosis in general can often be missed. We see so many patients with heart failure with preserved ejection fraction. We blame it on hypertension, diabetes, other risk factors, and comorbidities. But I think the reason is that amyloidosis is sort of nobody's baby. Every physicians look after it, hematologists look after it, cardiologists look after it. And again, it's a fragmented knowledge, misconceptions, perceived rarity, which is actually a bit true, but not that rare as we think it is. So multiple reasons why we do not usually diagnose amyloid cardiomyopathy so often. As you well know, amyloid cardiomyopathy presents as a hypertrophic heart, as you can see out here. And this is basically produced by misfolding proteins and amyloid fibrils which deposit. And two simple definitions would be the immunoglobulin light chain amyloid, which is the AL amyloid, which is usually a field taken care of by the hematologist. And the new one, not the new, but the more recently talked about the transthyretin amyloid proteins, which is called the ATTR-CM. So transthyretin cardiomyopathy is now taking importance. Now, if you look at the disease burden, it's not that rare. We know that heart failure with preserved ejection fraction is quite common in our country. In fact, half the patients with heart failure will probably be preserved and half will be with reduced. And of these heart failure with preserved ejection fractions, 25% of patients with heart failure present with preserved ejection fraction, 25 to almost 40%. And at ATTR-CM forms about 13% of this. So you can understand that we have some couple of millions of patients with heart failure with preserved ejection fraction, and even 10% of this being an ATTR-CM can produce a very large volume. The other important thing that you must remember is that survival is pretty poor once you diagnose the disease. The average survival time is just 3 to 5 years from diagnosis. So whether it's a hereditary type or a wild type, the prognosis is pretty poor. So when you talk of amyloidosis cardiac in totality, we have the light chain amyloidosis, which has all the hematological problems and usually involves a hematologist and the management of that. Then you got the other types of amyloidosis, which come with various immunoglobulin problems, etc. But today we are going to talk of the transthyretin, the ATTR, which comes as two types, the wild type and the hereditary type. So these are the two points that we need to remember. Now, what is ATTR-CM? Now, the transthyretin is a protein produced by the liver. It's composed of 4 subunits, which then dissociate and misfold. And then they misfold and then they get deposited into the heart and produce this fibril deposition in the heart, which produces hypertrophy of the heart and leads to hypertrophic amyloid cardiomyopathy. Now, usually if you look at the patient's journey, it's pretty long, and you can understand why. Cardiomyopathy, first of all, may be missed, then amyloidosis will be missed, and then within the amyloidosis to make a diagnosis of ATTR. So if you look at the amount of time, the patient begins exhibiting symptoms of heart failure, some breathlessness, passed on as many other things, then does rounds of many cardiologists, physicians, etc., and then gets narrowed down with some ECG biomarkers to, okay, this looks like a hypertrophic cardiomyopathy. Then you have to suspect the hypertrophic cardiomyopathy and then confirm it, and I'll tell you how we confirm it. I think it's important to remember that we need to have some super specialty institutes looking into this. And I'm glad to say that Kokilabhen Hospital is in the Western India, has been selected as a super specialty institute for the diagnosis and treatment of ATTR. So this has just been recently started last few weeks ago, because we have all these facilities available. Any hospital which has all these facilities should make sure that they have knowledge so that you don't miss the red flags, because you know the prognosis is very poor and you know that now treatment is available. So again, as I mentioned, ATTR is very common. Survival is very short. So keep these 2 points always in mind. Now, diagnostic algorithm, the most important thing is heightened index of suspicion. So whenever you see a patient with heart failure with preserved ejection fraction, or you see a patient who comes with an echo report of left ventricular hypertrophy, Often these patients have hypertension, and you simply pass it off and say, oh, this is hypertensive heart disease, or this is some hypertrophic cardiomyopathy. Many patients we diagnose with hypertrophic cardiomyopathy, non-obstructive, and we just leave it at that, maybe a little beta blocker or something. So I think it's important that we have a high index of suspicion thinking of amyloidosis. Then you need to rule out the AL exclusion. That means you need to refer to the hematologist for looking at the kappa lambda light chain. I'm not very familiar with this management of this part of AL, and we won't talk too much about that. This is predominantly a hematological investigation and that confirmation. Then we need to do other confirmatory tests in terms of, I'll explain about the bone scintigraphy, endomyocarditis biopsies, and MRIs. And then, of course, you come to the ATTR, which is hereditary and infamilial, or wild type, which is the one which we often see and which we need to talk about. So we need to look at some of the red flags. So patient presenting with heart failure, obviously has cardiac symptoms. You need to look at very simple things. ECG, there's a discordance between LV wall thickness and the voltage. So whenever you see an echo report of LV hypertrophy, but you don't see the LV hypertrophy on the ECG, raise a red flag. Is this an amyloid cardiomyopathy, TTR? So you also on the echo what is called as a sparkling myocardium. Of course, that itself doesn't make you diagnose an ATTR. And then again, what you have is a base to apex strain gradient, relative apical sparing of the longitudinal strain. So you not only have to look at sparkling, you have to look at the longitudinal strain, and you have to look at the difference between the apex and the base. Cardiac MRI, of course, is frequently done in our country. But again, the diagnosis of ATTR based only on MRI is not easy. And then, of course, nowadays we do NT-proBNP in many patients and troponins, and you'll find many of these patients with hypertrophic cardiomyopathy, and you find unusually high NT-proBNPs, low voltage on the ECG. Those should certainly be red markers, and you should warn your echocardiographer to look more specifically for these points. So in step one diagnostic things, of course, ECG, echo, MRI, and cardiac biomarkers are most important. Also, what happens is that often ATTR comes with non-cardiac signals. And non-cardiac signals would be neurological, ophthalmic, gastric, renal, and again, family history of cardiomyopathy. So when you see a family of cardiomyopathies, investigate them for amyloidosis and ATTR. And then, of course, you have the non-invasive approach, which is the bone scintigraphy and the test for free light chain. So whenever you have a patient you suspect this is amyloid cardiomyopathy, refer to your hematologist, rule out AL cardiomyopathy. If that is negative, then you need to do an MRI. Again, MRI, as I mentioned, is non-diagnostic. It will show hypertrophy and various things, but doesn't make a diagnosis of ATTR. But what really makes the diagnosis is the bone scintigraphy with technetium pyrophosphate. So this has now become a test of great importance in the diagnosis of ATTR. And of course, it's an easy test. I mean, any large hospital have a nuclear testing. Most patients are very aware of nuclear testing. So if you send a patient for it, because we do so many times PET scans and we do thallium tests, and so patients are quite familiar with it. It's not an invasive test. It's relatively easy, not so expensive, and safe test to do. And then, of course, you need, if necessary, to do invasive biopsies for amyloid typing, but this is not required that often to make a confirmatory diagnosis of ATTR. Then, of course, once ATTR is diagnosed, then, of course, you do various genetic testing, which again gets more complex. But I think the real basic thing is non-invasive testing, and when diagnosed or suspected, to do a bone scintigraphy. So we need to keep it simple in order to make the diagnosis. You also must remember that there are a lot of extra cardiac signs, and therefore we need to look at soft tissue infiltrations that happen. Now, bilateral carpal tunnel syndrome. So any patient with bilateral carpal tunnel syndrome should be sent to a cardiologist for investigation, because this is some of the commonest association with ATTR. Then you get neural nervous system involvement, nystagmus, and various other problems, GI problems, diarrhea, nausea, gastroenteritis, ophthalmic like dry eyes, etc., peripheral neuropathies, hepatomegaly, and occasionally renal disease. But I think the important things you need to think of is the bilateral carpal tunnel syndrome, biceps tendon rupture, and some amount of the spinal stenosis that can be seen. So these are some of the non-cardiac manifestations. So what are the warning signs? Heart failure in patients above 65, aortic stenosis. Often this ATTR is associated with aortic stenosis. Hypotension develops in a patient who was otherwise hypertensive. So hypertensive patient now gets left ventricular hypertrophy and blood pressure begins to fall instead of rising. And that is one of these signals as well. Sensory involvement, peripheral neuropathy, bilateral carpal tunnel syndrome, the commonest one, decreased QRS voltage I mentioned, pseudo QRS pattern, and occasionally even AV conduction. So all patients with AV conduction defects should have a good echocardiography to look for cardiomyopathy. I mentioned this earlier and I'm mentioning it again. Severe left ventricular hypertrophy, but low QRS voltage. Again, that's not what you expect when you have left ventricular hypertrophy. So this, according to me, would probably form the first red flag because everybody has an ECG done and most people will have an echocardiography done. So correlating these two will probably be your first marker. Of course, many of them may have left bundle branch or right bundle branch block or some degrees of AV block as well. So this sort of pattern, one first degree AV block or a bundle branch block, narrow, low voltage and LV hypertrophy, I think should be the first clue that you need to look for that. Again, you can do more extensive cardiac imaging, looking, as I said, apical sparing that you see in some of these patients. And again, you have to differentiate the dilated cardiomyopathies from the hypertrophic, which of course is not a difficult issue at all. What about cardiac MRI? Cardiac MRI is important. It gives you some clue, but unfortunately, it is not really diagnostic. So you cannot do a cardiac MRI and say, this is ATTR. You can say, yes, this is a cardiomyopathy. This is a hypertrophic cardiomyopathy. You can look at fibrosis and amount of fibrotic changes in the myocardium. You can look for pericardial effusions, but you cannot make a diagnostic confirmation of ATTR. So what really does the confirmation is the bone scintigraphy with pyrophosphate scanning. So this is grade 0. What happens in the pyrophosphate scan is that you get speckling of calcium in the fibrils. So the amyloid fibrils which get deposited in the heart have calcium speckling, and therefore it behaves like bone to some extent. And therefore what happens is that the pyrophosphate is picked up. Normally pyrophosphate is picked up by the bone. So you can see grade 0, there is no pyrophosphate uptake in the heart. Grade 1, little bit of uptake, grade 2 more. But this, as you can see, this is what you would see. Good bone uptake, but in fact, even more bone uptake in the heart compared, more pyrophosphate uptake in the heart compared even to the skeletal. So when you see grade 2 and grade 3, then of course, suspicion is very high, and especially grade 3 is almost diagnostic of. So grade 1, grade 0 is absent myocardial uptake, grade 2 is mild myocardial uptake, grade 3 is moderate uptake accompanied by attenuated bone uptake, and you compare the myocardial uptake to the rib uptake. So that's how you do the comparison between the myocardium and the ribs. And of course, strong cardiac uptake, which was myocardial uptake, is greater than the rib, and that makes a diagnostic of ATTR. Then, of course, you have to, in some patients, do a biopsy if you're not sure, and you can see that Congo rate staining for amyloid myocardial biopsy, and you can see various patterns, but of course, the accuracy is much more, but again, it's an invasive procedure, and that's why it makes it difficult to diagnose. How many patients, if you have LV hypertrophy on ECG, on echocardiography, that you'll be sending them for biopsies? But clearly, you could send them for a pyrophosphate scan, few thousand rupees, non-invasive test, an hour's test, and you have your diagnosis at hand. So the diagnosis has definitely become easy. I won't go into the hematological test because I personally don't also know too much about the AL type of cardiomyopathies. But again, you look at the serum electrophoresis pattern, urine electrophoresis pattern, and you make a hematological diagnosis of AL cardiomyopathy, AL amyloidosis cardiomyopathy. So this is another spectrum that we need to exclude before we make a diagnosis of ATTR. Many of us sat together and made some sort of a consensus diagnosis, and this was held very recently in September, and the consensus was India-specific diagnostic. So you have a patient with suspected ATTR, you have to do the hematological test, rule them out, and then you do a scintigraphy. So if your scintigraphy is 0 and your hematological tests are negative, then of course you don't think there is going to be a cardiomyopathy. On the other hand, if you have hematological tests which are, grade scintigraphy 1 to 3, if the grade is 2 to 3, then clearly your diagnosis is going to be ATTR, and you want to maybe do genetic testing of the family, etc. But at this point, certainly you want to use the drug in order to treat it. In other situations, you might want to do a histological confirmation with a biopsy. So clearly those are the options available to us in the algorithm problem. But I think the important challenges are that we have a low disease awareness, and which is the reason why we are having this meeting and lecture today. Low awareness amongst cardiologists. patient's journey is complex. As I mentioned, they may go to a neurologist, they may go to an orthopedic for carpal tunnel syndrome, and establishing the ATR probably takes a long time. Also, very low awareness of patients. Patients hardly know anything about cardiomyopathy, leave aside amyloidosis, and even more specific ATTR. Again, less attention is paid to red flags, so we need to improve our attention to red flags. Look, whenever you do an echo, please look for cardiomyopathy. If you see a cardiomyopathy, please simply don't report hypertrophic cardiomyopathy or LV hypertrophy. Look for other evidences of ATTR and amyloidosis. Again, accidentally, sometimes it's detected while doing an MRI or a biopsy, and that can happen. There are diagnostic limitations because all centers don't have MRIs and scans to do that. Low awareness about the scintigraphy and genetic testing. Especially, I think we need to emphasize scintigraphy because it is more readily available, non-invasive, safe, relatively not so expensive, and very diagnostic of the problem. Many patients will be lost during the follow-up. And again, at one point in time, we had no definitive treatment. So it was simply a question of anyway treat the patient for hypertrophy. But now that we have a treatment, I think we need to be very careful about that. So most important is that we need to have a center which looks at heart failure in all. Many of us have heart failure clinics now. Within the heart failure clinics, we need to have a rare disease clinics where we look at these rare diseases like amyloidosis. But like a heart failure clinic, it's not a job of the cardiologist. You have to involve your orthopedic surgeons, the neurologists. Hematologists are extremely important because they are the ones who do the amyloidosis investigations. Of course, the cardiologists, the nuclear cardiologists become extremely important. They need to be aware of this phenomena. Then, of course, the GI problems, because often they manifest first with GI issues. We need genetic counseling and genetic testing, of which cardiologists know so little, as we all know. And of course, the primary physician internist should be aware that when you have a hypertrophic cardiomyopathy or a hypertrophied heart, please look at hypertrophic cardiomyopathy, please look at ATTR. So this is a whole process that we need to look at from multiple factors. And I said the whole importance of generating this thing is the availability of Vitamix, which is tafamidis, which is now available with us, which can treat the patient. I'm not going to go too much into treatment, but it definitely reduces the symptoms of the patient, and it also increases the survival of the patient. But it has to be given relatively earlier in the course of the disease. Again, I would like to mention that it is not a cure. It is only improvement of survival and reduction of symptoms. So ATTR is not going to be cured by tafamidis, but it can improve the patient's symptoms and prolong the life. So thank you very much. I've sort of quickly taken you through this rather unusual, rare subject of ATTR. Thank you very much.
Dr. Yolekar. Dr. Yolekar, you are muted. Dr. Yolekar, you are muted.
The host.
Any questions?
Thank you, Dr. Dalal. Thank you for bringing an investigative approach to amyloidosis. As rightly pointed out, index of suspicion has to be high. And these days we know that too much of CHF and SGLT2 inhibitors all the time, but we need to focus. And one important finding which you tell is very important, that is ECG and the voltage, hypertrophy and the voltage, the discordance between the two is something extremely important. Now we know in internal medicine, we always talked about amyloidosis as a systemic disease. And we talk of organs other than the heart. And now that we are aware that heart also can get involved, an important cause of cardiac heart failure it can be. You have also shown that every aortic stenosis is not a case for TAVR. So I think the deep approach is extremely important, and all the investigation that you have pointed out. And particularly because one important drug is available, because erstwhile it was considered as a hopeless condition with poor prognosis. Now at least a part of it, we have therapeutic access. Any questions, please?
Dr. Dalal, what are important side effects of tafamidis and any important drug interactions if we use it?
I'm sorry, I don't know about the drug interaction. There are a few drug interactions. As far as side effects are concerned, they're very minimal side effects. So it's not very toxic drug by any chance. So it is clearly, one must also understand that the data on the drug is very limited. At least in India, I don't think it has been used so far. It's a rare condition, we know that, But I would never have looked at amyloid. We look at amyloidosis. I think all cardiologists are familiar with amyloidosis, but I never knew the concept of ATTR or transmyosin this until we started talking about it and having meetings. And having had this meeting, I had a young person about 54 years old who came and who was under my treatment for hypertrophic cardiomyopathy. And then when I discussed all these things, I told him, why don't you go and have a pyrophosphate scan done? And lo and behold, he turned out to be positive for pyrophosphate scan, and he turned out to be TTR. I would never have thought about it if I hadn't had this knowledge just because of our discussions. So I think you do pick it up. I mean, within a few weeks, I picked up my first patient and we are discussing about management of this patient. So clearly we need to have the knowledge and then we need to act on the knowledge. Again, experience of drug is zero because we have not yet started the patient on the drug.
Thank you. We stand knowledgeable with all that you have said. Thank you, Dr. Dalal.
Thank you very much.
So with this, we conclude this session and pass on to the next session. The next session is on hypertension, current concepts in the treatment of hypertension. And the speaker for this person is our near dear friend, Soumitra Ray. He is Director Invasive Cardiology at Emory Hospital, Kolkata, Professor at the Vivekananda Institute of Medical Sciences, Kolkata, Executive Committee member and ex-Vice President, CSI, stood first in order of merit in higher secondary school, MBBS and MD, pursued MRCP in UK after completing MD from Calcutta Medical College and got FRCP, trained in cardiology at the Royal London Hospital, London, published many papers, review articles, chapters in cardiology books in India and abroad, and he's on the editorial board of Indian Heart Journal, International Journal of Diabetic Dyslipidemia, and he represented CSI in international conferences and is the founder president of the Calcutta Cardiology Foundation. I'd like to hand over this session to Dr. Balbir Kalra to initiate the session, and Dr. R.K. Jha will be the co-chairpersons. Dr. Balbir Kalra, please.
Thank you so much, Professor P.C. Manoria. At the outset, I want to thank Dr. P.C. Manoria for arranging the series of updates on cardiometabolic syndromes, which has really led us to increase in the knowledge of different medical faculties and doctors. Today, we are having a very learned speaker from Calcutta who brings along with him the blessings of Mata Durga from Calcutta. And he is going to give a talk on current concepts in treatment of hypertension. So without further delay, I'll request Professor Soumitra Roy to start his brilliant talk. Dr. Soumitra Roy, please.
Thank you, Colonel Dr. Kalra. Thank you, Dr. Manoria, and all my friends and teachers over here. After the very difficult subject of Dr. Dalal, I have got a very day-to-day humdrum subject, and that makes the life more difficult because everybody's expectation is too high. And the subject is current concepts. So it is open to argument what I should include and what I should exclude. So I have tried my best to see if we can interest, my presentation can interest you. So I've got a long agenda, so I go quickly. So it's a bits and pieces. So first and foremost is threshold and target of treatment. Just two things I'll say. ESC guideline, we all know 2018 was the last time it was published. Very funnily, of the comorbidities, they have said everybody should have a blood pressure between 120 and 130, not above 30 and not below 120, which is opposed to the ACC guideline, which says there is no lower limit if the patient can tolerate. So here is a sharp contrast that ESC says do not go below 120. But for CKD patient, very surprisingly, they said the target is 130 to 140 and don't go below 130, which goes against the KDIGO and other renal guidelines. If you see the ACC guideline, contemporary guideline, they said for any kind of kidney disease, your blood pressure target should be below 130 by 80. So here is a sharp contrast which I found between ESC and ACC, because by no means chronic kidney disease is uncommon in a hypertension setup. So whether we should keep our systolic pressure 130 to 140 or 120 to 130 or even below 120, I do not know. We have to make up our mind on an individual basis. Next agenda, isolated diastolic hypertension and concept of J-curve. Now, if you see, up to 1985, all blood pressure related trials had the target of only diastolic blood pressure. Systolic blood pressure was never mentioned before 1991 SHAPE trial. And of course, all the trials started after President Roosevelt died, and all started after 1960, but 65 to 85, only diastolic pressure. If you see the JNC 1, 2, 3, up to 1984, only target is diastolic pressure. No mention about systolic pressure. Only from JNC 4, 1988, systolic came into our vision, our radar. But nowadays we know it is a 20/10 rule. If you increase by 20/10, your risk is doubled. If you reduce by 20/10, your risk is halved. And here there is no discrimination between systolic and diastolic. 20 systolic rise or fall is equivalent to 10 diastolic rise or fall as far as events are concerned. That is the present concept, but perhaps it is not true. The risk factors for high diastolic blood pressure includes younger age, family history, male predominance, diabetes, metabolic syndrome, thyroid, and kidney disease. And if you see, younger the patient, higher the chance of isolated diastolic hypertension, around 4 to 5% in the 4th decade, and what is 1% in the 7th decade. This isolated diastolic hypertension has got adverse cardiovascular event by observational study, but never proved by epidemiological studies. Actually, in the SPRINT trial, a reduction of diastolic pressure below 68 was associated with adverse cardiovascular outcome. It was never highlighted by the SPRINT trialist because by motto, they were aggressive about blood pressure reduction, but they themselves noted that below 70 diastolic causes harm. Particularly in elderly patient with isolated diastolic hypertension, if we lower pressure below 70, there could be impaired cerebral and coronary blood flow with consequent stroke or heart attack. But for diastolic hypertension, again, the first line therapy is calcium channel blocker, not RAS blocker. RAS blocker is a close second, but not like other hypertension. Next comes the fixed dose combination versus free pill combination. We know we need at least 2 to 3 antihypertensive in majority of our patients, particularly if our target is 130/80. But as you know, as the pill burden increases, the compliance sharply decreases, and as the compliance sharply decreases, the hospitalization sharply increases. So they are interrelated to each other. Number of pill, compliance, hospitalization. You cannot separate them. The ACC actually said the last guideline, 2 first-line agent of different classes, either as separate agent or in a fixed dose combination is recommended. They gave a free choice, whereas ACC says if it is 2 drug, 1 pill, if it is 3 drug, still 1 pill, triple combination in a single pill. So again, there is a sharp difference of attitude, whether you should combine the 2 or 3 pills together, or you should give a freedom to the clinician. And even today, it is a very recent study, the triple combination provides early reduction of blood pressure from baseline compared with dual therapy, particularly in stage 2 hypertension that is below 160/100. Is there any gender difference in hypertension management? Last month in ESC Barcelona, this paper was presented by De Simon, the relationship between achieved blood pressure and cardiovascular risk in women. And they studied the SPRINT subject of 9,300 and ACCORD subject of 4,700 patients. Remember, they're all of high cardiovascular risk. And if you see this graph, this is very interesting. The males survive less for the same blood pressure compared to female, both in SPRINT trial as well as in ACCORD trial. So men were at higher risk of cardiovascular event than women for the same amount of blood pressure, same level of blood pressure. And but on the other hand, there is more potent relationship between systolic blood pressure and cardiovascular risk in men than in women. No, not in the other hand, I'm sorry. It's the same trend that men are more affected by blood pressure at a lower level as well as in the systolic pressure. My next agenda is timing of antihypertensive medication. Last year in the ESC, HYGEA trial was published, and there was a huge commotion. HYGEA showed that if you give your antihypertensive in the evening rather than in the morning, you have got a significant reduction of cardiovascular event to the tune of 42% reduction of stroke. And the whole cardiology and physician community was shaken. Is it true? Our age-old practice of giving morning dose of medicine, is it bad practice? And then this thing came, the time trial published last month in Barcelona. It came from the Oxford group. It showed that signs of biological rhythm in hypertension chronotherapy, especially considering blood pressure variability and once-a-day treatment, evidence that evening dosing improves nighttime blood pressure, reduces cardiovascular event, and normalized cardiac dipping pattern. That was the HYGEA trial conclusion. Evening dosing may predispose to morning hypotension with more fall. On the other hand, there could be more fall. Cochrane database systematic review showed there was no difference in endpoint between daytime versus nighttime dosing. On this background, the time trial was done, and which showed, you see the graph, exactly superimposed morning versus evening as far as the cumulative hazard is concerned. So evening dosing did not improve risk of cardiovascular event. HYGEA is out. Evening dosing was not harmful. Our age-old concept is out. Evening dosing did not have extra benefit. Daytime and evening dosing were equally effective. So it's a democratic world. You and your patient will choose when to give the medicine. Don't listen to anybody, to any guideline. There it is primary endpoint, stroke, heart attack, cardiovascular death, all-cause mortality, hospitalization, heart failure. Nothing changes whether you give your medicines in the morning or in the evening. So that was a fantastic trial result. Everybody clapped. Evening fewer falls than morning, just a little difference, no difference in the fracture. So ultimately they concluded allocation to evening dosing of usual antihypertensive medication did not improve, but did not deteriorate any of the endpoints. Next, hypertension treatment in atrial fibrillation. Atrial fibrillation is closely related to hypertension. And if you see, about 60% patients of AF have got hypertension. And if you now reduce the threshold to 130/80 as the definition of hypertension, then 80% of AF patients are hypertensive patients. Now, there are certain facts we need to remember. Additional measurement may have to be performed in patients with unstable BP due to arrhythmia, such as AF, in whom manual auscultatory method should be used, as most automated devices have not been validated for blood pressure measurement in patients with AF. The very important thing, many times you are embarrassed by seeing error coming in your Omron machine while trying to check blood pressure in AF. So keep a manual meter, an aneroid meter in your chamber for the atrial fibrillation patient to check the blood pressure. You know that standard therapy in it slightly changes if there is AF. ACE inhibitor ARB is closely associated with beta blocker or diltiazem verapamil, or even you can start diltiazem and calcium blocker together. And you know that you have to do CHA2DS2-VASc score for AF, and hypertension is there as H. But what is this H? This H means history of hypertension or hypertension. So history of hypertension may result in vascular changes that predispose to stroke. And well-controlled blood pressure today may not be well-controlled tomorrow. So uncontrolled blood pressure, the optimal BP target is below 130 to 80. So it is not only your today's blood pressure. If there is history of blood pressure, your H is 1 point. But for Has-Bled score, the H is 1 point only if your today's blood pressure systolic is above 160. So H of Chadvask and H of Has-Bled are completely different kettle of fish. H of Chadvask is any history of hypertension, and H of Has-Bled is today's systolic pressure above 160. We must keep this in mind while treating. And stroke prevention, this is very interesting. We know if the Chadvask score is 1, there is a plus minus indication of oral anticoagulation. But if this 1 comes from hypertension, then you are supposed to give oral anticoagulation, because hypertension is much more stronger stroke producer than any other risk factor. This is very interesting. Hypertension in heart failure, this is absolutely breathtaking, just came last month. This paper from Sweden, they took about 3,700 patients of Sweden of heart failure and found that resistant hypertension present in 10% of HEP-REP patient and almost 20% in HEP-PEP patient. 10% of HEP-REP patient, and several factors were independently associated. These associations were same, whether it is HEP-REP or HEP-PEP. But you just read it and you will be surprised. Read the second line. In patient with HEP-REP and mid-range, resistant hypertension was associated with a lower risk of composite outcome than normal blood pressure with HEP-REP. Whereas they were similar in HEP-PEP, but not worse. It is lower risk or same risk. Why? Maybe, you see the last paragraph, maybe hypertension is a marker, low blood pressure may be a marker of more severe and advanced heart failure. Patients are already dying. Where will they have the blood pressure from? Or maybe the heart failure caused by hypertension is better than heart failure caused by heart attack in prognosis. So fantastic outcome, and we have to think about it. But the treatment is same for HEP-REP, ACE inhibitor, ARB, diuretic, and beta blocker comes again. And there is a myth that amlodipine cannot be given in HEP-REP. ESC says yes, unless there is fluid overload, amlodipine and felodipine can freely be used for HEP-REP patient. Ultimate current status of renal denervation, again presented last month in Barcelona, ESC. 3 years observational study of renal denervation of simplicity registry, both the flex and spiral. And you see, there is a significant durability of reduction even after 3 years in high-risk patient. In high-risk patient, it has got a role. My last agenda, precision hypertension care, presented last month again. I don't understand it, whether to try to understand it. They have changed medicine between 6 groups, each giving 8 weeks each time, and they found differential effect from RAS blockade to volume blockade to calcium channel inhibitor. And they concluded there is a potential for personalized monotherapy. If you can identify the cause, pathogenesis of hypertension, then maybe only diuretic is sufficient. Your RAS blockade is redundant. Or if it is a high PRA, then only RAS blockade is sufficient. You are giving the calcium blockade unnecessarily. So days are coming, my friends, for personalized hypertension medicine. I stop over here. Thank you.
Thank you, Dr. Sumitra Rai, for covering such a big topic in such a small time, especially the current concepts in the management of hypertension. One of the problems, Dr. Rai, which we feel in day-to-day hypertension is the renal hypertension, which is very difficult to treat on certain occasions, especially the renovascular hypertension. Could you tell us some of the important indications when you will like to send these patients for renal revascularization?
Renal revascularization is indicated only if there is a uncontrolled hypertension or resistant hypertension with standard medicine, or there is a significant blockage on bilateral renal artery or unilateral functional renal artery. These are the indications for renal revascularization by angioplasty. But renal denervation is a completely different ballgame. Renal denervation is nothing to do with renal revascularization. It is for standard resistant hypertension. Its role, as I mentioned, is again resurfacing ups and downs over last 2 decades. Sometimes they are saying it's very good. Sometimes they are saying it is more complication. Sometimes they are saying it is not durable. But now I think there is a pocket of patients who will benefit from that. But renovascular hypertension definitely should have angioplasty done if there is more than 70% of renal artery stenosis on one side. It does not matter whether the patient has got hypertension, because here you are going to revascularize to protect the renal parenchyma, renal ischemia. Whether there is hypertension, controlled, uncontrolled, that is a secondary consideration. So I think these are 2 different issues we have to tackle differently.
Dr. Jha, any comments? Dr. Jha, you are muted. Dr. Jha, you are muted.
Thank you, Professor Rai. And I am hearing since long, and he is always excellent in his lecture. And only one question from my side: if you are giving the more than 3 drugs or 3 drugs, should the diuretics should be given in morning and other 2 drugs should be given in evening, and that combination will give the better result, or it is not important either you are giving in morning or evening? It is say equally potent.
Dr. Jha, I think time has come after
Yes.
all guideline, after all evidence, after all trial, that it's between you and your patient. You have to individualize your patient. You see, you can do an ABPM, see what are the times the blood pressure is high, why the pressure is high. You talk to the patient. If the compliance permits, you individualize the patient. I now am is totally convinced that there should not be any such rule to guide when you should give your medicine and whether you give a free drug or a fixed drug. I think it's absolutely between you and your patient. It's our freedom.
Thank you, sir. Thank you. Thank you for the excellent.
Conclude this session, and the next session is on a very important topic: reversal of diabetes, myth or reality. And the speaker for this session is no other person but Dr. V. Mohan. Dr. V. Mohan is MD, FRCP, PhD, DSc, FNSC, FASC, FN, and so many other degrees he has. He is the chairman and chief of diabetology at Dr. Mohan's Diabetes Specialty Center at Chennai in South India, which is an IDP center of excellence in diabetes care. Dr. Mohan oversees a chain of 50 diabetes centers across 8 states in India and has over 56,000 registered diabetes patients in his centers. He also the president and director of the Madras Medical Research Foundation, which is Asia's largest standalone diabetes research center. And his main research interests are epidemiology of diabetes and its complications, genomics of diabetes, including monogenic diabetes and type 1 diabetes, fibrocalculus, pancreatic diabetes, and precision diabetes. And he has published over 1,500 research papers. He has a masterly approach of slowly unmasking the depth of the problem, and I'm sure you will enjoy the flash of complexity during his discourse. I'll hand over the session to Dr. Chandni and Dr. Sangram. Dr. Chandni, you can initiate the session.
For taking us through cardiometabolic update and giving us this opportunity. And as we all know, from diabetes is a chronic progressive disease, and we were believing that we need to live with it. But the huge number that is happening, we can no longer afford, especially India. So if there is anything new, is there a paradigm shift? A very important topic. We are going to hear from none other than our own dear Mohan sir. Over to you, sir.
Thank you.
Are you able to see?
No, sir, no.
No.
Yes, sir. Yes, sir. Able to see, sir.
You able to see, no?
Yes, sir.
I'll
Side
share
is
again.
visible.
Now?
Yes, sir. Visible. Yes, side is visible.
Visible, no? You're visible and I'm audible. Okay.
Yes, sir.
Right. So let me start by thanking Professor Manoria and the organizing committee of Cardiometabolic Update. This seems to be a déjà vu for me because Dr. Sangabiradar and Dr. Chandani seem to be sharing every talk I'm giving. I don't know how this coincidence is occurring. It's a great honor to be amidst such doyens in the field of diabetes, cardiology, and metabolic diseases. In the interest of time, let me move on to my presentation. So, where is this? Okay, laser pointer. Okay. So my talk is reversal of diabetes, myth or reality. And at the outset, I can tell you it's not a myth. It is definitely a reality, but it's a reality for some. It is not a reality for everyone. I wish it was a reality for everyone. Then there'll be no diabetology left. Within next 6 months, all of us can reverse everyone's diabetes, and I can become a orthopedic surgeon or some other specialty. I can start my training all over again, although my age may not permit it. But I don't think such a rosy picture we can present, although there are a lot of claims of such things being done. So I thought I'll put this in proper perspective. Now, when you talk about diabetes, we're actually talking about clinical diabetes, which means that the fasting blood sugar is about 126, 2 hours is about 200, HbA1c is about 6.5, random about 200 with symptoms, or you have signs and symptoms of diabetes, and that's clinical diabetes. The last stage is a stage of complications, where if your eyes, kidney, heart, feet are all affected, to talk of reversal at that stage, I think is stretching it a bit too much. And in fact, even to stop it at that stage is very difficult, because as you can see, the disease is going to pull you in one direction. It's like a wave, pulling you in one direction. You have to, swim against the tide, how difficult it is. So reversal of diabetes is as difficult as that. But having said that, from clinical diabetes, you can definitely go back to pre-diabetes. And once you get the pre-diabetes, you can then try to reverse back to complete normal. And I was pleasantly surprised when I was going through my papers recently and reading all my old papers, that in 1985, that is what, 37 years ago, I had already published a paper on 45 cases of remission of diabetes with my father and Dr. Ramchandran and Dr. Snehallata. When I was working with my father, we had 45 clear cases where the GTT became normal. And so this is not a new thing, although everybody's talking about it now. My father used to talk about reversal of diabetes and prevention of diabetes even in the 1960s and 70s. But the evidence for that has become stronger now. So going in the opposite direction, not from left to right, but from right to left, is what is called as reversal of diabetes. Now, definition for this, again, is very interesting, that in 1985, when we were doing our remission study, there's no HbA1c at all, leave alone a normal value for HbA1c. We are only fasting and 2 hour and OGTT and so on. But the ADA has said that remission of diabetes, they don't like the word reversal, they use the word remission. It's interestingly, in 1985 paper, I'd also use the word remission only. I had not used the word reversal even at that time. So the ADA says that remission can occur if the A1C is below 6.5 for at least 3 months without any oral anti-diabetic drugs or insulin or anything. That means you stop all drugs in somebody who had an A1C above 6.5, now it is below 6.5, then it is remission of diabetes. Now, there are lots of examples of remission of diabetes. Remission is there not only in diabetes, it's there in psoriasis, it is there in cancer, it is there in hypertension, it's there in so many fields where a remission of a disease occurs. And the reason why the word remission is used instead of reversal is that it may come back. Somebody who had cancer, my wife had cancer, and then she took all the treatment. And then for 13 years, the PET scan was negative, 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 negative. Everything that we did was negative. And then it came back after 13 years, and she didn't live more than 4 years after that. So diabetes, like cancer, can go into remission, and it can come back at any time. So that's one disclaimer which you should always keep when you talk to patients about remission. But it can occur after severe weight loss, and I'm going to talk only about this today. But it can occur after GDM. Somebody has gestational diabetes, delivers, and then it can become normal. Sometimes it may not come back at all. Of course, it often does come back, but in some people, it doesn't come back. After bariatric surgery, we all know if you do it early enough, you can get remission. Stress-induced diabetes, we all know after stress goes away. Drug-induced diabetes, we all know about the COVID situation. After steroids, how when stopped, it goes back. And I have shown, and others have shown, that after early and aggressive treatment of new onset type 2 diabetes, when the beta cell function is low and they have glucotoxicity and lipotoxicity, if you give them a short course of insulin, they seem to go into remission. And many of them, for a couple of years, 3 years after that, don't even need metformin. I've had many such cases as well. But I'm going to talk about the role of diet and the role of physical activity. Needless to say, stress reduction and early and aggressive treatment are also very important. When you talk about remission and diet, there is a controversy between two groups of people. One group says it's all about carbs and low carbohydrate diet is very important. The others say it's only a very low calorie diet. It doesn't matter what you eat, as long as you eat less, it is enough to produce remission. I think partly they are both right, but a very low calorie diet is indeed needed for example, if you just reduce the carbs and don't reduce the calories and eat as much as you want, the fat and the protein and everything else, you're not going to get remission of diabetes. There has to be a caloric restriction. The problem is that in India, we consume 65 to 70% carbohydrate. Dr. Shashank Joshi, whom I know is in the Zoom meeting today, has shown through his START study that everywhere in India, 65, 70% carbohydrate. We have shown it in India, we have shown it in cures, we've shown it everywhere, that Indians just eat too much carbs, very high carbohydrate diet, not even high. From there, you go to moderate, low, and very low. Very low is less than 10% carbohydrate, only 20 to 50 grams of carbohydrate in the whole day. I would say this is possible for a short period, 6 weeks, 8 weeks, 3 months, 4 months. You can't lifelong tell an Indian, or for anybody for that matter, not to take carbs at all for the rest of your life. Next 40 years, you'd be on zero carb and eat all the fat you want, buy as much red meat as you want, and then eat. And you'll be very healthy. I'd be very foolish to tell a cardiology-related audience that your LDL will hit the ceiling and you won't live very long because you'll get a heart attack and you'll die. So some reduction in carbohydrate is definitely needed in India. A lot of reduction in calories is also needed, and that's the way to produce remission. Now, this beautiful twin cycle hypothesis was put forward by Roy Taylor in 2013 in Diabetes Care, where he says the whole problem in diabetes is due to two things. When we're talking about type 2 diabetes, by the way, I'm not talking about type 1 diabetes. I'm not talking about other forms of fibrocalcific pancreatitis. I'm talking about only type 2 diabetes, which is 90% of all the diabetes that we see. So we know that the two defects, the first defect is insulin resistance, which is very common. And a lot of that insulin resistance is in the liver. We know that the liver is playing a very important role. And secondly, the pancreatic insulin secretion is also not very good in type 2 patients. Of course, in type 1, there's no insulin at all. Now, how does this happen? When you eat too much and have a positive calorie balance, the liver gets loaded with fat, and therefore you produce insulin resistance. And also the pancreas gets loaded with fat, and therefore the insulin secretion also goes down. So obviously, if you reduce weight and reduce it significantly and reduce your calories, the liver fat will go away and the pancreatic fat will also go away. In fact, within the first 7 days, within 1 week, the liver fat will start accumulating. I know somebody who through intense yoga had grade 3 fatty liver disease, and in a matter of 3 to 4 months, made it 0 fatty liver. He had no fat at all. And with that, his diabetes went into complete remission. So it's possible to produce dramatic results. However, the pancreatic fat will take more time. It takes about 8 weeks, okay? And you can see this, how when within the first 1 week itself, when the hepatic triglyceride is coming down, the hepatic basal production of insulin, of glucose also comes down, the HGP or the hepatic glucose production comes down, and you can see the fasting blood sugar coming down very nicely. And all this, of course, happens within the first 1 week or 2 weeks of going on an intense low-calorie diet. In the case of the pancreas, it takes a little longer. You can see that it takes 8 weeks for the pancreatic triglyceride to come down, but then the first phase insulin secretion and the arginine-induced insulin secretion also improves. Now, this is a very interesting trivia which you might like to know. The pancreas itself is such a small organ. It's like a small leaf. And within that, if you have 1 gram, just 1 gram of fat, that is enough to produce diabetes. But in Westerners, To get rid of that 1 gram of fat, you have to lose 15 kilograms in weight. And a white Caucasian has to lose 15 kilos in weight. We have shown in an earlier paper 30 years ago, and we still show it now. You don't need to lose 15 kilograms in India because we don't have that much of weight. Most Indians don't have that much of weight to lose. Even if you lose 5 kilos or 8 kilograms, that is enough to produce remission. Now, the results came from what is called as a direct trial of the diabetes remission clinical trial, which is the largest clinical trial reported so far, the best done RCT so far, around 300 people, roughly divided into about 150 in the intervention group, 150 in the control group. The intervention group were given a practical starvation diet, which means only 800 calories per day. And that too, they drank it like an Optifast drink. So 1 drink in the morning, 1 drink in the evening, and that's it. You're done. Nothing else you can take. Your water you can drink the rest of the day. Okay. And so with that kind of a near starvation diet, they were able to get results. And these results are shown here. If you just focus on the lower part of this, even with this near starvation diet with about 800 calorie diet, only some people did not even lose weight. Only 5 kilos, less than 5 kilos of weight they lost. And they were not able to get remission at all. The percentages here are the percentages who achieved remission, that is less than 6.5 without medication. So if you lose less than 5 kilos and you're a white European, you don't get a remission. I would argue that in India, even there, you will get much more remission. But if you lose more weight, 5 to 10, 10 to 15, more than 15 kg. Now look at those who lost more than 15 kg in weight. There is an 86% prevalence of remission. So when you talk about remission of diabetes and you lost 15 kilos in weight on this near starvation diet, then you can get 86%. I would like to add that 14% did not develop remission even after losing 15 kilos in weight, even after going on a near starvation diet. That's why I said it's not easy to achieve it. And look at this 86%, what happened to them after another year? Just after this, at the end of first year. By the end of the second year, what happened is 16% of those who were in remission have now got back their diabetes again. So from 100% they never achieved, 86%, from there it's now down to 70%. And I would argue, if you wait for another year, it will go down further. Now, this is in the best situation in a randomized clinical trial where people had to follow the diet, close supervision, all dietitians, educators, and doctors, everyone following them, giving them a near starvation diet. After losing 15 kg in weight, even then, people are reverting back to diabetes. Just to emphasize, and these are the best people who they have taken for the trial, not the common guard and everybody who comes to your clinic. These are the best, highly selected, mild diabetics with short duration. And even then, these are the results that you can get. Why I'm emphasizing this so much is because there are commercial organizations claim that 98%, 99% of people they're able to reverse, and everybody they can reverse. Even if they get kidney problem, they can still reverse. Even if your eyes are gone, your heart is gone, everything is gone, I can still reverse your diabetes. These are kind of claims which are being made, basically because they're not doctors and they don't know the science. Now, I have put down an A, B, C, D, E, and you can add F also to that if you want, of who with type 2 diabetes will reverse. A stands for A1C. If it's not very high, we don't know the exact cutoff, but those would say up to 8, 8.5, maybe up to 9. A1C, it's easier to reverse. If you have HbA1c of 15, it's very unlikely you will reverse. Body weight. If you are a very thin person, if you have the severe insulin deficient diabetes, SID variety, how are you going to reverse? It's going to be very difficult to reverse. The fatter you are, the easier it's to reverse. You must have some insulin secretion. C-peptide must be good, and that's a C. If your beta cells are all gone, how are you going to reverse your diabetes? Duration of diabetes has to be short. In this trial, the direct trial, they took up to 6 years. In our bariatric surgery, we found that up to 8.5 years, we were able to reverse. If it goes beyond that, beyond 10 years, even after bariatric surgery, we are not able to reverse. Even after losing 40 kilos in weight, still they have needed medicines. The doses may come down, but they still needed medicines. No remission occurred. And last is E is enthusiasm. Okay. Enthusiasm is very, very important. If you don't have a motivated person, you're not going to get, you can go to F also. Follow-up is very important. If you don't have frequent follow-up, you're not going to get. So A, B, C, D, E, F is very important if you want to achieve remission. Note, however, that the evidence that we have today, the published evidence that we have today, it may come later on, is only up to 2 years in the direct trial. So what happens after 3, 4, 5, 6 years, we don't know. In my earlier remission paper, what I found was 1 year, 1.5 years, 2 years, they were able to maintain. Then many of them went back. But there are a few who will have some kind of a stress-induced diabetes, then go into remission in the next 20 years, they may not get diabetes, even if they eat whatever they want. they don't come back. Diabetes is a very complex disease. We cannot simplify it and say you do this and you'll get that. It never happens. 2 + 2 is very rarely 4 in biology. And the most important is this re-reversal or relapse of diabetes, about which nobody talks. I've been the only person who's been talking about this. Everybody talks as if it's some kind of a panacea, but re-reversal of diabetes occurs. So what is this re-reversal or relapse of diabetes? Let me show you one case study. This is a 35-year-old man. He had 6 years duration. So you can see he's a short duration guy, somebody who follows that ABCD mantra thing. And then he was treated with tablets, insulin. He was very keen. He said, I must bring my weight down. I want to achieve remission. Very motivated guy. He lost a lot of weight, no bariatric surgery. With intense diet, he was able to achieve remission of diabetes. He stopped all his medicines. Let's see what happened to him. Now that's his weight, 123 kg. And he slowly brought it. His aim was to bring it below 100. And slowly but steadily, he brought it to less than 100. And so he brought it to 99. What happened at that time was that remission was achieved. The A1C, which was 8.4, now came to 5.4. We're not even talking about 6.5. We're talking about below 5.6. He was able to completely achieve it. No insulin, no tablets, nothing. Okay. Now, look at his fasting blood sugar. 132 became 89, and postprandial 293 became 110. Almost normal values. Okay. He had fatty liver, and he had SGOT, SGPT, which is high. The 94 of the SGPT became 20, and the 61 SGOT became 16. So you can see how the liver fat has gone. What I just showed you, you can see it in this particular case. Now, what happened to him? He now stopped all his medicine. What they first do is they'll go to social media and they'll say, I'm cured, I'm cured, I'm cured, I'm completely, he wants to announce it to the whole world. Okay. But that at that particular time, they forget about their diabetes. But we, have follow-up. 30 years we've been doing this. So we ring up to people and say, look, why don't you just come 3 months? Even if you're normal, that's fine. Just come. There's no money involved. Just come. We just see you. I want to see you. No, don't call me. I am cured. You diabetologists are bad people. You keep calling people even if they are normal. You are commercial. You are paid by pharma. You're this, you're that. All kinds of things. After 2-3 attempts, we say, okay, your fate, your karma, you don't come back. After 2-3 attempts, we give up. Okay. Why you mean when I'm cured, why you should even call me? Don't call me. Don't disturb me. After 9 months, he sheepishly came back. So we asked him, what happened to you? Now, what happened is his weight has gone from 99 to 112. Note, it has not gone back to 123. Okay. Because luckily he came in 9 months. If he had waited for 2 years, it would have been 140 when he comes back. I've seen that also. Going back, worst ever in their life also, they'll occur. Okay. Look at his HbA1c though. His highest in his life was only 8.4 before he did all this reversal. Now it's 9.6. Much worse than when he started. And remember, he's put on only half the weight. With that itself, he has become like this. Okay. Look at his blood sugar. Worst ever, 321. And postprandial 247. Worst ever in his life. Look at his SGOT, SGPT. 94 has become 152. 60 something has become 66 now. So everything that he did has gone. Okay. This time he had to again be put on tablets, again put on everything. And then this time it was a struggle to bring it down to normal. So this is an example of re-reversal or relapse of diabetes. You may say, is it one case I've seen? I can tell you at least 1,000 such cases I've seen. Okay. Every time they'll go to this fellow's diet, that fellow's diet, or every guy gives some name now. I don't want to name those diets, but every fellow would have gone to every reversal program in the country and they'll all come back with severe diabetes, uncontrolled, sometimes in very, very bad shape also, they come back. Okay. So I would like to conclude, ladies and gentlemen, by saying that we must discuss with suitable patient. Now, our fault is also there. We don't treat people. We don't tell them about remission. We don't tell them about diet. And they come not high, all right, I don't SGLT2. That is not high, add something else. That is not there. 1 minute you spend with the patient. Oh, okay, now you take DPP4. Oh, that's not okay. Now new drug has come, GLP1. You take that. Then you take this. This is what we do. We are drug dispensers. We are not treating diabetes as we should treat. Okay, that's where others are taking over the field from us. Diet is the foundation of treatment of diabetes, and it must be a diet which you can follow lifelong. Don't take it for 2 months, 3 months, zero carb diet, all these fads, keto diet, this diet, that diet, all fads. They will not work. They'll do you harm. Okay. But programs supporting people, you must encourage them and say, yes, 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 we can do it. You're a suitable candidate. Continuous dedicated teams must keep talking to these people. Despite this, because diabetes is a progressive condition, re-reversal or relapse of diabetes occurs. But these commercial organizations promise magical cures and reversal. Many of them have closed down now. The others are still continuing because they've taken huge private equity money, they have to now say that whole India will be now solved by them. I hope they do. Then I can change my specialty. I'm waiting to do that. I've done enough of diabetes. But as of now, I think this is a condition which we should try to do. And in some patients, at least, we're able to achieve remission. Even for 2 years, 3 years, I think it is worthwhile. And with that, I'll stop. And if there are any questions, I'll be happy to take. Thank you.
Yeah, thank you, sir, for your excellent thought-provoking deliberation, as usual, clarifying all the doubts. Sir, are there any genetic predictors to assess who is reversible?
Probably more studies have to be done. To do genetic studies, you need thousands and thousands of samples, as you know. When you do 100, 200, 300, it's very unlikely that you'll pick up genetic markers. But one thing that we know, both for progression as well as for regression, if you have a very strong family history, it is more difficult to reverse. Suppose your father and mother are both diabetic, your grandparents are diabetic, you got 3 genes, 4 genes already loaded in you. That will be a little bit more difficult. For example, when the TCF7L2 studies were done and the DPP4 studies, those who had the TCF7L2 certain polymorphs, certain variants, they were not able to get prevention of diabetes. They also did not respond well to sulfonylureas. So this is an area of pharmacogenomics. And I don't think in this case to do reversal, we have to go to genomics and all that. I think even if you have a family history of diabetes, the environmental factor is so strong, especially obesity and excess fat, that we can definitely try to reverse even in those. But if you have the stronger the family history, the more difficult it is to reverse.
Another thing being come up is, sir, application of artificial intelligence in reversal. Is it going to help?
It will definitely help because it can help to identify how did we pick up this A, B, C, D, E. Using our clinical judgment, we have picked up A, B, C, D, E. Artificial intelligence will be able to narrow it down still further and say that these are the people who are likely to get, and we are doing such studies. We are actually part of it, that studies to look at it. So definitely using artificial intelligence will be able to identify who are the more likely candidates who will achieve remission. For that matter, artificial intelligence can also tell you who are the people who are more likely to develop kidney disease in 5 years, 10 years, 15 years, because when you have millions of data, a human brain may not be, clinician may not be able to sit and say, oh, this is a common things you can say, HbA1c duration, 1 or 2 common things you can say. But within that, subgroup after subgroup, to identify a layer of people who will easily achieve remission or who will go into, end stage and so on, you do need the help of computers. And that's what artificial intelligence is all about.
Dr. Mohan, your comments on keto diet increasing LDL cholesterol.
100% it increases. I've seen it again and again. And I don't think it's a big, magical thing about it, because when you replace all the carbs with 80% fat, what do you think will happen to the LDL? Whenever you take 80% fat, your LDL will go sky high. I've seen coronary artery thickness increasing. I've seen IMT increasing within 6 months to 1 year after going on a keto diet. So I don't think these diets, leave alone the fact that, they work only short time and they're not sustainable, I don't think they're healthy also. A balanced diet is what we need. We just published a paper on diabetes here, and it's not on the individual level, but at the population level. If Indians reduce their carbohydrate from 60-65% to around 50% and replace it with good fat as well as protein, you can actually reverse diabetes at a population level. It's not for an individual level. Individual level is different. But at a just like you say, as cardiologists, if you reduce the systolic blood pressure by 5 millimeters in a population, 40% of strokes can be avoided. We're not talking about individual, we're talking about at a population level. So similarly, at a population level, if you can change the way people eat carbs and replace it with healthy proteins, vegetable protein particularly, and healthy fats, polyunsaturated fats and monounsaturated fats, I think we'll make a big dent, not only in preventing diabetes, but also obesity and heart disease, and maybe some forms of cancer as well.
Sir, earlier NAFLD, now it has changed to metabolically associated fatty liver disease.
Correct.
Professor Sarina used to tell diabetes is a disease of liver.
Yeah.
When we diagnosed at
I'm sure Dr. Manoria will say it's a disease of the heart. And we'll say cardiology is a part of diabetes. So I think we're all dealing with the same thing and drawing artificial boundaries. Finally, when it comes to public health, there is no diabetes, heart disease, this one. You have to do it at a population level. But at individual level, when the person is sitting in front of you, You'll have to see his risk factors, how many drugs to give. Why you were just discussing 2 drugs to give or 3 drugs to give. That is not at a population level. So one hat we wear is at a population level. What do we do for the nation? The other, when the patient is sitting in front of you, his his needs and her needs and social contact, that is personalized medicine.
I think with this, we conclude this session and pass on to the next session, which is on new diabetes care in 2020. And we have 2 experts for this session, Dr. Shashank R. Joshi, our dear friend, eminent diabetologist of national and international repute, chair IDF South East Asia, president of Indian Academy of Diabetes, former national president API, RSDDI, and AIA-RRO. Dr. Shashank R. Joshi was honored by the government of India by awarding him the Padma Shri in 2014 in recognition of his efforts to the cause of medicine. He has published more than 800 research articles in peer-reviewed journal. Our second expert is Dr. Bansi Sabu, again, our great friend, chief diabetologist and chairman of Diabetes Care and Hormone Clinic at Ahmedabad. He is president of RSSDDI 2019-20, president of AIA-RO 2016 to 2020, honorary secretary of Diabetes India and honorary secretary of Diabetes in Asia Study Group, launch a product Diabetes Free India in 2030, acknowledged by the Honorable President of India, expert of RSSDI guidelines for management of diabetes, ATTD, CGM guidelines, and ISPAD. More than 112 publications in index journals and several chapters in textbooks and monogram. And he is a fellowship of the several international organizations, FACE, FCP, FIC, and FRCP. So with this, we start this session. Now, the last couple of years has witnessed a sea change in diabetes care. Gone are the days when diabetes were merely managed by glycemic control and no impact on cardiovascular outcome. The 2 new blockbusters, SGLT2 inhibitors and GLP1 receptor agonists, are powered to improve cardiorenal outcomes. SGLT2 inhibitors, all of us know, are a panacea for heart failure. They can be used across the spectrum of heart failure. They're also a boon to CKD. They slow down the trajectory of CKD and postpone dialysis by 10 to 15 years, and they are the statins of the 21st century. GLP1 receptor agonist minimizes ASCVD coupled with good glycemic control, with minimal or no hypoglycemia, weight reduction, and are very safe. Both these agents must be utilized to minimize cardiorenal complications, which is one of the most important aims in new diabetes care. Attention should also be focused on the quality of life, weight reduction by lifestyle modification, drugs or bariatric procedure. The risk factor should be controlled. Behavior modification is also important, and physical activity should also be monitored, and suitable advice should be given. And lastly, the personalized approach should also be followed. The glycemic control has also witnessed great strides. In past, we used to assess glycemic control by FBG, postprandial blood glucose, SMBG, but now we are equipped with continuous glucose monitoring and time and range. Dr. Shashank, recently the joint EASCD and ADA has issued a statement on new diabetes care. What are the salient features of this?
So thank you, Dr. Manoria. The salient features of this new guidance is very clear cut. That as you rightfully said, 2 molecules have moved up on the pecking order, and they are strongly competing with metformin to displace them. One is if there is a high or a compelling cardiovascular risk, SGLT2 inhibitors are right up the pecking order. And second is, of course, GLP1 analogs. Both of them have gone up the pecking order. But what is novel and new, and if I'm permitted to maybe share a slide or 2 from the new guidance, there has been some extraordinary data in terms of the lifestyle modification. So I think patient is the center of the universe. I hope my slides are visible. And this is again an ADA ESD consensus. It is not a guideline, number 1. Number 2, ACE has come out with its own guideline this week. And number 3, a week from now, RSSDI will come out with its own things. So as Dr. Manoria rightfully said, the core of this guidance is not just glucose control. It is the quadrant: glucose control, cardiorenal protection, weight management, and cardiovascular risk factor management. So two places, cardiovascular risk factor and cardiorenal protection, are up the pecking order. Weight management is right there beyond glucose control. So that's the first overarching take-home point. And the second thing is the communication skills between patient and the person living with diabetes is the key. So putting the person living with diabetes at the center of decision-making process. So assess the individual, make specific recommendations, do a shared decision-making based on socioeconomic data, affordability, accessibility, agree to a management plan, implement it, provide ongoing support and monitoring, and review the management plan. That's really the edifice of this new guidance. And so it's prevention of complications, optimize quality of life, individualize. That's the key. That's what Dr. Mohan was also saying in his talk. Look at lifestyle and healthy behaviors. Look at comorbidities, heart disease, kidney disease, heart failure. Look at A1C, age and weight. Look at motivation, depression, cognition, and social determinants of health. Then individualize these goals. And look at complexity of regimens, access, cost. Then try to do a shared decision-making, dialogue with the patient, discuss with the patient. And this is the key, shared decision-making. And I think we can discuss more, but then they say have SMART plan. What is SMART plan? Specific, measurable, achievable, realistic, time limited. And then implement that time plan and overcome clinical inertia and then try to monitor and agree to a MAT plan. So that's, I'll stop sharing here, but this is the core of that. And the lifestyle component is very well written in this. They have included yoga, they have included meditation, they have said sitting is the next smoking, they have said breaking, sitting down is equally important. I can share those slides if you are interested, sir. But the whole guidance has a huge focus on lifestyle. It's not just about SGLT2 inhibitors and GLP-1 analogs. They have come up the pecking order. In the Indian scenario, we are very insulin resistant. So in the Indian scenario, we need to sensitize. And I am certain that when RSSDI guidance comes and we have the immediate past president, Dr. Sabu and Dr. Mohan and myself also have given our own inputs, it will be a little different because this is catered to a reimbursed economy. North America and Europe are reimbursed through third-party reimbursements. And these are consensus recommendations. They are not guidelines. ACE has come out with a more comprehensive report, which is a more than 360-page report on the ACE recommendations. They are recommendations from United States for clinical endocrinologists and diabetologists. And ADA-ESD is more of a consensus report. But clearly, as you rightly said, Dr. Manoria, the SGLT2 inhibitors and GLP-1 analogs are trying to displace metformin and kick it out as the first-line therapy. And the difference algorithm is what we apply. So hit hard, hit early, particularly the duration of diabetes is early. Probably you need 2 or 3 drugs to initiate diabetes therapy, but lifestyle is still the key.
Dr. Bansi Sabu, looking at the cardiorenal metabolic benefits of SGLT2 inhibitors, is it not that all patients of type 2 diabetes must be offered SGLT2 inhibitors, barring few contraindications like recurrent genital infections or acute medical illness or proneness to diabetic ketoacidosis or very low BMI or eGFR less than 20? Your comments, please. Dr. Sabu.
So first of all, thank you, Dr. Manoria, sir, for giving me an opportunity. I am really thankful to you that I am also along with Dr. Shashank for this panel discussion. As Shashank has rightly said about the ADA-ESD consensus, which was there in ADA, now again with ESD, also talked about SGLT2 and GLP-1 should be at the supreme position with the patients, particularly with the patient with the established cardiovascular disease. But as you rightly said, with the SGLT2, should it be given to everyone? I mean, with the few contraindications which we had already talked. Now, why we should give to everyone? As 2/3 of our Indian diabetic patients are dying of cardiac disease. We develop coronary artery disease in a younger population. We already developed diabetes almost 1.5 decade or 2 decades earlier than the Western population. We have more cardiovascular risk factor, which includes insulin resistance, which includes diabetic dyslipidemia, which includes higher LDL cholesterol, atherogenic LDL cholesterol. We have more number of persons with hypertension, central obesity, smoking, tobacco chewers. So all these cardiovascular risk factors and more patients of cardiovascular disease, I fully agree that it should be given the benefit of SGLT2 inhibitor to all patients who are not contraindicated to use with SGLT2. Now, with the advantage of last 1 year, when this molecule had come at a price which can be now given to all Indian patients. Otherwise, the finance was a major challenge for our Indian patients because they have to pay from their pocket. So when it was costing around 50 rupees per tablets, we were not able to give to each and everyone. But now we can give to almost like 2/3 of our diabetic patients, or almost 60-70% of the patients who are not in acute condition, not having any recurrent infection, not acute infection. They can be given the benefit of SGLT2 inhibitor. And in some of the conditions in the place where metformin is either contraindicated or it is not tolerated, where also we would like to use the SGLT2 inhibitor. But I mean, as your panel discussion is what is new in diabetes care, that was your discussion. And we had moved from the molecules like 2015 onward with the SGLT2 inhibitor, and a lot of data had come with GLP1. And in last 5 years, if you see our all diabetes meeting, it is now revolving around technology, because that is something also changed the way we were treating diabetic patients who were only on dependent on self-monitoring or on 3 monthly HbA1c. Now we move to continuous glucose monitoring. But one part in last 25 years, even with so many newer molecules and so much technology which had come, still the 2/3 of our diabetic patients are not under good control of diabetes. I mean, that's a fact which is remaining with our, we can't improve. And there, I think this education, personalized education, and educating the patients more about the diabetes management, and educating the doctors also. That is what we are doing through RSSDI, reaching out to the district coordinator across the country in a rural part of India also, trying to educate with the help of online education program and teaching them about the guidelines, trying to improve the care for diabetic patients, which is not improved actually in last 25 years. If you see from 95 to 2021, data remains almost same. So even so many new things have come, so many newer data is also available to us and with such a cost-effective medicines which are available to us, but still our patients are not achieving good tight control of diabetes. That's a real challenge for us. Thank you, sir.
Dr. Shashank, GLP-1 receptor agonists are very useful agent to minimize ASCVD. Liraglutide is available, dulaglutide is available, and oral semaglutides. So what are your comments on oral semaglutide, and do you prefer dulaglutide once weekly after semaglutide, or when do you prefer these agents, injectable ones?
So there are two words in the guidance or the recommendation: SGLT2 inhibitors with proven cardiovascular benefit and GLP-1 receptor agents with proven cardiovascular benefits. So in the GLP-1 stable, there is a GLP-1, GIP-1, tirzepatide, which has picked all of them, whether it is cardiovascular outcomes, renal outcomes, weight loss. Tirzepatide is like right up the pecking order there. So if you ask me from a hierarchical preference, that gets the top slot. As far as oral versus injectable semaglutide is concerned, it is excellent for weight loss, but the cardiovascular outcome documentation needs to be proven. As far as the dulaglutide is concerned, it has both primary and secondary cardiovascular outcome benefit, which has been documented beyond reasonable doubt. Now, injectable GLP-1 in North of America is very popular. In Europe, it is getting popular. In India, it has not got popular. 3 reasons. Number 1, India has an inertia for injectables. Number 2, India cost is a major rate limiting step for easy use of this. And number 3, oral semaglutide, which has come in, will have some challenges. But we will need to look at outcome data from the semaglutide backbone. Tirzepatide data is already available. As far as the dulaglutide is concerned, the data is already available. So they are all in the injectable space. One of the best agents with excellent data for diabetes and weight loss, approved for weight loss and diabetes and cardiovascular prevention, is liraglutide. Once a day, easy to use, can be used. But the once a week agents have become popular. There are also ongoing global trials on once a month and once a year agents in the GLP-1 backbone space. As I said, cost, affordability, access will be the major rate limiting concerns. and documentation of cardiorenal safety. Beyond that, one more point, Dr. Manoria, before I stop, is that there is also a challenge. These agents need strong pharmacovigilance. See, we have a tendency to embrace agents too quick, too fast. The gliptin as a class has worked very well in India because they were supposed to increase the GLP-1 levels physiologically. We ate more carbohydrate, that's why our A1C response was very robust compared to the Westerners where they eat less carbohydrates. Now, the pharmacological use of GLP-1 in the Indian data space needs documentation. Cardiovascular outcomes in the Indian patients needs documentation. So GLP-1s is work in progress, but in the hierarchical preference in terms of evidence-based generation and the weight loss is pretty dramatic. And they have outcomes at par with SGLT2 inhibitors. And they also have an oral agent in oral semaglutide, which is at par with an oral SGLT2 inhibitor, without the adverse events of mycotic genital infections, urinary tract infections, so on and so forth. But remember, no new drug is safe beyond reasonable doubt. That doesn't mean the old drugs are not, safe either. But the database on pharmacovigilance is better with them, while the database on these agents is less.
Both tirzepatide and semaglutide 2.4 milligram are likely to be available in the future. How will you make a choice for diversity between these agents?
It is tirzepatide as of now, when weight loss is my primary concern.
Okay. Dr. Bansi Sabu, CGM has come to stay and is very useful in our day-to-day practice of diabetes. What are your comments on once weekly basal insulin icodec, which is likely to come in India maybe after a few months or next year?
I'm part of some of the trials for this once in a week insulin for type 1 diabetes, and simultaneously we are doing continuous glucose monitoring also. And my type 1 diabetic patients, when we are comparing it with the once in a day, now the advantage of once in a week, particularly for type 1 diabetes, the number of shots you can significantly decrease. We are also looking whether it is decreasing the glycemic variability. Does it have the work completely for 7 days or not? And that type of data is getting generated. We are doing it with the continuous glucose monitoring, but it is very exciting because the patients who can be on a once in a week on a basal insulin with the, if suppose there is a oral short-acting insulin comes or an inhaled insulin comes, probably the patient is almost like a injection free. You can say that a type 1 diabetic patient on a basal bolus with a continuous glucose monitoring, still he can maintain his sugar and occasionally he can take a shots of bolus as and when the sugar increases. But there are disadvantages also, sir. The once in a week injection means if suppose the patient goes in hypoglycemia, these patients with a basal insulin when given in a higher dose and patient put in a hypoglycemia, probably these patients will require prolonged hospitalization. Instead of what we are doing, those patients who are given once in a day, the injection, the basal insulin, if they develop hypoglycemia, they may not require even the hospitalization also. So these are some of the advantages which a patients may have with the injectable once in a day. But yes, once in a week is really very, we all are looking for such type of injection, and maybe in 2 years it will be available to our patients also.
Dr. Shashank, weight reduction is one of the important management features of diabetes. The endoscopic bariatric procedures like intragastric balloons, which are now soluble, sleeve gastroplasty, nutrition, diverting therapies. How do you look upon these endoscopic bariatric procedures, which are often patient like them for weight reduction?
So these are short-term measures usually used as reverse or reserve agents. I definitely have clients or people living with morbid obesity where bariatric surgery is a standard of care. In bariatric surgery, there are 5 parts. One is what you rightfully said, the endoscopic procedures, stroke balloons, which are short-term, 6 months to 1 year, cause excellent weight loss and easy to do. And there are centers of excellence which do them. Second is, of course, what is very popular in the US is called a procedure called gastric bypass. Third is another procedure which is popular in India called sleeve gastrectomy. Fourth, another procedure called biliary pancreatic diversion, on which the original remission data has been based. You heard Dr. Mohan also saying about it. So clearly we have excellent data in morbid obesity in terms of remission of diabetes, hypertension, cardiometabolic diseases from a endoscopic stroke bariatric surgical angle. But now we have very compelling drugs. First is lifestyle, followed by drugs. Both of them give compelling results at par with some of the surgical procedures. So for me, the surgical procedures are clearly the procedures in brittle diabetes, where lifestyle and modern new medications, including newer analogs, have failed. And I would just like a sharing of slide from the new ADA guidance on the current, status of these agents, because they have given a very nice summary. And I would urge each one of you, to take this, kit forward and take it forward in terms of how to, manage weight from the ADA ESD standpoint, because they really have done a wonderful job as far as the guidance is concerned, as far as the recommendations are concerned, and as far as the various other procedures are concerned. So this is something which I feel the ADA ESD algorithm gives us, and I'm going to just quickly share in 2 minutes. Direct trial, just caloric restriction, 800 calories. You see the data, 10 kg, 2-year diabetes remission. Okay. Step 2, and tirzepatide, excellent data at par with endoscopic procedures. And this is surgical. These are surgical outcomes from Bigron et al. And very clear data again. Biliary pancreatic diversion and Roux-en-Y bypass, gastric bypass versus medical therapy. Clearly, the weight loss is superior, with the surgical procedure. So whenever weight loss is compelling, Dr. Manoria, I think the surgeons or the endoscopists have an edge over medications. But when it comes to glucose control, probably all of them are at similar time point. And this is something which we need to recognize. And this is something which is there. And this is the final guidance. And I would like you to focus on this slide, because this was exactly the question which you asked me. Individualized weight management goals, have a general and an intensive evidence-based structured management program, consider medications for weight loss and metabolic surgeons, and you will have to mix and match and look at glucose and weight with its efficacy in a dual manner. So that's really the standard of care as of the ADA ESD guidance, which was presented last week. It got published last Friday.
So with this, we end our discussion on new diabetes care. If there's any questions from the faculty, chairperson, speakers, or from the attendee, they are welcome.
I just wanted to ask, good afternoon, everyone. I wanted to ask Dr. Banshi and Dr. Shashank sir, as to what is your experience with a small rise in serum creatinine starting SGLT2 inhibitors? How many patients you find that, and how you convince the patients then that you wait and it might come down?
Should I answer, sir? Yes.
Yes.
Yeah, yes.
So, Dr. Sandeep Rai, those patients to whom you want to give SGLT2 for halting the progression of CKD, and where your indication is to prevent the renal complication. When we start these patients with the albuminuria, suppose you have started a patient with 1.4, like let us understand with the eGFR of this patient is like 55 or 60. Now there will be a slight decrease in eGFR, and that will not improve. What we are going to explain the patient, like as your progression of the disease, otherwise from 55 eGFR, you will reach 30. If I will not be giving you the medication which is going to be a renoprotective, like now the Finrenon had also come to market, and we are also giving that molecule also to the patient. So there will be some decreases there, but then progressive further decrease in eGFR will be halted. So down the line, 3 years down the line, if I will see your eGFR, if I will not be giving you renoprotective medication, probably the chances are more there that you will be having more decrease in eGFR. In compared to that, there will be initial 55 to it may become 50, but then further decrease in eGFR will be reduced. Instead of 3 eGFR, 3 ml per year, instead of it may decrease by 1 or 2. So that is what we explain the patient, and that And at the same time, definitely other parameters are to be monitored for these patients. But this does not happen who is someone who is absolutely normal. Suppose someone have a 0.9 A1C, no micro and macroalbuminuria, and you are giving the patient SGLT2 inhibitor, there is an anti-diabetic effect of this molecule will be fantastic, and there will not be any increase in creatinine level, or there won't be any decrease in EGFR patients. Yes, Dr. Shashank.
No, I agree. Reassurance, education, patience, monitoring. EGFR is the key. Calculating it appropriately is the key. Individualizing a patient care is also the key. But remember one thing, if somebody's creatinine is already baseline high and the patient has nausea, and this happens in practice, a lot of our patients have poor appetite, then don't start that patient on a GLP-1 and all. Settle the mild DKD and then come back to the agent.
Thank you, sir.
With this, we stop this session. Thank you very much, Dr. Joshi and Dr. Bansi Sabu, for your experiments. They're creating a permanent imprint on the mind of the audience. Thank you very much.
Thank you, Manoria.
With this, I will pass on for the next session to Dr. Spandan Baduri. Dr. Spandan Baduri, please.
Yes. Good afternoon, everybody. So after, am I audible?
Yes. Yes, audible, sir.
After these well-known experts' discussion on the different facets of diabetes, now it is time to shift to cardiology. And the topic today is heart failure, and that will be aptly dealt with none other than the leader of this conference, that is Dr. Prabhas Chandra Manoria, who is past national president of CSI, API, ICC, past dean of ICP and ICMU, etc. He is past chairman, Hypertension Council, Asia Pacific region, vice president, SARC Cardiac Society. He received several awards and orations like Lifetime Achievement Award during WCCPC 2008, Bharat Ratna, Honorable Sri APJ Abdul Kalam, awarded by Special Award in Cardiology by AACIO 2011 at New Orleans, USA, Master Teacher Award by ICC in 2009, and Netaji Oration, the most prestigious award of API in 2002. So the accolades are so huge. So now I am directly asking respected Dr. Manoria to start his deliberation on heart failure.
Dr. Spandan Baduri and Dr. Abhishek Singhai. So for the next 15 or 18 minutes, I'll be talking on heart failure, a 360-degree panoramic view. The last couple of years has witnessed a sea change in heart failure, both in terms of enhanced understanding and in the availability of a panoply of therapeutic options. The first big message in heart failure is that the 4 foundational drugs, which you can see on the screen, have kicked off a new era of drug revolution in HFrEF, which was never present before. And these are powered to improve the survival of patients of HFrEF. All these 4 drugs are given class 1A recommendation and are considered as GDMT for patients of HFrEF. And as you can see in this slide, all these 4 drugs provide incremental benefit on top of each other, and therefore they must be utilized in all patients of HFrEF. Just as in acute myocardial infarction, we have door to balloon or door to device time, we have 2 new dictas for heart failure patients. Door to GDMT time, which means how early you initiate the quadruple therapy. And the second dicta is door to maximum dose GDMT time, which means how early you achieve the maximum tolerated dose. And here you can see this is the initiation protocol of quadruple therapy for HFrEF. If it is feasible and possible, you must try to initiate all the 4 drugs on day 1. SGLT2 inhibitors are the most easy drugs to initiate right on the first day because they don't create problem in most of the parameters. Second thing is, you must try to get all 4 drugs in the maximum tolerated time within 1 to 4 weeks. The earlier it is, the better it is, preferably before discharge. And you can see on this green bar what are the multiple benefits if you initiate all those 4 drugs in the early phase of HFrEF. And this is very important because 1 out of 4 patients hospitalized for heart failure die or is re-hospitalized within 30 days of discharge. So early initiation of quadruple therapy is most important. And here you can see the earlier you initiate quadruple therapy, the better are the results, whether it is HF hospitalization for CV death or all-cause death. And when we look at the effect of various drugs in the quantity of ejection fraction, you can see up to ejection fraction 50, the benefits are there. As the ejection fraction rises, the beneficial effects are blunted, whether it is for ARNI, whether it is for mineralocorticoids, whether it's for beta blockers, whether it's for ARB. The reason is when the ejection fraction rises more than 50%, which means HFpEF, neurohormonal modulation does not play an active role. It is the comorbidities like obesity, OSA, which play a major role in determination of the mortality. And here you can see EMPA is different, that it continues to show benefit even when the ejection fraction is 65 or 70, unlike ARNI. So at the present state of time, SGLT2 inhibitors are the drugs for treatment of HFpEF. Suboptimal GDMT, as you can see, in Indian heart failure patient is very important and is the cause of increased all-cause mortality. So earlier you initiate the quadruple therapy, better are the results. What about HFpEF? Prior to the year 2021, HFpEF was considered to be an orphan disease. No treatment was available which could change the outcome of HFpEF. And all these trials, which you can see on the right side, failed to produce a statistically significant reduction in the primary endpoint. But 2021 came with a breaking news when Emperor Preserve trial was present, and the trial showed positive results for patients of HFpEF. So after the Emperor Preserve trial, EMPA has become the first agent to improve outcome of HFpEF, and Deliver trial, which was presented this year, DAPA has also shown positive results in HFpEF. The other big message is that after the positive Emperor Preserve, the Deliver trial, SGLT2 inhibitors can now be used across the spectrum of heart failure, irrespective of the ejection fraction. So all 4 subsets of universal definition of heart failure, you can use SGLT2 inhibitors. And this is a big feather in the cap of SGLT2 inhibitors. The other big message is there is excellent reverse remodeling by the 4 foundational drugs, to the extent that this has forced the committee members of the universal definition of heart failure to create a new subset of improved ejection fraction, which never existed before in the history of heart failure. And this is indeed, again, a revolutionary change in the treatment of heart failure. The other big message is exciting data has emerged from the PROVE-HF trial. It has transformed ICD eligible patients into ICD ineligible patients. I'll show you the data, and therefore the new message is optimize the use of ARNI before ICD implantation. Heart failure is also poised to postpone device therapy, whether it's ICD, CRT, LVAD, or even cardiac transplantation. So the treatment of heart failure has undergone revolutionary change. But all of us know heart failure, once sets in, runs a malignant progression with a very high morbidity and mortality. The 5-year mortality in past was 5 years, but it's likely to get blunted. Drug therapy, device therapy blunts this malignant progression and no doubt improves survival, but does not arrest this progression. This is because the human myocyte is not endowed with an endogenous capacity for repair. Once dead, is dead forever. Cell therapy has therefore emerged as a very exciting option, but after several years of research, we do not know is the end of the beginning or beginning of the end. But the hopes are still there, and therefore prevention of heart failure has emerged as a very important agenda and is indeed possible by early control of risk factors for heart failure. And rightly, ACC stage A heart failure is now redesignated at risk for heart failure to stage B pre-heart failure. The treatment of chronic heart failure basically revolves around drugs, devices, and transplant, and known pharmacological modalities are utilized as an adjunct, but I'll be only talking on drug therapy for chronic heart failure. This is the ESCHF guidelines, all of us are familiar with. Now, when we look at the evolution of drug therapy for heart failure, prior to 2019, all drugs which improved outcome modulated their action through neurohormonal modulation. So we have beta blocker, ACE/ARBs, and MRAs, which targeted the maladaptive neurohormonal modulation, and sacubitril/valsartan increased the activity of natriuretic peptides, which is a vasculoprotective arm. 2019 came with the breaking news when the DAPA-HF trial was presented, and it shows positive results in diabetic as well as non-diabetic HFrEF, and DAPA kicked off a new era of SGLT2 inhibitors in heart failure, which was never existed before. 2020, we have Emperor Preserve trials, similar results, and we also now have data in the HFpEF. I've already told you the Emperor Preserved and the Deliver. And now we also have data in worsening heart failure, Solis WHF, and ADHF after hemodynamic improvement impulse trial. And Dictate-HF and EMPA-HF are ongoing. Besides these pathways, we have two other newer pathways, soluble guanylate pathway, which is stimulated by vericiguat and has shown positive results in the Victoria trial, and the myosin activation, which is executed by omecamtiv mecarbil, which has also shown positive results in GALACTIC-HF trial. So at the present time, we have multiple pathways, as you can see on the screen. When we look at sacubitril/valsartan, these are the landmark trials, and all of us are familiar with. And these are the landmark trials which paved the way for approval of sacubitril/valsartan in heart failure. The Paradigm-HF trial paved the way for approval in chronic HF. Pioneer-HF paved the way for in ADHF. And the Paragon trial in HFpEF narrowly missed the primary endpoint, but showed benefit from ejection fraction 45 to 57, for which it has been approved by ACC. Now, this is the data from the PROVE-HF trial, and the evaluate shows excellent reverse remodeling, as you can see. And this is the data which I was talking about. This is the data of 1,613 patients. As you can see on the slide, all these patients' ejection fraction was less than 35. They were eligible for ICD. After 6 months, as you can see, 32% of patients' ejection fraction increased above 35 because of excellent reverse remodeling. They became ineligible for ICD. After 1 year, you can see 61% patient ejection fraction increased above 35, and these patients became ineligible for ICD implantation. And look at after 6 months, the ejection fraction may increase after 10% and maybe more after the end of 1 year. So what is the new dicta for ICD implantation? Optimize the use of RNA before ICD implantation for primary prevention of sudden cardiac death. What about SGLT2 inhibitors? As we said, they are a panacea for heart failure and a boon for CKD. You can see SGLT2 inhibitors have completed the whole circle of cardiovascular continuum. They have trials in primary prevention, they have trials in secondary prevention, they have trials in HFrEF, HFpEF, and ADHF and worsening heart failure. No single molecule in the world has shown positive outcome across the spectrum of heart failure. And they also slow down the trajectory of CKD and postpone dialysis by 10 to 15 years. We have the Credence trial in DAPA CKD and DAPA CKD and EMPA CKD. in diabetic and non-diabetic CKD. All CKD trials have shown immense benefit, and all of them were prematurely terminated. So SGLT2 inhibitors have not only completed the whole circle of cardiovascular continuum, they also have completed the cardiorenal continuum. These are the two trials in HFrEF, all of you are aware of, and the lower panel shows HFpEF. This is a comparison of DAPA-H and Emperor preserved, although this is not two-head comparison. You can see DAPA, more reduction in cardiovascular death, all-cause death and new onset diabetes, and all of them have decreased hospitalization for heart failure, improvement in the quality of life. And look at this meta-analysis. Reduction in hospitalization for heart failure is the signature effect of SGLT2 inhibitor. Wherever you put SGLT2 inhibitor, they would decrease hospitalization for. Look at this, benefit occurs very early, and decreasing hospitalization for heart failure is indeed a great achievement, because every hospitalization, every rehospitalization takes the patient closer to death. SGLT2 inhibitors, they have also data in the Impulse trial, as I've talked to, and also in the Soloist WHF, you can see a statistically significant reduction in the usual primary endpoint. This core trial somehow showed a very peculiar data. It was done in diabetic CKD. You can see a significant reduction in non-fatal MI, non-fatal stroke, which is not the usual scenario of SGLT2 inhibitors. We are not only interested in improving the cardiovascular morbidity and mortality, quality of life is very, very important for the patients, and SGLT2 inhibitors, all of them improve the quality of life. The mechanisms of SGLT2 inhibitors are multiple, and I'm not going to discuss. You can see they also provide renal benefit, they decrease interstitial edema, and they can be initiated across the cardio-renal continuum. While treating heart failure, it is very important to remember that heart failure and CKD should never be treated alone, because there's the close cross connect between heart failure and CKD. The cardiorenal continuum should be targeted as a whole, and never forget, targeting kidney disease triggers benefit for the heart failure, which was a missing link which we have recognized quite late. And this is the CKD benefits. They postpone dialysis by 10 to 15 years. And these are the 7 reasons why cardiologists must also focus on kidneys while treating heart failure. And this is the ACC AHA guidelines in the ESC 2021. If you look at heart failure reduced ejection fraction, class 1A indication. If you look at mid-range 2B indication, 2A indication by the ACC, ESC did not comment it because the Emperor Preserve trial was released after the ESC guidelines. It has the subset of mild reduced. If you look at HFpEF, ACC 2A recommendation for empagliflozin, the Emperor Preserve trial was released after ESC, that's why not mentioned, and the Deliver was released after ESC, but both these agents will be included as similar. And improved ejection fraction, again, is a class 1 recommendation. But what is important to realize is that because the benefits are same whether you treat heart failure with reduced ejection fraction or heart failure with mildly reduced ejection fraction. So this is the British Society of Echocardiography, which says ejection fraction less than 50 is reduced ejection fraction, which seems more logical rather than categorizing a separate subset of mild reduced, because the behavior is like heart failure with reduced ejection. And this is the Victoria trial with Reversible, which is a stimulator, direct stimulator of guanylate cyclase, which increase the level of cyclic GMP, which provides benefit to the myocytes and the to the vessels. And this is the Victoria trial, 5,000 patients, 2,500 patient each group, carried out in patients with worsening heart failure, a 10% statistically significant reduction driven mainly by hospitalization for heart failure. CV death was not much affected. And look at the NNT, only 24, once daily medicine, easy to titrate, safe and well titrated. Omecamtiv mecarbil is a myosin activator and has shown positive results in the GALACTIC trial, a 8% reduction in the primary endpoint driven by decreased HF events. Cardiovascular mortality was not a good. Iron therapy should never be forgotten. Iron deficiency is rampant in the Indian context and should be considered as the 5th pillar of heart failure. The influenza vaccine and pneumococcal vaccine must be advised, and they produce reduction in cardiovascular morbidity and mortality, and this is pneumococcal vaccine showing results on the all-cause mortality. So in summary, the 4 foundational drugs for HFrEF must be utilized for all patients of HFrEF, as they provide incremental benefit on top of each other. The dose to maximum dose GDMT should be achieved at the earliest, preferably before discharge, but not more than 4 weeks. The physician inertia should be minimized and patient motivated for long-term polypharmacy to improve survival. The 4 foundational drugs are poised to postpone device therapy in cardiac transplantation. Heart failure, one such and runs a malignant progression. All therapies should be escalated to target dose unless side effects preclude their escalation. And one should not think of de-escalating therapies because heart failure is never stable and always potentially dangerous. HFpEF no longer remains an orphan disease. We have EMPEROR preserved and delivered trial to treat these patients and has been recommended by the guidelines. In heart failure, the cardiorenal continuum should be targeted. Never treat heart failure alone, kidney failure alone. Targeting CKD triggers benefit for heart failure. Vericiguat is a new weapon approved for HFrEF after ARNI and SGLT2. Omecamtiv mecarbil is yet to be approved. Intravenous iron therapy should be considered as the 5th pillar of heart failure treatment, and prevention of heart failure has emerged as a very important agenda in heart failure. Indeed, is possible by early control of this factor. Thank you very much for your kind attention.
I congratulate Manoria sir for his enlightening. You have rightly stressed the benefits of SGLT2 inhibitor in heart failure management in diabetic as well as non-diabetic subjects. My question is, sir, FDA has approved 3 SGLT2 inhibitors, CANA, EMPA, and dapagliflozin. So are there any difference in terms of efficacy or side effect profile among these 3 drugs?
The 2 SGLT2 inhibitors which are commonly used are EMPA and DAPA. CANA has the limitation that is data only in CKD, not data in heart failure, either HFrEF or HFpEF. The guidelines usually do not differentiate between EMPA and DAPA for heart failure because both these agents have trials in HFpEF and HFrEF, and CKD, diabetic as non-diabetic. Although there are minor differences, but both these agents have not undergone head-to-head trials. So by and large, both agents are utilized in patients of heart failure and also CKD, diabetic as well as non-diabetic. CANA has data only in diabetic CKD.
Thank you, sir. My second question is, in a non-diabetic ADHF patient, I have started SGLT2 inhibitor along with other standard treatment. So after clinical recovery, suppose improvement in ejection fraction. So like we reduce the dose of diuretics. So is there any guidelines whether to reduce dose of SGLT2 inhibitor or stop after? You have mentioned in your slide that we have to continue beyond 42 days. But after 3 months or 6 months, is there any guidelines suggesting decrease the dose of SGLT2 inhibitor?
With current therapy for HFrEF, the reverse remodeling produces great improvement in ejection fraction to the extent that patient may be only mildly symptomatic or sometimes even asymptomatic. But one should never commit the mistake of stopping drugs. The drugs have to be continued indefinitely because if you stop, it is seen these patients may not respond in a similar fashion as they were responding, and some of them may not respond at all. The only exceptions are reversible disease like a peripartum cardiomyopathy, a myocarditis, or a Takashiobo cardiomyopathy. In these subsets also, if you are trying to stop, do not stop merely on the basis of ejection fraction, because ejection fraction can be normal, yet there can be subclinical LV dysfunction. So if you are thinking of stopping in these reversible diseases, always measure GLS. If both GLS and ejection fraction are normal, you may think, but that has also to be a very careful decision and a very slow approach. Otherwise, except these exceptions, it has to be an indefinite therapy.
Okay, thank you, sir. House is open for discussion.
Excellent masterly deliberation on this huge topic, sir. So I have to ask you, in continuum of true heart failure study, do you feel that SGLT2 inhibitors usage in HFrEF, particularly depending on the data from DAPA heart failure and Emperor reduced trial, the need for this device therapy in heart failure, severe heart failure will reduce.
See, all these drugs, they are very likely to decrease device therapy. ICD, I have already shown the data. 62% of patients who were eligible for ICD, because ejection fraction less than 35% is taken as the criteria, they become ineligible. CRT is also likely to be improved, and the device therapy is also likely to improve, because look at the ejection fraction increase, 10 to 15% there will be increase in the ejection fraction. The reversible modeling is so strong that the definition, universal definition of heart failure committee members were forced to create a new subset of improved ejection fraction. Previously, the subset was not there. So strong is the reverse cardiac remodeling process that you can even have a subset of improved rejection. And this is the reason even devices. So suppose you go for an NVET, nobody will pull Advil unless you have utilized all the 4 foundational drugs for heart failure, or nobody would put cardiac transplantation unless you have utilized all medical therapy, all these foundational drugs and other therapies also.
Dr. Manoria, in this country, most of the patients who come for private medical care, they pay from their own pocket. Insurance is almost non-existent, particularly in smaller towns. So the question in my mind is that whenever a patient with acute heart failure is admitted, the endeavor of the physicians as well as the patients is to get out of the hospital as soon as possible to contain the cost. Now, considering that fact, don't you think that in certain cases where the patient has not been very stable and had acute kidney injury or hyperkalemia to begin with, now the patient is stable. So when you start treatments like, ARNI, SGLT2 inhibitor, particularly ARNI, we should give them at least 24 hours to 48 hours to be in the hospital after starting this therapy to see that there is no recurrence of AKI or something. Or do you think it is safe enough for us to start the treatments and then just discharge the patient after a few hours or the next day? What do you think?
Whenever we are starting these 4 foundational drugs, you have to take into account 4 parameters: the blood pressure, the heart rate, the eGFR, and the potassium. Suppose a patient is admitted whose blood pressure is reasonable, say 100 or so, there's no postural fall, his eGFR is 35 or 40, his potassium is normal, his heart rate is slightly elevated. All 4 drugs can be initiated, maybe in low dose right from the first day. Otherwise, suppose his blood pressure is 90/60, he has postural hypotension, we would not like to initiate ARNI, we would like to wait, put on an SGLT2 inhibitors, which does not have any effect on the eGFR, on the blood pressure, on the potassium, and this can be executed. Similarly, you can also initiate MRAs if there is no hyperkalemia and if GFR is reasonable. So depending on the subset of patients, we try to initiate these individual drugs. Suppose we have a patient of heart failure with 80/60 BP, which we don't see uncommonly. We would not like to initiate ARNI, we would not like to initiate we would like to initiate SGLT2 inhibitors, we would like to initiate ivabradine, we would like to initiate phlebidone. And if the patient is in an acute heart failure, we put in an intra-aortic balloon pump or some other device. And only when the heart failure improves, the CKD will also improve, then you can initiate. So initiation is an individualized approach depending on the subset of patient, and you have to consider all these 4 factors before initiating. But it is SGLT2 inhibitors which can be initiated at any time in heart failure, because it doesn't affect blood pressure, doesn't affect potassium levels, doesn't affect heart rate, and potassium level may even be decreased. And eGFR, there is a slight decrease which usually comes up. So if your eGFR is less than 30 or 25 or 20, then you will be careful. But if the GFR is above 30, I think SGLT2 in the vast majority of times will not create any problems.
Thank you.
Dr. Manoria, can I raise one question? It was a great talk, sir. This is Dr. Nursing in here. Can you hear me, sir?
Yes.
Yeah. What is your comment on the dosage of diuretic combined with an acetazolamide, which had been recently published?
They can be useful. But again, diuretics only help in decongestion. they do not increase the mortality, they do not decrease morbidity or mortality. And one thing you must always remember, that if you use diuretics alone, they increase RAS stimulation, which increases morbidity and mortality. Therefore, diuretics should always be combined with RAS inhibitors. But if you continue to use diuretics in the long run, they would increase mortality.
Thank you, sir.
I think we can stop this session here and
Yes.
go on to the next session. The next session is on optimal management of diabetic dyslipidemia in Indian. The live experts consensus, and the speaker for this session is no other person, Dr. Raman Puri, who is widely known, and all of us are great fan of Dr. Raman Puri for his great work in lipidology. He's a senior interventional cardiologist at the Indraprastha Apollo Hospital, New Delhi, founder and chairman, Lipid Association of India, formerly head Department of Cardiology, Safdarjung Hospital, New Delhi, and member of the International Lipid Panel. I'll hand over this session to Dr. Piyush Jain to conduct. Dr. Piyush Jain, please.
Thank you. So Dr. Raman Puri has already been introduced very nicely, and he is going to tell us about the consensus statement published by Lipid Association of India on diabetic dyslipidemia. So let's hear him out, and then we can have a thorough discussion on this subject. Dr. Puri.
Yeah, good afternoon, everyone, and thanks, Dr. P.C. Manoria, for giving me an opportunity to present what we are going to publish shortly in Journal of Clinical Lipidology regarding the optimal management of dyslipidemia in people with diabetes. Now, if you look into the prevalence of diabetes, it has increased from 7.1 to 8.9 from between 2009 to 2019, and we expect about 125 million diabetic patients in India in 2045. And it is estimated that more than half of the patients with diabetes in India are undiagnosed, and of course, mortality is very high due to cardiovascular disease. Now, there are some unique features of Indian diabetes patients. One is that the younger age of onset, based upon ICMR in that study, it was found that type 2 diabetes among Asian Indian occurred between 25 to 34 years of age, which is 10 to 20 years earlier than Western population. And in one of the multinational studies involving 11 countries, this 24,000 subjects, it was found that Asian Indian have the highest prevalence of diabetes, number one, and the age of peak prevalence of diabetes occurred 10 years earlier as compared to Chinese and Japanese individuals. Another study from USA revealed that there was high prevalence of diabetes in South Asians, despite important observation with a lower BMI and with a high prevalence of atherogenic dyslipidemia. So this triad of diabetes with BMI, which is normal, or and with the atherogenic dyslipidemia is what is typical of South Asian, which is often described as normal elevated body fatty mass with normal body weight and BMI, with insulin resistant dyslipidemia and increased risk of type 2 diabetes. So one thing more important is the progression of pre-diabetes to diabetes is much higher in Indians. It's about 14 to 18% as compared to 2.5%, which is suggestive of more aggressive diabetes phenotype in Indians. This is a study by Ali done in 2013, and which we, tried to find out the prevalence of dyslipidemia in school-going children in the age group of 14 to 18. 2,500 school children were included in this study, and we found a very high prevalence of atherogenic dyslipidemia. Remember, this is the second decade of life in Indian population. Now, in SINDI-2 trial, it was found that newly diagnosed patients with type 2 diabetes had high prevalence of ASABD risk factor, which of course will increase or accelerate the process of atherosclerosis. Now, if you look into the 10-year risk of cardiovascular CV events in diabetes, pre-diabetes, and metabolic syndrome, we can see if we take normal fasting glucose as a reference, impaired fasting glucose has high incidence of CVD and CST, which goes further up when the patient becomes diabetic. But more interestingly, in metabolic syndrome, if you take patient with no component of metabolic syndrome as a reference, increasing number of component increases CV events. And when all 5 components are present, the hazard ratio becomes 6 to 7 times. That shows very high incidence of cardiovascular. Now, in Chennai urban population study by Dr. V. Mohan, it was found that those patients with normal glucose tolerance also had about 9% incidence of prevalence of coronary artery disease, which went up to 15% in patients with impaired glucose tolerance and 21%. That shows very high prevalence of CAD even in patients with normal glucose, and of course it goes up significantly in patients with impaired fasting glucose, or we can call it as a pre-diabetic. Now, this may be one of the reasons why the CVD mortality has gone up in India, though it is a premature coronary artery disease. Probably this early onset diabetes may be contributing to this increase in CVD mortality. Now, to sum up what I have discussed now is that there is high prevalence of diabetes in Asian Indians. It occurs at a younger age, on an average of 25 to 35 years of age. Asian phenotype features contribute to higher prevalence of pre-diabetes, metabolic syndrome, and early onset diabetes in Indians. And in a pre-diabetic state and metabolic syndrome, there is high prevalence of ASCVD risk factor along with atherogenic dyslipidemia, which are responsible for increased CV events even before diabetes manifests. Furthermore, it provides the foundation for increased CV mortality in diabetes, which is the leading cause of death. Therefore, there is a strong need for aggressive treatment of atherogenic dyslipidemia in addition to control of all modifiable ASCVD risk factor and glycemic control in Indian diabetic patients with or without ASCVD on the day it is diagnosed. This is how we differ from all other international guidelines or recommendations for treatment of lipids in patients with diabetes. Now, what is the objective of LAI recommendation? Of course, the objective is to reduce cardiovascular morbidity and mortality in Indian patients with diabetes. There are two main reasons for increased mortality. One is delay in the diagnosis of type 2 diabetes, and the second is the undertreatment of dyslipidemia. Though there are excellent recommendations from a number of international societies, but there are unique features of type 2 diabetes and cardiovascular risk in India, with that makes us, go for these recommendations which are specific for Indian population. So with this objective, we had series of webinar, about 160 webinar across pan-India from May 2020 to July 2021. And we involved about 155 experts in the field of endocrinology and cardiology, and we had an additional 2,880 physicians. Now, coming to the LAI recommendations, you can classify your patients of diabetes into diabetes without ASCVD, and if these patients do not have any target organ damage or one or no ASCVD risk factor, they are classified as high risk group with LDL cholesterol target of less than 70. And if they have target organ damage or two or more ASCVD risk factors, they are classified as very high risk group with LDL cholesterol goal of less than 50. And those patients of diabetes with ASCVD without target organ damage or no or one ASCVD risk factor is classified as category A of extreme risk group, where the goal is less than 50, but the optional goal is less than equal to 30 milligram of LDL cholesterol. Whereas in those patients with target organ damage with two or more ASCVD risk factors, they fall into category B of extreme risk group, in which the target of LDL cholesterol goal recommended is less than 30 milligram. For all practical purposes, the triglyceride in Indian population, fasting triglyceride should not be more than 100 milligram per deciliter. Now, this is our latest treatment algorithm in the management of diabetic dyslipidemia. You will see it in our published document. Now, once patient comes to you with the diagnosis of diabetes, you go for lipid profile, including ApoB and lipoprotein small a assessment. And in patients with high risk group, you start either with moderate or high intensity statin. And in patients with extreme risk group or very high risk group, start with high intensity statin plus ezetimibe and add fibrate if the fasting triglyceride is more than 500 milligram per deciliter. Remember, when the triglyceride is more than 500, you should always exclude secondary cause of hypertriglyceridemia. And if they are there, you should treat them. Now, after 4 weeks, you repeat the lipid profile. If the goals are achieved, then continue the same treatment. If the goals are not achieved, then if the LDL cholesterol is still high in moderate in high risk group, you can add a high intensity statin if the patient was initially in moderate statin group. And if he was already on high intensity statin, you can add either ezetimibe plus minus bempedoic acid. Whereas in patients with very high risk group and extreme risk group, you can patient is already on high intensity statin and ezetimibe, you can add bempedoic acid or PCSK9 depending upon how much LDL cholesterol you require. because if it is less than 20%, bempedoic acid is a choice, and if it is more than 20%, PCSK9 is a choice. Then after another 4 weeks, repeat lipid profile. If the LDL goals are met and ApoB and non-SDL goal, they are not within the targets. If we have not started fibrate initially, then add fibrate. If they were already on fibrate, add icosapent ethyl ester in a dose of 4 grams per day, especially if the triglyceride is more than 135 milligram per deciliter. And repeat lipid profile again after 4 weeks with ApoB also. And if, for example, the goals are still not achieved and patient was not on icosapent ethyl ester before, you can add. And if repeat this lipid profile after another 4 weeks. By this treatment regime, I think almost all patients will achieve LDL cholesterol target, non-SDL cholesterol, and ApoB target. But make sure all other modifiable risk factors, including diabetes control, and patient is advised aggressive lifestyle intervention. Now, the take-home message from whatever our recommendations are that you initiate statin on the day diabetes is diagnosed, decide diabetic patient ASCVD risk category, and achieve LDL cholesterol, non-SDL cholesterol, and ApoB target at earliest as recommended by LAI. Screen Indians for diabetes, pre-diabetes, another ASCVD risk factor, including lipid profile, which should also include lipoprotein A and ApoB, if possible, at age 20 or earlier if indicated. Good glycemic control in addition to lipid-lowering drug is important to achieve lipoprotein targets. Lifestyle intervention is extremely important, and one should treat all modifiable risk factors as per respective guidelines. Now, coming to the justification of recommendation, we published our first consensus statement in 2016. We classified patients of diabetes into high risk group and very high risk group, which we have already described. And also the target in high risk was LDL is less than 70 and very high risk group was less than 50. We were the first country or association in the world to recommend these lower levels of LDL cholesterol in diabetic patients. Now, if we look into the trials which have shown benefit of LDL cholesterol reduction, one is the most important trial is the CARD trial. They were primarily diabetic patients without documented ASCVD, in which just 10 milligram of atorvastatin reduced cardiovascular event by 37%, with the reduction of LDL from 118 to 82 milligram. Now, regarding justification of new risk category means extreme risk group, and another justification is for LDL cholesterol 30 milligram. For these two important, our recommendation, you should understand two important facts. The first is that at any level of achieved LDL cholesterol, diabetes associated with coronary artery disease or ASCVD increases cardiovascular event. That is number one fact. Number two, regardless of LDL cholesterol level, diabetes plus CAD have shown increase in CV event if they are associated comorbidities. So these are the two important points which we took into consideration when we came to and created extreme risk group and category and LDL cholesterol less than 30 milligram. Now coming to the first. Now, if we look into these statin trials, in lipid and care trial, those patients of CAD without diabetes on pravastatin 40 achieved LDL cholesterol 90, 98, and the LDL cholesterol the event rate was 19.4%. These patients were without diabetes, and in diabetic patients 28.7%. In TNT trial, 80 milligram of atorvastatin brought down LDL to around 77. The events without diabetes 7.8%, with diabetes 13.8%. If you look into the IMPROVE-IT trial, at achieved LDL cholesterol of 53, those patients of coronary artery disease with diabetes had more event as compared to those patients without diabetes. Then, if you look into the 48 trial, those in which the median LDL cholesterol was around 30 milligram, there was 14.4 more events as compared to those patients without diabetes, which is 11.4%. Now, coming to the second point, that CAD plus diabetes, if associated with other comorbidities, increases events further. Now, one of the most important post-hoc analysis trial of IMPROVE-IT trial is that patient with CAD residual risk is 30%. With diabetes, it goes to 40%. And if there is an associated peripheral artery disease, it goes up to 56%. And there is an interesting trial in acute MI, when PCI was done, it was seen that in patients with coronary artery disease, in-hospital outcome was 2.9%, which went up to 8.8% when there was diabetes, and which went up to 9.3% when the diabetes was associated with hypertension. That shows that associated comorbidities increases events further. Based upon all these things, we came out with an extreme risk category, which was in addition to 4 which we published in 2016. And category A is those patients of CAD with 1 or more features of high risk group, and coronary artery disease with 1 or more features of very high risk group was classified as category B. Now coming to number 30, why we choose 30 milligram for extreme risk group. If you look into the Fourier trial, the LDL cholesterol, median LDL cholesterol achieved velocumab over and above statin was 30 milligram, and there was about 15% reduction in primary endpoint and 20% reduction in secondary endpoint. Now remember, we are reducing LDL from 50 to 30, the gap of 20 milligram. If you look into the CTT meta-analysis of high intensive statin versus moderate intensive statin, there was on average 20 milligram LDL cholesterol reduction, and there was associated with significant reduction in event. So we thought that if we reduce LDL cholesterol from 50 to 30, we will achieve these benefit which was shown in CTT meta-analysis. Now, National Lipid Association also came out with a statement on prevention of ASCVD in South Asians in US. This paper was published 1 year later than our publication. And they also created an extreme risk group in which patients of diabetes and CAD, they also recommended goal of less than 30 milligram. Now, despite achieving LDL cholesterol of 30 in Fourier trials, still 14.4% of these patients had events. So this means we have to look beyond LDL cholesterol. Then we have to look at triglyceride, non-HDL, and lipoprotein small a. Remember, you have to have an aggressive lifestyle intervention, and you have to treat all modifiable risk factors when you are looking towards triglyceride and non-HDL cholesterol. Triglyceride, does reducing triglyceride reduces cardiovascular event? Answer is yes, but it has to be selected. The selection of patient is extremely important, because those patients with high triglyceride more than 204 and HDL less than 34 are benefited. There are 35% risk reduction as compared to those with TG less than 204 and HDL of 34, where there was only 6% reduction in event. Now, we had a lot of hope with pemafibrate, but it has been withdrawn because it was found that there is it was unlikely to have a primary endpoint to be met, but it is continued in patients with NAFLD and patients with non-alcoholic steatohepatitis because of encouraging result in these two subsets. Reduced trial was another trial in which it was found that there was 20% reduction in those patients who have diabetes with 1 or more risk factors, with the mean triglyceride of 216 and median LDL cholesterol of 75, and about 25% reduction in primary endpoint. So regarding triglyceride, as I said before, our aim should be to have fasting triglyceride less than 100 milligram, and of course we have to rule out all secondary cause and treat them. Lifestyle modification plays a very important role in reducing triglyceride. Non-HDL cholesterol continues to remain as our co-primary target. And regarding ApoB, we have put a lot of emphasis in 2022, expert consensus recommendations, and we have strongly recommended it in patients with diabetes and metabolic syndrome to assess ASCVD risk. And if ApoB is high, despite LDL and non-HDL cholesterol to the target, we have to reduce the residual cholesterol risk more aggressively. PCSK9 to be given only after you have given statin, high-intensity statin plus ezetimibe plus minus bempedoic acid now. And regarding type 1 diabetes, it should be treated similarly to those with type 2 diabetes when their risk factor profiles are similar. So I conclude that ASCVD is common in patients with type 2 diabetes. Not only morbidity, but also CV mortality is on the rise. Atherogenic dyslipidemia is common in patients with diabetes. Priority is to reduce LDL cholesterol with statin plus minus ezetimibe plus minus bempedoic acid, but PCSK9, the last drug to be used to achieve LDL cholesterol target. Attention needs to be paid to reducing triglyceride and non-HDL cholesterol. Fibrate may play an important role in reducing triglyceride with possible benefit in reducing CV event. Icosapent ethyl 4 grams per day has shown promising results. Never forget to emphasize therapeutic lifestyle change. Thank you very much for your kind attention.
Thank you, Dr. Puri. So I have got two comments or questions to make, One is regarding this reduction in the LDL-C to less than 30 in high risk, very high risk or extremely high risk. If you're convinced in your mind that this is a strong, evidence for that, then why are you still calling this as a consensus statement? Why don't you just say that it is a guideline now from Lipid Association of India? That is question number one. The second question is regarding the optimal management of atherogenic dyslipidemia in metabolic syndrome prior to the onset of over diabetes mellitus. Has the consensus statement made any recommendation regarding that?
Yeah, two important questions. See, we do not have our trials in India, which is of course very extremely difficult to have a successful in India. So we cannot go for a guideline. You have to be specific, trials conducted in that country to come out with a guideline. Therefore, we have an expert consensus statement, and our expert consensus statement is absolutely different from others. It is not only 15 people sitting in a room, and within span of 2 or 3 or 4 meetings, they come with the expert consensus statement. This is a universal method of doing it. We have number of meetings, many points are discussed, and we come to a consensus statement. So for India, at present, guidelines cannot be there. We can only have an expert consensus statement. There is strong, very strong, convincing evidence that LDL cholesterol 30 milligram is important for patients with extreme risk. I'm not saying strong, very strong. If you look into the European guidelines, let me see. They say for extreme risk group, LDL cholesterol less than 55. They have one evidence only, IMPROVE-IT trial. There are no other trials. Only IMPROVE-IT trial was the main trial they have taken. Then they say 40 milligram in patients with recurrent ACS. From where this number 40 has come, I don't know. I have asked the authors of these European guidelines, that where is this 40 number has come from? They have no answer to it. So if you look into 30, I can speak on 30 for about 1 hour. But point is this, there are not only one, you have a large 4-year trial of 28,000 patients of ASCVD, which have shown now. Now you forget about the 4 years. Now we have 8 years, study of 4 years. There also the mean LDL cholesterol is around 29 milligrams. 8 years documented further reduction in, not only reduction in events, reduction in mortality has been documented now. So therefore, I think there is a very strong convincing evidence that not all patients, extreme risk of patients. Now tell me, a patient of coronary artery disease, according to European guidelines, whether you diagnose it clinically or by imaging technique, to bring down LDL cholesterol to less than 55. This is what European guidelines says, and I think all of us are very confident when we use word 55. But tell me, how will the patient of coronary artery disease with diabetes, who is a smoker, who has a peripheral artery disease, who has a cerebrovascular disease, will have the same events? Answer is no. He will have much more events. Now, event reduction depends upon residual cholesterol risk also. How much is the risk cholesterol you can reduce it further. So there is no doubt about that lowering LDL cholesterol to 30 milligram is useful. So I am very sure about. Now regarding metabolic syndrome, what we have said now here is that before the patient becomes diabetic, he has already has a high risk of CV events, which I have shown in 10 years, 29% CVD events in 10 years in patients with only impaired glucose tolerance, which goes to, and if you look into CHD, it's 42% higher even. So with, and the LAI own study of school-going children, high prevalence of, atherogenic dyslipidemia in 14 to 18 years students, and BMI, remember, only 6% of the children had a BMI more than 25. So taking into all this condition, premature coronary artery disease, even patients with impaired fasting glucose and metabolic syndrome has to be treated for the dyslipidemia. And this will be definitely a part of our recommendation. Just wait for 1 to 2 months time. It will be published in Journal of Clinical Epidemiology.
Thank you. Dr. Malhotra, Ashish.
Yeah, I would like to ask, is there any role of the Indian drug like saroglitazar for severe hypertriglyceridemia and diabetes? Is there any recommendation from lipid association?
See, saroglitazar does reduce triglyceride by 45 to 50%, but there are no cardiovascular outcome data. So we definitely, without that, LAI will definitely not approve it for as one of the recommended drugs for our own in our recommendations now.
Dr. Raman, the physicians often ask what is the difference between diabetic dyslipidemia and non-diabetic dyslipidemia. So will you express your viewpoint on this? Commonly asked.
They are absolutely right in asking this question, and answer is when I am talking about school-going children, it also has the same, because if you look into school-going children, only 12% had elevated LDL cholesterol, which is the same thing which we normally call for atherogenic dyslipidemia, and diabetic dyslipidemia. Only thing which we can say is that more of patients, like for example, one study shows that 85% of diabetic male have this type of triad abnormality and 96% of female have this. Since there is a high prevalence of this type of dyslipidemia in diabetic patients, therefore we call it as a diabetic dyslipidemia.
What about type 1 diabetes in adolescents and children?
Piyush, we have said that if the risk factors profile is same, then it should be treated in the same way as we treat type 2 diabetes. And regarding initiating treatment in the initial stage of type 1 diabetes, where the European guidelines says that if it is less than 10 years or 20 years, it should not be, LDL cholesterol goal of 100 milligram is, accepted. Of course, we do not agree with it. And therefore, they are all Indian and they are all prone to have this atherogenic dyslipidemia. I think initiating treatment and coming to the target, what we have recommended for type 2 diabetes should also be applicable to type 1 diabetes.
I think with this, we finish this session. We are running late. So the next session is again on lipidology, assessment of atherogenic risk. Which is a better parameter, LDL cholesterol, non-HDL cholesterol, or ApoB? And the speaker for this session is our dear and near friend, Dr. Narasimhan. Dr. Narasimhan is the Managing Director of SSN Diagnostic Center and SSN Specialty Clinic, Chennai. He is Vice Chairman, Lipid Association of India, National President, Indian Society of Hypertension, 70,000 publications in prestigious medical journals, contributed chapters for textbooks of medicine, delivered 550 guest lectures at national level conferences and 58 international meetings, and Lifetime Achievement Award by the Tamil Nadu Dr. MGR Medical University, Master Teacher Award by the Indian College of Physicians. I'll hand over the session to Dr. Alraj to conduct the proceedings, and Dr. Sandeep Rai is the other chairperson for this session. Dr. Alraj, please.
Thank you, Dr. Manoria, for continuing this cardiometabolic medicine. You are a great inspiration for people like me who are pushing cardiodiabetology medicine, now cardiometabolic medicine. I'm so happy that you could do a one-day program, and the topics and faculty chosen are excellent, top on line. They'll definitely educate the participants. Now coming to today's topic, we just now listened to Dr. Raman Puri, who is one of the experts in lipidology, not only in India, but globally through the LAI. And he made things very clear. What is the need to consider the lipid levels and where it has to be reduced, what extent. Now, welcome to Dr. S. N. Narasimhan. He is another expert in the field of lipidology. Over 15 years, we are utilizing his knowledge. And today, he has accepted for an excellent topic. That is the assessment of the atherogenic risk based on the levels of lipids, LDL or non-HDL, or ApoB. It's a very great task because all of us know we are anxious about diabetes because of the vascular complications. And the vascular complications, lipid levels contribute a lot. Though there were this side or that side earlier discussion, now it has been very much confirmed that lipids, especially the LDL group, contribute for it. Hello. That leads to the atheromatous plaque, which ruptures and gives rise to vascular event. The vascular event is same, depending on the place or depending on the system which is affected. It can be a stroke when the lesion is there in the brain. It can be a myocardial infarction when the lesion is in, the coronary artery. It can be a peripheral arterial disease when it is in the peripheral vessels, or it can be a renal. Now we have as I said earlier, we have an excellent, explicit, faculty to address this issue. Sure, we will know, how to assess the atherogenic risk based on the lipid level. What is the level that has to be? How to keep it? How to evaluate? What are the benefits? Over to Dr. Narasimhan.
Can you see my slides, sir?
Yes, sir.
Yes, we are able to see.
Am I audible, sir?
Yes.
Good afternoon, everyone. Thank you very much, sir, Dr. P.C. Manoria and Professor Arulraj for the nice introduction and the and the praising words that were showered by both of you. Let me try to talk to you about the assessment of atherosclerotic cardiovascular risk, whether it is non-HDL cholesterol, LDL cholesterol, ApoB, which is a better parameter. Let me try to dwell into this particular aspect of this talk by starting with the burden of atherosclerotic cardiovascular disease globally. Cardiovascular disease claims more lives than each every year than any other non-communicable disease globally. 31% of all deaths occur due to cardiovascular disease. Cardiovascular disease is also leading cause of premature death. And in fact, no, 1933, there was a journal called Arteriosclerosis in which about atherosclerosis, there was a mention. In the absence of hypercholesterolemia, particularly raised LDL cholesterol or remnant particles, it's virtually impossible to cause atherosclerosis in an experimental animal. We know that the role played by LDL cholesterol, there is a Mendelian randomization studies, observational studies, epidemiological data, experimental studies. But the most important evidence comes from the familial hypercholesterolemia, where the role of LDL cholesterol is emphasized. Again, it's re-emphasized by the randomized control trials which were conducted by using the statin group of drugs. The more the reduction that were witnessed, both in primary and secondary prevention trials, the reduction was also seen in cardiovascular morbidity as well as mortality. Hence, our focus should always be on LDL cholesterol and lowering it throughout our life. Let me try to tell you something about the LDL cholesterol, whether we can continue to consider this as a primary target. Higher levels of exposure to the LDL cholesterol, lifelong exposure. For example, somebody has 80 milligrams of LDL cholesterol and continues throughout his life. The average age for a myocardial infarction is 100 years, with a long exposure to 80 milligrams. If a person gets about 125 milligrams, a lifetime exposure of this 125 milligram probably will bring down the occurrence of myocardial infarction to 64 years. If somebody has 200 milligrams, for example, familial hypercholesterolemia, such patients are likely to get myocardial infarction below the age of 40 years. That is the magnitude of the problem of the burden of the disease. Primary prevention trials, secondary prevention trials have gone to prove beyond doubt that the more the reduction of LDL cholesterol witnessed in these trials had produced a lot of reduction in the cardiovascular events as well as the mortality benefit. If you reduce the LDL cholesterol to the extent of 50 milligrams, you can expect that the CV events can get reduced by more than half. We have enough proof from the cholesterol treatment trials collaborations where they have analyzed the data. There are 3 meta-analyses which I have indicated here. The top one is about 26 randomized trials. 170,000 patients were actually recruited for these studies. You can just see the about 22% risk reduction and 10% reduction in all-cause mortality. The second meta-analysis is about 49 trials. Nearly 312,000 patients were recruited for this study, 23% relative risk reduction. The last trial is a meta-analysis of 52 trials, which indicated the different therapies, maybe the statin plus or minus ezetimibe and the PCSK9 inhibitor, again, going to show that about 19% relative risk reduction. So we have enough proof that reducing the LDL cholesterol can get the maximum benefit of reduction, not only the morbidity, but also mortality. Now let us look at the assessment of atherosclerotic cardiovascular risk. All guidelines on the prevention of cardiovascular disease recommend assessment of total cardiovascular risk. 1, the systemic coronary risk estimation. Actually, it is a gold standard practiced in Europe. The US actually practices the pooled cohort equations, but we need to remember that there are limitations by using this formula. Over or underestimation of the risk in certain populations, including Asian Indians. So, Lipid Association of India came up with the recommendation in 2016 and again updated in 2020. This was already shown by Dr. Manpuri. I would like to tell you that a very simplified algorithm was published in 2016 and updated in 2020, which includes the risk factors, other high-risk features, moderate risk, non-conventional risk factors. Based on this, you can categorize your patient as low risk, moderate risk, high risk, and very high risk. In case the patient comes into the low risk, you need to concentrate about this lifetime risk by going through this ABS3 score. When the risk is less than 30%, probably comes into the low risk. If it is more than 30%, it comes into the moderate risk. Now we have introduced yet another group called extreme risk, for which Dr. Ramanpuri was repeatedly telling you that how we had arrived at this category A, category B recommendation, how useful it is to bring down the levels of LDL cholesterol to less than 30 milligrams for category B of extreme risk group. Let me now try to take you to the level of our understanding on non-HDL cholesterol. All hypertriglyceridemic states, you have one, elevated levels of non-HDL, two, small LDL cholesterol particles, and high LDL particle concentration. The non-HDL cholesterol out of this is a greater predictor of cardiovascular risk than LDL-C. Let us look at the evidence. Way back 2001, when the NCP ATP3 guidelines got published, in fact, the recommendation was that non-HDL cholesterol should be considered a secondary goal for hypertriglyceridemic individuals when the triglyceride levels were more than 200 milligrams. I think this is the best diagram which probably can depict the values of non-HDL cholesterol. Very simple to calculate. Total cholesterol minus HDL cholesterol, you get the figure, and that is a non-HDL cholesterol. So you have the lipoproteins, you remove the HDL cholesterol, which is anti-atherogenic. The rest of all are considered all atherogenic lipoproteins, and they come under one label, that is non-HDL cholesterol, which includes 1 LDL, 2 IDL, 3 VLDL, VLA remnants, chylomicron remnants, and ApoB. We need to remember LDL cholesterol contains ApoB 100, IDL contains ApoB 100, VLDL contains ApoB 100, except the chylomicron remnant, which contains ApoB 48. Now, having seen this, I think I should also introduce this terminology called remnant cholesterol. So you removed the HDL cholesterol, we have actually arrived at non-HDL cholesterol. Now you remove the LDL as well as the lipoprotein little, which also contains LDL-like particle. Rest of the things which are remaining, like IDL, VLDL, and chylomicron remnants, are all called as a remnant cholesterol. How to arrive at this figure? Remnant cholesterol means total cholesterol minus HDL cholesterol minus LDL cholesterol is the correct figure, which probably can be implemented in clinical practice. If you look at the data that is available, focusing attention on the value of non-HDL cholesterol, the lipid research clinic, it has come out with the data that 4,462 middle-aged individuals who are free from associated cardiovascular disease, they were all followed up for a period of 19 years. Amazing to see that the non-HDL cholesterol was predicted of ASCVD outcomes compared to non-LDL cholesterol. In fact, the analysis have clearly shown if there is a 30 milligram dissolution increase in non-HDL cholesterol, that resulted in 19% increase in mortality in men and 11% increase in women. Whereas if you have an increase the same percentage in LDL, you get only 15% and 8% respectively for men and women. This is again an excellent projection where you can just see within the levels of LDL cholesterol, for example, 130 to 160, you have an increase in the non-HDL cholesterol from 160 to 190. The cardiovascular risk is very high. Whereas within the non-HDL cholesterol, whatever is the degree of increase in the LDL cholesterol is not increase in the cardiovascular risk. This happens irrespective of the matter whether the patient has got a triglyceride level of less than 200 or more than 200. This is yet another data. Is again a patient meta-analysis, 68 prospective studies, huge data, 302,000 patients without any cardiovascular disease. Again, non-HDL cholesterol was a single best predictor of future cardiovascular risk for coronary artery disease. In fact, one standard deviation increased 1.38 for LDL cholesterol, 1.42 for non-HDL cholesterol. The most important study actually come from the JAMA publication in the year 2012. One standard deviation in LDL cholesterol, the risk of cardiovascular events increased by 13%. One standard deviation ApoB, the risk of cardiovascular events increased by 14%. The same one standard deviation increase non-HDL cholesterol, the risk of events increased by 16% as per the meta-analysis, which involved nearly 62,000 patients, taking into consideration 6 important landmark trials in the field of lipidology, including the Jupiter trial. So the strength of association with the cardiovascular disease is greater for non-HDL than for LDL cholesterol and ApoB. Same study has given yet another information. The information that we can probably get it from this projection is that people who had reduced the LDL cholesterol to less than 100 milligram, but still their non-HDL cholesterol is more than 130, the risk of getting subsequent events in statin-treated patients is about 32%, compared to people in whom the non-HDL cholesterol was brought down to the levels less than 130, till the LDL cholesterol is high, it is only 2%. So you can probably assess the importance of estimation of the calculation of the non-HDL cholesterol to predict the future cardiovascular events in people who had received statin, even if the LDL cholesterol is under control. In the next year, I think that the American Journal of Cardiology had published yet another meta-analysis, which included 25 trials involving 131,000 patients on lipid-lowering therapy. The non-HDL cholesterol outperforms the ApoB for prediction of cardiovascular disease. This is the most important message that I thought I should share it with you. Keeping the reference value of 175 LDL cholesterol and 200 non-HDL cholesterol, which is seen on the right extreme, where the reference value is 1. When the LDL cholesterol was coming down, the hazard ratio is also coming down. But whereas the hazard ratio for the non-HDL cholesterol, every level of reduction of LDL cholesterol, the hazard ratio, you can just see hazard ratio for non-HDL cholesterol treated, statin-treated patients definitely higher at each and every level. Yet another information, people in whom you have 220 milligrams and above of non-HDL cholesterol, both men and women, have a higher cumulative incidence of coronary artery disease. We also have shown that the people with the diabetes also have an increase in the non-HDL cholesterol. We had published this data in Indian Heart Journal from the Professor M. Viswanathan Diabetes Research Center. Let me now try to look at the guideline. What is their information about non-HDL cholesterol can be used to define the primary hypercholesterolemia. This is ACC-AHA guidelines 190 to 219. It is considered as a risk-enhancing factor. One important message that these people have shared with us is that may facilitate the decisions regarding initiation of PCSK9 inhibitor, and the non-HDL cholesterol is more than 100 milligrams in those with established atherosclerotic cardiovascular disease. Look at information from EAS and ESC guidelines 2019. Non-HDL cholesterol should be considered as a secondary target in combined hyperlipidemia, 2, diabetes, 3, metabolic syndrome, 4, this CKD. So what is a recommendation by Lipid Association of India? Non-HDL cholesterol includes all atherogenic lipoproteins or accurate predictor of of elevated triglycerides like diabetes, obese persons, metabolic syndrome, those already on statin therapy. Non-HDL cholesterol needs to be considered as a co-primary target. Still, the LDL cholesterol is the primary target. Monitoring non-HDL cholesterol will provide a very simple practical tool for treatment decisions. It does not require a fasting blood sample. It takes care of both LDL and TG targets. Non-HDL cholesterol level should be about 30 milligrams more than that of the LDL goal, what you want for your patient. Statins remain the first line of agent to treat even non-HDL. Adding ezetimibe can be considered. Icosapent is the ester using 4 grams per day probably reduces the ASC risk in those people with the non-HDL cholesterol elevation. Let me now try to take you to the level of understanding about ApoB. ApoB represents the concentration of atherogenic particles in the plasma, whereas non-HDLC represents the concentration of cholesterol trafficked by atherogenic lipoproteins in the plasma. There are 2 major isoforms, which I had already indicated in the diagram. ApoB48 is a chylomicron, and the remnants. ApoB100 is present in LDL, IDL, LDL, and lipoprotein little a. Each of these atherogenic particles harbors a single copy of ApoB. The ApoB represents, ladies and gentlemen, it is a better proxy of total atherogenic lipoprotein particle concentration and the lipid fractions measured in standard lipid profile. When you talk about non-HDL and ApoB together, highly correlated, both perform better than LDL when assessing the risk. Some studies favor ApoB considered as a superior biomarker for ASC risk compared with LDL or non-HDL. But we need to remember there are other studies also which report similar risk prediction compared with non-HDL cholesterol. NLA says it should be assessed for people who are in the intermediate risk, strong families to premature coronary artery disease, recurrent atherosclerotic cardiovascular events. 2018 ACC tells you that whenever the triglyceride goes above 200 milligrams, NCP, ATP told us to talk about the non-HDL cholesterol when the triglyceride levels are going beyond 200. But whereas 2018 ACC tells you that you should probably concentrate on ApoB. I recommend that ApoB more than 110 milligrams should be considered as a moderate risk, non-conventional risk factor. This is the most important slide which I thought I should probably share it with you. To talk about risk of getting subclinical atherosclerosis based on the concordant and the discordant values. On to the left, you can just see the low ApoB, low LDL cholesterol, low non-HDL cholesterol. This is called concordant lowest risk. Go to the right extreme, high ApoB, high LDL, high non-HDL, that is concordant highest risk. In between, you have two, low ApoB, high LDL-C, high non-HDL-C, discordant low risk. Whereas people in whom you have high ApoB, low LDL, low non-HDL, that means it's a discordant high risk. Studies have shown clearly that the discordant group in those patients in whom the ApoB levels are high when compared to LDL or non-HDL probably is responsible for subclinical atherosclerosis. This is an excellent data which got published in American College of Theology, again stressing the importance of discordant ApoB levels in those individuals who were treated for lipid lowering, particularly with the statin. Nearly about 13,000 patients in the Copenhagen dental population very clearly reveal discordant ApoB levels are very important. Having seen this, I need to tell you the levels of recommendation given by the LIE 2020 guidelines. Those people in whom you have highest risk, 70. 100 should be the goal for non-HDL, 30 milligram. Goal for ApoB, less than 80. Very high risk, 50, 80, 65. Extreme risk A group, almost same. Whereas when you concentrate on the extreme risk group B, where you have coronary artery disease, polyvascular disease, more than 3 risk factors, recurrence of events, you should keep the levels of LDL cholesterol less than 30. Goal for non-HDL cholesterol should be 60 less than that, and ApoB goal should be less than 50. That's the recommendation what we have done through Lipid Association of India. We need to remember it is a moderate non-conventional risk factor. Level more than 110 milligram almost corresponds to 130 milligram now. Assess the risk, almost I covered it. Diabetes, metabolic syndrome, obesity, high triglyceride concentration, and very low LDL levels. ApoB should be recommended in high-risk patients after LDL and non-HDL goals have been achieved. Discordant elevated ApoB levels, it indicates that there is a high residual cholesterol risk. It may warrant intensive statin therapy and the use of non-statin drugs. Efforts should be made to bring in gradual change in the perception of the importance of ApoB amongst the physicians, patients, and laboratories. Laboratories should standardize their methods. Immunoassay method probably is the best method. ApoB estimation should be included in the standard lipid panel. When it is not measured, it is not possible, non-HDL should be assessed. We witness more advances in our understanding of atherosclerosis, which had led to the development of lipid-based biomarkers. Lipid-based biomarkers help discriminate risk of CVD when it is unclear. Implementation in clinical medicine remains very, very difficult. Why? There is a discrepancies in the literature, lack of assay standardization, poor accessibility, high cost. May offer more precise assessment and risk of lipid-lowering therapy. Use of LDL to assess CV risk and guide therapy is now firmly established. Entrenched in the minds of clinicians and in routine practice LDL all the time. Replacing the LDL with ApoB is likely to take time and is not easy since physicians and patients are accustomed to LDL cholesterol all the time. Efforts should be made to change the perceptions and practice gradually. So, ladies and gentlemen, let me now conclude my talk by telling you one important message. LDL cholesterol is a target that should be considered at present. It is better target when compared to non-HDL and ApoB. And you should try to keep it at the lower level. And the earlier the better, longer the better. Thank you very much, ladies and gentlemen, for patient listening.
Thank you very much, Dr. Is Att Rcn. As usual, it is another feather on your cap.
Thank
Excellent, explicit way of explaining the current concepts in lipidology. As you said, all of us are focused on LDL cholesterol. Now, non-HDL cholesterol, ApoB, you have brought in, and the ways of reducing also. I have only one doubt.
Yes.
See, we want it to be reduced to earlier 100, now 70 and 30. We'll have to use larger dose of statins. Is it worthy or tolerated by the 30 milligram, nobody tolerates. Nursing, sir?
Sir, reducing it and keeping it at the level of 30 is indicated only for an extreme risk group B.
Okay.
For the people who have established coronary artery disease, People in whom you are not able to bring down the LDL cholesterol to the levels what you want less than 50 in that group. Or people in whom you have a recurrence of events. In spite of bringing down the levels less than 50, the patient is getting another attack, or he has got a polyvascular disease. Such patients are coming under extreme risk group D. So such patients need to probably are expected to bring down the levels of LDL to less than 30. And we need to start high dose statin for very high risk individuals. Very, very important. Because there's no point in just giving a smaller dose, updating it, starting with 10 milligram, 20 milligrams, and going for a 40 milligram. It's always better to give high dose statin for an individual who requires the beneficial effects of statin to prolong his life. Most important. I think we need to have a good interaction with the patient, start the medicine appropriately and adequate dose.
Sir, one comment I have that in recent literature, they are saying that in diabetic patients, ApoB is a better marker of CV risk than non-HDL or even LDL, especially in patients with insulin resistance. In fact, I read an article where they were saying that if ApoB is raised in a pre-diabetic state, you can predict diabetes 3 to 10 years earlier if your ApoB is raised, provided you can obviously afford it and do it. My second, sir, question, just a small one, is that in my experience, I have seen that those people, especially younger people who are coming with very high cholesterol levels, diabetic, I do diabetes. If I add very early, just 10 milligram of statin with 10 milligram of ezetimibe, within 3 weeks, 1 month, I get a cholesterol, I get an LDL of. So why is it that we are going to, higher and higher dose of statins? Why not start ezetimibe at least at 10 or 20? Because it gives excellent results. I've seen it in many.
Yes, sir. Can I try to give some answers, sir?
And within a month, you are getting it to the level. And then maybe.
Sir, no doubt about the ApoB. ApoB is the best actually parameter which can be concentrated in people with diabetes. No doubt about it. The problem is that we always try to, in fact, no, if you are able to recollect the projections what I made, ApoB is the one that should be concentrated in people with pre-diabetes, metabolic syndrome, severe obesity, or type 2 diabetic patients, or people who are not showing a good response, or very low levels of LDL cholesterol. You need to concentrate on ApoB. The ApoB estimation cannot be thrown out. It should be considered, provided if you have a good standard laboratory who can give you the promising results all the time. Most important, because it should be done by an immunoassay method, not by the usual standardization. The global standardization has not been done. Moreover, it is very costly procedure, and you cannot submit all your patients for this procedure. At least once in a patient with a diabetes, you can always do it. But what is important here, most of the patients with diabetes, they will have either normal LDL or even subnormal LDL, but that does not matter. Whenever there is a triglyceride increase, is always showing that the patient has got an associated non-HDL cholesterol increase and associated ApoB increase. Why? ApoB is almost equivalent to small dense LDL cholesterol or small dense LDL particles. So when you don't want to measure small dense LDL cholesterol or small LDL particle, you can concentrate on ApoB, which is the best parameter. And that if it is not possible for you to go for a standardized laboratory where you're not able to get a proper result, you can always try to depend on non-HDL cholesterol, which is actually very, very simple. You don't require any laboratory technician to do it. All that is required is only calculation. That itself will guide you properly. It's almost equivalent to the ApoB.
Dr. Narsingan, question from the physician's point of view.
Yes, sir.
Everybody does LDL cholesterol, non-HDL cholesterol. What are specific subsets where a physician must get an ApoB? A simplistic answer.
Those patients in whom you have a higher risk and the LDL cholesterol not very high. You have started a statin. The cholesterol levels have come down. But you know that the patient has got a high risk. Taking into consideration whatever guidelines that you follow, whatever level of evidence or other things you follow. If the person is coming under high risk group, it is better that ApoB is done for such individuals. Particularly patients with diabetes, patients with metabolic syndrome, or patients in whom there is a problem of CKD, ApoB probably will give you final message.
So I have one question, Dr. Narsingan, from you. We always, talk of, atherogenic risk and targets. I think we should segregate these two. I mean, what I gather from all the evidence till date, if we take into consideration the atherogenic risk, it is non-HDL oblique apolipoprotein B. And if we see the targets, it is LDL even today, followed by non-HDL, and then the other. So, I think the atherogenic risk versus targets, I think should be segregated.
Yeah, I think time is not far off to witness that changes are going to occur. It's very difficult for us to accept immediately, or it should come to OP. That is not going to be universally accepted. People now have reservation because they had been traditionally following one method of identifying LDL all the time. Now time has come for us to probably open our eyes and try to look at other parameters, whether this is going to be useful. Probably in the next few years, you will witness more data on ApoB or non-HD.
Thank Dr. Narsingan for such a nice...
With this, we finish this session, and the next session is on tirzepatide, a new blockbuster for diabetes. And the speaker for this session is Dr. Vinod Mittal. Dr. Vinod Mittal is a senior consultant diabetologist and head Center for Diabetes and Metabolic Diseases, Delhi Heart and Lung Institute, New Delhi. He's director, Delhi Diabetes Center, New Delhi, past chairman and secretary, RSDI, Delhi chapter, fellow American College of Physicians, RSDI, Diabetes India, ICP, master class in diabetes management, Royal College of Physicians, postgraduate program in diabetes, John Hopkins, PG diploma in diabetes management, Middlesex University, London, vast clinical experience, received many awards and orations. With this, I will hand over the session to the chairperson, Dr. Abhishek Srivastav, to conduct this session. And the other chairperson is Dr. Animesh Chaudhary from Dr. Abhishek.
Sir, good afternoon.
Yeah, good afternoon, Abhishek.
Kaise hain, sir? And thanks, Manoria sir, for organizing such a beautiful and academic programs. And I truly welcome Dr. Vinod Mittal sir, who is a renowned physician and a well-known figure. And let us give the dais to Dr. Vinod Mittal sir, and we'll listen to him. Thank you.
Thank you. So thanks a lot, Abhishek, for those kind words. And I convey my thanks to Dr. P.C. Manoria for inviting me to share my views on tirzepatide. Just let me share my screen. Yeah, can you see my screen? Is it visible?
Yes, sir, visible.
Okay. So, good afternoon, everyone. And it's my proud privilege to share my views on tirzepatide. It's a new blockbuster for diabetes, epidemic of diabetes and obesity. It's already available in US and would soon be available in India, maybe next year. And it is basically, these would be my, say, flow of presentation, some guidelines, clinical trials, diabetes control, then weight control, and CVOT. So it's basically a dual GLP-1. We already talk of GLP-1 receptor agonist. We know them. But it's a dual GLP-1 plus GIP receptor agonist. GIP, we used to think it's an inert molecule, but now, recently, it has been known it is no more inert. It is very, very active. And it's already available in US with the name Mounjaro. So this concept came with an idea of, bariatric surgery. We know a couple of years back when bariatric surgery was started with a big boom, there was, the conclusion that it leads to remission of diabetes. And, at least if not remission, a decrease in weight and, other parameters. So then it was found that bariatric surgery is not just an anatomical switch. It is more than that, it's a metabolic switch. There are changes in incretins and other hormones. And these are like GLP-1 was found to be increased 3 times, after bariatric surgery. And then GIP was also found to be increased. And glucagon also increases the energy expenditure. and then PYY peptide also. So basically, effect on glucose was basically overall a reduction in fasting plasma glucose, postprandial glucose, and HbA1c. So this was the turning point, and that time it was thought that why not GIP1 is also combined with GLP-1 receptor agonist. So these are different, basically, effects of GLP-1 and GIP, and both are complementary to each other. So that point has to be well understood, that if we combine these two, there would be a greater reduction in glucose control, HbA1c, and a more reduction in weight. So there are more, dual peptides already going on. The studies are already going on, and these are like tirzepatide I'm talking. Then there is also, basically cotadutide, which is again the studies are going on. This is GLP-1 and glucagon, and then SAR 425, 899, and others. So basically now it is time has reached when we have GLP-1 that we should add more molecules to the existing armamentarium of anti-diabetic medications. So basically, tirzepatide is a multifunctional peptide. It is 39 amino acid peptide, and half-life is 5 days. So once a week injection is given, just like other GLP-1 like dulaglutide, and we have semaglutide. Now there's basically, so it's available as 5, 10, and 15 milligram world over. And important point is these are all clinical programs, surpassed clinical program already done with the tirzepatide, and there are almost 6 studies and then 1 COVOT which is already ongoing CVOT. So this point has to be understood. We have a vast data and evidence in favor of tirzepatide as a strong weight reduction as well as glucose reducing. So it is a molecule going to help in epidemic of diabetes. So these are different, clinical, trials, SURPASS 1, 2, 3, 4, 5, 6, and then CVOT. And SURPASS CVOT is versus dulaglutide. So because dulaglutide is recent, the latest, GLP-1, which was released, with CVOT, and was found to be having better, in fact, slightly better than even semaglutide. So this study is ongoing. We don't have the results as of today. Now, all SURPASS programs, tirzepatide was used in a dose of 5, 10, and 15 milligram in 3 arms, and the 4th arm was the comparator. Comparator was even placebo, metformin, glargine, or even semaglutide. We have a very good study versus semaglutide, because as of today, semaglutide is taken as, it has been approved also for anti-obesity, medication. So it is taken as, a kind of a prototype, or, the best medicine as of today. So I'll be showing you the results versus semaglutide. So these are the different programs, and we can see A1C reduction with with tirzepatide is almost 2%. In fact, SURPASS 2, it is 2.5%. So approximately 2 to 2.5% A1C reduction, which is very, very important, and is the maximum. It's more than even semaglutide. And then SURPASS 2 is the trial versus semaglutide, where tirzepatide was given in 3 arms as 5, 10, 15 milligram, and semaglutide was given as 1 milligram. And the baseline treatment, the background treatment, was metformin. So metformin was given along with lifestyle modifications in all. And then in 3 arms, tirzepatide 5, 10, and 15, and the 4th arm, it was semaglutide 1 milligram. Now, these are the baseline characteristics in 2, and they are, basically cross-matched in all the 4 arms. And we can see the difference. We can see, semaglutide is, the brown, this one. And so basically, if we see the one which is, say, tirzepatide is, got a better A1C reduction, slightly better than semaglutide 1 milligram, that is 15 milligram. And if we see this proportion of patients reaching A1C goal at 40 weeks, here again, we can see here the first, we can see this bar diagram, the 92% patients on tirzepatide achieved the results while 81% on semaglutide achieved the targets. So this is an important thing to understand. And then surpassed, there was also 7-point SMBG at baseline and at 40 weeks. Then here also, there is a more flattening. So we can say there's a very slight difference, but it is more flatter with tirzepatide versus semaglutide, although it's almost the same. Then if we see here, this is another important. Again, we can see this is all the basically weight reduction. This is semaglutide, okay, and these are all tirzepatide 5, 10, and 15. So even in a dose of 5 milligram, the lowest dose for tirzepatide, there was a greater weight reduction compared to semaglutide 1 milligram. So this point again has to be well understood, that it is more robust agent in decreasing weight loss compared to semaglutide. Maybe since there is another GIP molecules also being added to this, so that may be the reason. And then we see different parameters. If we see and we compare this with say semaglutide, we can see here that A1C reduction around 2.4 or 2.2, and with sema it is 1.8. So there was a greater A1C reduction compared to semaglutide. All the doses 5, 10, and 15 milligram. Weight reduction was tremendous, much more, almost double of that of semaglutide. Even LDL reduction was almost parallel to semaglutide. HDL also increased almost same, but little more with tirzepatide compared to semaglutide, and TG levels also decreased more than semaglutide, as well as systolic blood pressure also reduced much more than semaglutide. So overall, SURPASS-2 trials showed there was a better reductions in all parameters, considering whether it is A1C, weight, or lipid parameters. And this is a slide again showing the same trial, a lipid profile. And we can see here again that 5, 10, 15 milligram, and this is sema, all there is a decrease, much more decrease in triglycerides, and this total cholesterol also. HDL increased much more than semaglutide. LDL lowering was also more. So overall, as far as lipid parameters are concerned, there were better reduction and with say tirzepatide. And this is another important thing, is the composite endpoints. 60% of the participants on tirzepatide achieved the composite endpoints compared to 22% once weekly semaglutide. So overall, once this molecule comes, I think we'll have a better molecule once a week, which will have a better A1C reduction, more lipid friendly, as well as more weight reduction. Side effects are almost comparable. We can see here whether it was in terms of nausea, vomiting, diarrhea. You can see almost the same. Obviously, the higher dose tirzepatide had slightly more nausea, vomiting, but there's always a graded or a gradual increase. We always start low. So in tirzepatide, we start with 2.5, increase to 5, and then 7.5, 10, and then you make it 15 milligram. That's how we go for the increase in the dose. So we can see the over. And other important thing is, whenever these nausea, vomiting occur, they are only in the initial stage. As the time passes, there is a less, because there's some kind of a tolerance develops, and there is less nausea, vomiting as the time passes. Now, this is the treatment discontinuation. This was slightly more with higher dose of tirzepatide overall, but it was almost the same. And then, permanent discontinuation also. So this was a little more compared to, but otherwise, if we see all other parameters, they're also, matched with semaglutide. Now, SURPASS-3 was, in this, a CGM was used to see whether time in range was achieved, in which one better or, less. So here, we can see this was basically, 24 weeks and say 52 weeks. And here we can see again, I'll show you in the next, diagram. And then we can see here, basically CGM. This was, basically versus degludec, because degludec again is a standard, basal, true basal insulin. And this was compared with the CGM. There was a more flattening of the curve or not, and less, or more time was spent in time in range or not. So here we can see all the curves, this is the baseline, and as the time passed, we can see more flattening of the curve. And let's see the results. Tirzepatide 10 and 15 milligrams significantly increased the time spent in time target range at 52 weeks versus insulin degludec. So an insulin, which is a basal insulin taken as, which is given every day, taken as again, again a standard for, time in range. Here also, tirzepatide significantly increased by, some percentage better than degludec. Then SURPASS-4 was versus glargine for CVOT, although, like we have origin trial with the glargine, which was in favor of glargine, that it is a safe molecule as far as cardiovascular risk is concerned. It was given in high risk category of CV cardiovascular risk patients. So here again, there were 2,000 patients and 85% had history of CVD. Background was metformin, SGLT2, sulfonylureas. And, it was again primary endpoint. It was non-inferiority of tirzepatide versus glargine. And here again, A1C reduction was good. We already know. And then adverse effects were almost the same as hypoglycemia and other. Nausea, vomiting was slightly more, but hazard ratio 3-point hazard ratio was 26%, better than glargine. Although this is really not considered as a CVOT, we are still awaiting another CVOT versus dulaglutide. But here in this trial, it showed better results in terms of reduction in 3-point MACE by 26% versus glargine. Then weight loss was significant. Almost 9 to 10 kg of weight loss was seen in different SURPASS trial, whether 1, 2, 3, 4, or 5, or 6. And this is nausea, vomiting. Again, it was higher with the higher dose, understood, but it decreased as the time passed. Other side effects was not significant in terms of pancreatitis, anti-diabetic medications, anti-drug antibodies, medullary thyroid carcinoma, and retinopathy, which is more with semaglutide. Now, this is weight loss. This is, basically when we normally, lose weight with lifestyle modification, there is initially weight loss, but then there's a metabolic adaptation and we tend to gain weight. So there comes the role of these molecules which help us in keeping the weight reduced despite of metabolic adaptation. Now, there's another program which has already been done. SURMOUNT-1 has been, has already been, say, published in June or July 2022, and it was as an anti-obesity medication. Now, GLP-1 have been tried, only basically liraglutide and semaglutide have been approved. This molecule, as of today, has not been approved, but there are studies ongoing, SURMOUNT-2, 3, and 4, and I'm sure this molecule would be approved for, as anti-obesity and would be better than semaglutide. So in this, it's a little congested, slide, but this was basically, in SURMOUNT-1, baseline, weight was 104, BMI was 30, and there was significant reduction in this by almost 20%, which was much higher than basically, semaglutide, where it was only 15%. So overall, what I want to say that, till now, the evidence shows that it has better A1C reduction and reduction in the weight. Now, SURPASS CVOT is already going on, where tirzepatide is compared versus dulaglutide. And again, let's see, the results would be take another 2 or 3 years, and let's wait till that time. These are basically, just 2 minutes more. So these are, some basically prescribing information. The molecule is contraindicated in patients who have history of medullary thyroid carcinoma. There is sensitivity to the drug. And yes, type 1 diabetes and history of pancreatitis, we don't have any data as of today. Yes, warning and precautions in patients, who have pancreatitis or hypersensitivity reaction, kidney injury, severe GI problems, retinopathy. All these are relative, precautions we have to take. So, friends, the take-home message is very clear that SURPASS clinical program has shown, tremendous, benefits of tirzepatide in, in reduction of the weight as well as A1C. versus semaglutide 1 milligram, which as of today has got the maximum benefit. It was still better in terms of weight reduction, BP reduction, lipid friendly, as well as cardiovascular risk factors reduction. CVOT is ongoing. GI side effects are almost equal to other GLP-1 analogs. We know that, and that will remain. And this molecule, as of today, is not approved for obesity. But once it is approved, like this might be the best agent for diabetes and obesity. We can handle this dual epidemic of diabetes and obesity. So with this, I conclude my talk and I convey my thanks to all of you.
Thank you for the wonderful talk. Again, we will hope this molecule will do better, because obesity also is a very big global problem nowadays, apart from the diabetes and the hypertension. So, forum is open for any question.
Dr. Mittal, how
Yes,
do you
sir.
compare injectable semaglutide 2.4 with tirzepatide for diabetes?
Yeah, so that would be, once it is approved for anti-obesity, then maybe the dose may be more. We have as of today 5, 10, and 15 milligram. So for semaglutide, if we talk oral, it's 0.3 it's
No,
3
I'm
milligrams.
talking about 2.4 sema.
That's what I'm saying, sir. That's what I'm saying. I'm in continuation. So all the molecules which have been approved for as anti-obesity, the dose is much higher than anti-glycemic dose. Even for semaglutide, it is 2.4 milligram. Normally, we don't give more than 1 milligram. Okay. And similarly for, even liraglutide, we don't give more than 1.8, but it is 3 milligram. So here, maybe the dose we give in giving as 5, 10, 15, it may be 25 or 30. We don't know. We don't know. Let it come. But this would be improved, and dose may be more than 15 milligram. But as of today, 15 milligrams showed better results than 1 milligram. So 2.4, we don't know.
So if there are no questions, we pass on to the next talk. And the next talk is again on lipidology, remnant cholesterol, current concepts and future directions by Dr. Rajiv Agrawala. Dr. Rajiv Agrawala, please stop sharing. Your CV has to come first and then you can share.
Okay, should I stop sharing?
Yes, yes. Dr. Rajiv Agrawal is a well-known orator and all of us are his fans. He's a chairman, Department of Cardiology at the Jaswant Rai Specialty Hospital, Meerut. He has interest in preventive as well as invasive cardiology, particularly diabetic vascular disease. He has received several awards like the Amar Ujala National Excellence Award for Lifetime Achievement 2017, Lifetime Achievement Award 2017 by IMA Meerut, Inspiring Doctor of India Cardiology 2018 by the Economic Times, Literacy Excellence Honor 2018 by Bharat Nirman. His department implants free pacemakers for needy people and holds the Limca Book records for implanting maximum number of free pacemakers in India. The chairpersons for this session are Dr. Grish Verma and Dr. Pandey. I'll request Dr. Grish Verma to conduct this session. Dr. Verma, please.
So good afternoon. And am I audible, sir?
Yes, you are.
Okay. So thank you very much for designing this particular session, virtual session. This is really very much informing. There may be some perplexing situations which may arise. I mean, 2 talks before, it was non-HDL cholesterol, which was labeled more as a more risk factor. But the newer concept of remnant cholesterol is being emerged as a result of various studies. And of course, we would like to know the future direction too. So I think, as you have said very well, that Dr. Rajiv Agrawal is an excellent orator. So may I request Dr. Rajiv Agrawal to please speak upon remnant cholesterol, current concepts and future direction.
Thank you, Mr. Chairperson. It is a unique opportunity to talk on remnant cholesterol. And I'm sure in next 15-17 minutes, I'll try to update you how I look at remnant cholesterol. The first thing we should carry home is atherosclerosis is a lifetime disease. It creeps while you are sleeping. So all intervention related to atherosclerosis are lifetime interventions. Why we need lipoproteins? Triglyceride as such, you know, they are source of energy, but our blood is our blood is aqueous. And it is very difficult to carry blood and aqueous things together. So nature, they have encapsulated them into lipoprotein, and that is how the solubilized the fatty substance in the blood and lipoprotein evolved to bind the lipids. Let us understand the basics of atherosclerosis. We have two types of particles, which are either triglyceride rich or cholesterol rich. Bigger the particle, more is the triglyceride content. On the extreme left side, you have unique protein called ApoA1 HDL, and this particle is the densest particle, a smaller particle, and rich in cholesterol. On the left side, on the right side, you know, you have chylomicron remnants, which are rich in triglyceride. They are big particles, and there are two types of triglyceride-rich particle. One is ApoB48, which is of intestinal origin, and hepatic origin. They are ApoB100. So LDL is conventionally a molecule which is associated with atherosclerosis, but lately we have started believing that these three other particles are also atherogenic. And if I combine all the particles, what we say, what Narasimhan described, non-HDL, simple, total cholesterol minus HDL, it is a non-HDL particle, and you can say this indirectly reflects the ApoB load. And if you measure ApoB alone, then you can be still more precise. So risk prediction will be better off with these particles. So non-HDL-C can be simply calculated by total cholesterol minus HDL-C. Non-HDL-C targets are usually 30 points above the LDL targets. So just again, once to make you visualize and memorize, on the left side is a huge triglyceride-rich particles. When they are hydrolyzed, they become chylomicron remnants. They are still very big, very, very big in comparison to LDL on extreme right, or LPA particles. They are called chylomicron remnants, and the lipolysis or hydrolysis is done by an enzyme called lipoprotein lipase or endothelial lipase or hepatic lipase. Dr. Narasimhan has already showed you that even the TG-rich remnants explain CV and mortality residual risk beyond statin therapy, and they are independent of LDL-C and HDL-C. That's why it is very important to take into account non-HDL-C compartment of our lipid profile for its atherogenicity. This is just yesterday's publication that fasting triglyceride are positively associated with cardiovascular mortality risk in people with diabetes. So triglyceride-rich particles, naturally, if you have higher triglyceride, you create more triglyceride-rich particles like chylomicron remnants or VLDL remnants, what we call as ideal intermediate density lipoprotein. The another beauty is that if we understand the observational studies, remnant cholesterol and lipoprotein A, they behave more or less same in the Mendelian randomization studies and observational studies. So don't underestimate the value of remnant cholesterol in presence of LDL cholesterol. How it moves around, this is a VLDL or intermediate density particle, you can say VLDL remnants, or this is chylomicron remnants. VLDL is secreted by the hepatic enzyme, liver, and this is intestinal absorption. And they move in and out of subintimal space, leading to atherosclerosis. So remnants can also move in, but chylomicron as such are very huge particles. They bounce back from the intima and they are not causing atherosclerosis. When they become remnants, they're able to move in. So the movement can be paracellular leak, it can be fluid phase, it can be receptor mediated, and transcellular channels. So my remnants don't move through paracellular space, what we call gap junctions, because this can only permit particle movement up to a size of 65 to 70 nanometers. Other particles, bigger particles, mediate through the cellular mechanism, either fluid phase, receptor mediated, or transcellular. So chylomicrons don't move, remnants move in. So it's a kind of endothelial transcytosis of lipoproteins, and bigger particles are retained in the vascular lumen. They don't move into subintimal space, what is called sieve hypothesis. So today we are going to talk not on the left side, we are going to talk on triglyceride-rich lipoprotein called LDL, or the chylomicron remnants. Chylomicrons are several fold larger, as I have shown you pictorially, and contains more amount of total cholesterol than LDL. Remember that next time somebody tells you a small LDL is deadly but slightly larger one is harmless, challenge this hypothesis, because they can move through the transcytosis and they are atherogenic. Once again, showing and re-emphasizing, re-imprinting on your mind that both these particles can move in. It is only chylomicrons which are bounced back. VLDL, which very little go inside the subintimal space. Largely it is VLDL remnant lipoprotein, IDL, LDL, chylomicron, residual lipoprotein, they move in, and this is lipoprotein lipase, which makes them smaller by removing the triglyceride and becomes richer and richer in cholesterol. They move in. This is just a diagrammatic representation that how the lipoprotein lipase decreases the triglyceride content, and these particles, they become smaller and smaller. Hepatic lipase, when it works in high triglyceride environment, it makes a small density lipoprotein, which is still more atherogenic because the movement is still easier. Summarizing, low TG, large LDL particles, but when you have high TG, like NAFLD, you have small dense particle, and these particles are very, very atherogenic. So as the triglyceride level increases, LDL cholesterol almost plateaus down, but LDL particles number increases. So higher triglyceride level, probably the LDL particle correlates better than the LDL cholesterol. And you should remember that high triglyceride level, they modify the lipoprotein character and its atherogenicity. Again, the movement you are seeing that they can move in and out, but chylomicrons don't move. It is chylomicron remnants which move inside. This is how they move with lipoprotein, oxidize LDL. They are taken by macrophages and foam cells are made. Another thing which you should remember, that they are highly inflammatory. LDL is less inflammatory. If you look at the LDL, CRP levels are more or less plateaued. But if you look on the triglyceride, the CRP level of higher triglyceride are higher. So we say triglycerides are more inflammatory than LDL. So triglyceride particles makes particles smaller, which are more atherogenic. They make milieu more inflammatory. That is one difference you should remember. And the reason is when we have chylomicrons and chylomicron remnants, the epigenetics changes and inflammasomes are excited and they produce lot of inflammatory substance. And that is how the inflammation is more in the background of triglyceride. So let us come to what is the intervention required. Correlation versus causation. We know they correlate well with atherosclerosis, but causation is an issue. And if causation is there, whether we can handle it or not is the ultimate clinical goal. Field study, fenofibrate, was a negative study. It did not show any benefit. And only thing which was benefited was non-fatal MI and revascularization. They were the two components being benefit. But mortality was not reduced in field, and in field, females were benefited more with non-fatal MI than men, while accord, it was more men than women. So these two studies were contradictory and we don't have final answer. But by and large, field was a negative mortality study. If you look at all the triglyceride lowering particles, the only consistency is there is no CV mortality reduction, no mortality reduction. So triglycerides interventions, despite triglyceride has been shown to be atherogenic, are consistently negative for CV or total mortality. That is the bottleneck. Many of you will bring in discussion Reduce-IT, which was a positive trial, but ladies and gentlemen, Reduce was not a triglyceride lowering trial. Triglyceride was lowered by only 16–70%. It did not correlate with the triglyceride level. The triglyceride in Reduce-IT was a marker for enrollment. It was not the end point of enrollment. So to my mind, Reduce-IT is not a lipid triglyceride lowering trial. It is a vascular trial. You know the result of triglyceride were just reduced by 20%, CRP by 40%, and whether you are more than 150 or less than 150, the outcome was same. So triglyceride was a marker in Reduce-IT, not it was a marker of enrollment, was not a therapeutic goal. And the Reduce-IT is into a lot of controversy because of mineral oil, because mineral oil has got its own problem regarding inflammatory marker. So Reduce-IT is a vascular trial. And you know, in Reduce-IT, the mineral oil has got lot of inflammatory markers increment, with the result some of the people believe that Reduce-IT is a positive trial because of negative placebo. So strength worker call it is a positive trial because of negative placebo. And these were the negative placebo coordinates. Prominent was primarily a pemafibrate TG lowering trial. It failed, withdrawn. So triglyceride atherogenicity, chylomicron remnant atherogenicity is an established fact, but we are not able to hit it despite the reduction in ApoB, ApoC, increase in HDL-C, pemafibrate increased LDL-C and did not reduce ApoB 100. So this trial was midway stopped as a negative trial. We have another drug, buprenorphine, again withdrawn. So triglyceride lowering trial with the intention to lower chylomicron remnants and VLDL remnants are consistently failing like HDL raising trial. Now what we have in future, we have very strong hypothesis in atherogenesis of these molecules, but let us see what is in store for us because we are still hopeful. So as I told you, lipoprotein lipase, endothelial lipase, they are protective for us because they cause lipolysis, hydrolysis, and clearance of these molecules. If we stop, inhibit this evenocumab, which inhibits angiopoietin protein like 3, so these levels, lipoprotein lipase and endothelial lipase, will increase. With the result, positive outcome will increase. Similarly, ApoC3, when we inhibit by a drug, by a molecule, this lipoprotein lipase will increase. So these two drugs, angiopoietin 3 like 3 or ApoC3, they are upcoming drugs to reduce the triglyceride level, which they effectively reduce, but we don't have an outcome trial. So this is just the same diagrammatic representation. Lipoprotein lipase, the triglyceride-rich particle, they remove free fatty acids and reduce LDL and IDL. So it bypasses the LDL receptor. Now we have a therapy which can reduce LDL without taking it to the LDL receptor, what is called as the evenocumab or angiopoietin-3 protein. They can reduce effectively angiopoietin-3 like proteins, and they can reduce both LDL and triglyceride. You can see the effective reduction of by evenocumab, the triglycerides. So you can place LDL lowering therapy on this side and triglyceride lowering therapy on the right side, and evenocumab in between, which can handle both triglyceride and LDL. So when these therapies are used, the LPL is lipoprotein lipase upregulated. They are taken up by this also. They are taken up by without this receptor-mediated mechanism by passing the LDL receptor, and these particles can be reduced. So another drug which we talked about is volanesorsen, which is ApoC3. Again, it effectively reduces triglyceride, but both these molecules, we are waiting for outcome trial. If it is positive, we have made a huge beginning, but if they are negative, the triglyceride axis goes untamed again. The ApoC3 axis is independent of lipoprotein lipase also. That is one beauty of ApoC3. So it has got lipoprotein lipase dependence as well as independence, and is effectively reduces and is a drug of choice in familial chylomicronemia syndrome. This is phase 3 trial. If I compare both the drugs, they both upregulate lipoprotein lipase, which hydrolyzes and clears these molecules, and independence of lipoprotein lipase is also seen in volanesorsen in ApoC3 inhibition, while it is not there in the other molecule, evenocumab. So that is how these drugs are placed. This is a new drug which has come just last, I think, 15 days back. This is another way to hit hypertriglyceridemia, presented by Dr. Deepak Bhatt. If I look in totality, the triglyceride lowering does not remain a very powerful goal. The guidelines say if achieving the LDL level 2AP, but I personally feel this is misplaced because this is not a triglyceride lowering indication. It is a vascular indication. Primary prevention, it is 2BP, and in high-risk patients where LDL-C is achieved, it is 2BC. 2BC is, you can imagine, after that is 3A. So it is the weakest possible indication for triglyceride manipulation. At the moment, our emphasis is primarily LDL reduction. Another way, as I talked, listened to the discussion in previous talk, I agree with that, that if you combine ezetimibe with simvastatin, non-HDL reduction is better. So there is a good idea if you have a patient who have high TG and LDL, it is good idea to combine statin and ezetimibe because non-HDL reduction is better with ezetimibe statin combination than statin alone. So ladies and gentlemen, today triglyceride reduction is primarily lifestyle modification, therapeutic lifestyle change, because that can effectively reduce, purposely reduce the triglyceride level. And this is an algorithm which talks about EPA, evenocumab, volanesorsen, but EPA is not a TG lowering, it's a vascular trial. Here, the titration is not in relation like LDL reduction. We don't have TG reduction outcomes. It's basically a vascular trial and has become a controversial trial because of negative placebo. These two drugs are upcoming on board. Phase 3 is good, but we don't have an outcome data, so I don't know what is their future. So if I summarize all the therapy, primarily non-LDL directed therapy, ApoC3, apoangiopoietin particle 3, and these therapies we don't have an outcome. ApoA1 HDL mimetics, anti-lipase, all these therapies are upcoming on board. They are Alice in Wonderland, but we don't have an outcome data like we have outcome data for statin, ezetimibe, and PCSK9. So that is the biggest challenge. My crystal ball is the CRISPR technology will take over all these therapy. CRISPR therapies are called gene scissors. You remove the gene and you are done. So we have PCSK9 gene deletion therapies. Human trial has started. This is worm technology. One of the Indians is leading this trial, Dr. Seth Catherson, and he is speaking now of gene scissors for angiopoietin protein like 3. And if this is done, that is how it look at. You give PCSK9 after a heart attack, still residual aims in terms of LDL and TG, give another shot of angiopoietin protein like 3. And this is once in lifetime. You remove the gene. And this is the future. And that is what I describe Alice in Wonderland. 2 shots and your lipids are modified for lifetime. You can see the effectiveness within a month, like 4 foundation pillars in heart failure. We are going to see the future that we can knock off triglyceride and LDL both to the bottom by 2 injections. This is called once and done approach. This is lifetime reduction in elevated cholesterol. So if I place all these therapies, the non-HDL target, triglyceride-rich targets are secondary targets. They are atherogenic. They are not able to control them. We should stick to LDL goals because they are the most documented goals. And predominant gains in secondary prevention is through LDL. Triglyceride therapies are upcoming. We are waiting for outcome data. Till then, they are very good hypothesis. Taming and modification of remnant particles, whether it will result in good outcome is unknown. I'll just summarize with last 2-3 slides. Let us apply Koch's postulate for LDL hypothesis. LDL causes atherosclerosis. LDL can be effectively reduced. LDL reduction causes regression of atherosclerosis and mortality reduction. So my Koch's postulates are applicable to LDL hypothesis. When I apply it to remnant particles, which are rich in TGs, they are atherogenic proteins. They can be effectively reduced, but the third point is the bone of contention, and that is the problem that TG reduction do not translate into outcome benefit till today. I do not know the future. So at the moment, the Koch's postulate are not applicable to remnant particles. I am not contesting their atherogenic risk. I am contesting that at the moment, we are not able to control them. That's why the residual risk remains very high, and you should focus only on LDL. Science does not care really about your belief. So your belief is there that we should reduce triglyceride, but at the moment we are not able to handle it. So your belief is not translating into an outcome. Let us heal the arteries by modification of the lipid. Let us treat atherosclerosis. And ladies and gentlemen, disease is more expensive than health. We should at least be more cautious whenever patients are expressing disease. At least they should not have recurrence of disease. So I'll close up and wind up with a message that remnants are atherogenic proteins. They can be reduced, but we need to have an outcome data to justify their usage in day-to-day clinic practice. Evanicumab and volanesorsen, they are 2 therapies we are waiting for, or CRISPR technology, gene scissors, where it is once in lifetime and you are done. So I'm very wishful and hopeful we are able to manipulate triglyceride axis also, but at the moment we don't have an outcome data. Thank you very much.
Thank you very much, sir, for such a clear and comprehensive talk on remnant cholesterol. My question is, how can we calculate this remnant cholesterol? This is one, and there are certain studies they have proven that they are, as you have also expressed, that they are more risk factor as compared to LDL cholesterol in ischemic heart disease, and ischemic heart disease, ischemic strokes, and even they are very well associated with myocardial infarction. So how can we calculate it, and how do we relate with all these situations?
You say their atherogenicity is beyond question. There is no discussion that they are atherogenic or not atherogenic. They are atherogenic. Since at the moment the crudest possible calculation is non-HDL reduction, if you want to be more emphatic than ApoB, I will say let us focus on these two parameters and effectively reduce non-HDL by existing therapies. Non-HDL targets, even if they are unachieved, there is very little you can do. That is the problem. And these therapies, which I have talked about, are still without outcome. Like pemafibrate, we were expecting it will do miracles. Like vupanorsen, we were thinking there 50% LDL triglyceride reduction, it will do magic, but it didn't do. So I think like HDL raising therapies, it failed. Similarly, at the moment, triglyceride is atherogenic, but I am not interested in pushing my clinical colleagues to calculate remnants and all these things and wasting money without therapeutic intervention. The simple calculation is non-HDL. Still, you want to go ahead, ApoB. Let us not get patients' money wasted on remnant cholesterol particles and all these things, because they are not therapeutic target at the moment, because we can't do anything for them. That is how I look at it.
Dr. Agarwal, there has not been any outcome trial, as you said, but the hype for remnant cholesterol is tremendous during the last couple of years.
Yes, that is there.
So
that
this
is they are too atherogenic. I agree with you. They are truly atherogenic. We know that. But what to do? There is nothing beyond LDL reduction. What should I do?
Sir, you want to say
still you remain an LDL man?
Yes, because I have to spend patients' money on outcome. I am not to do a cosmetic correction without any benefit that a physician is happy triglyceride is lower. So permit me to say so that at the moment, TG correction is cosmetic correction.
TG
Thank you very much, sir.
From the pancreatitis point of view at the
That is different thing. That I agree. That is a different thing. But at the moment in atherosclerosis, I wish is in the absence of data of TG modification, we should focus on LDL reduction. Their atherogenesis is not contested at all. They are atherogenic.
Sir, besides this therapy which you have told that they are emerging, is there any study, or would you like to say something regarding dietary restriction which can
that is all
change
free
it?
sugars, free sugar, exercise, weight reduction, absence of alcohol, their therapeutic lifestyle modification that may reduce your triglyceride, that works. Like naturally raising HDL works for you, not by drugs. If you have high HDL because of exercise and weight reduction, it gives you immunity, not the drug raise. So at the moment, triglyceride axis is to be modified by therapeutic lifestyle changes, weight reduction, absence of alcohol, physical exercise, taking care of good diabetes, taking care of good thyroid. These are the things that can modify triglyceride axis, not the drugs.
Thank you.
Thank you very much, sir, for fantastic. Thank you very much for sir, such a fantastic talk. And over to PC Manoria, sir. And I'm highly thankful, sir, that you have given me to witness such a wonderful talk.
Thank you.
We conclude this session, and the next session is on hypertension, hypertensive emergency, and the speaker for this session is Dr. A. Mugunathan. Dr. A. Mugunathan is our dear friend. He's former emeritus professor, Tamil Nadu, Dr. MGR Medical University. He's an international advisor for Royal College of Physicians, Glasgow, international member of the Medical Education Board of RCP Glasgow, Chairman IMA Hypertension Standing Committee, Member Tamil Nadu Medical Council, Advisory Council Member of National Board of Examination, Director Hold Medical Academy, Chief Editor MediBeats, immediate past Governor American College of Physicians, India Chapter, Dean Indian College of Physicians, in past President Hypertension Society of India, and past President Association Physicians of India. Dr. Amal Bhattacharya.
Yeah, I'm here, sir. Good afternoon.
I hand over the session to you.
Yes, sir. So hypertensive emergencies is one of the dreaded complications of hypertension. And it also involves target organs which are vital like kidney, heart, and brain. So we should know how much reduce and how fast it can be reduced. For that topic, we have none other than Dr. Muruganathan, sir, who has very well conducted API in Coimbatore. We invite Dr. Muruganathan, sir, to conduct this session, lecture, hypertensive emergencies. Over to you, sir.
Good afternoon. Can I have the slides, please? Good afternoon, Manoria.
Yes, we will play the video recording of Dr. Muruganathan. He will come for question answer because he is not in his hometown. He's at Mumbai. So first we'll play the video recording and then you will have the answer, the question answer section.
I have chosen the topic hypertensive crisis. It is not so easy to talk about this subject. In chronic hypertension, the threshold and the target is 130/80 in majority of situations. But in hypertensive crisis, each situation has different threshold, different targets, different drugs, and different time frame. What is hypertensive crisis? Blood pressure, systolic blood pressure more than 180 and diastolic 120. If that is associated with organ damage, it is emergency. If it is not associated with acute end organ damage, it is urgency. People talk about malignant hypertension, which is retinal hemorrhage, exudates, and papilledema, renal involvement in the form of malignant nephrosclerosis. Whereas accelerated hypertension, similar to malignant hypertension, but papilledema is absent. I have already told you, hypertensive emergency, end organ damage, plus hypertensive urgency, end organ damage, minus. What are the target organ damage in hypertensive emergency? Let us take first neurology. Neurologically, it can be encephalopathy, including posterior reversible encephalopathy syndrome, hypertensive encephalopathy, stroke due to cerebral infarction, transient cerebral ischemic attack, non-traumatic intracerebral hemorrhage, and seizures, unspecified convulsions. Retinopathy, hypertensive retinopathy, in aortic dissection of thoracic aorta. In cardiac, it is acute myocardial infarction, acute heart failure, and renal acute kidney injury, scleroderma and renal crisis, progressive systemic sclerosis, hematologically, microangiopathic hemolytic anemia and other non-autoimmune hemolytic anemias, pregnancy, severe preeclampsia and eclampsia, and HELP syndrome. These are the pictorial representation, injuries, brain, kidney, heart and lungs. Now, what are the precipitating factors? The non-adherence to prescribed antihypertensive medications, dietary sodium indiscretion, over-the-counter or illicit drugs, example, cocaine, amphetamine, sympathomimetic agents, and non-steroidal anti-inflammatory drugs, and high-dose glucocorticoids, anxiety or panic, an acute stroke or heart failure, which can be both cause and consequence of severe hypertension. Patients with acute glomerular nephritis, preeclampsia, pheochromocytoma, and scleroderma renal crisis may present with acute severe hypertension. Among hospitalized patients, mobilization of infused intravenous fluids, withholding of antihypertensive medications, pain, and urinary retention are common precipitants. For patients presenting without a clear precipitant who meet criteria for treatment-resistant hypertension during follow-up, further testing should be considered for secondary cause of hypertension, such as renovascular or primary aldosteronism. Then, how do you assess? Perform complete patient history. You should elicit a good history about history of previous hypertension, CVD, endocrine disorders, surgeries. And then if they are hypertensive, disease duration, previous BP control, what are the drugs they are taking, and the compliance. You should investigate for alcohol consumption, some food ingestions, or use of drugs such as corticosteroid, mineralocorticoid, estrogen, NSAID, cyclosporine, carbamazepine, or metoclopramide, and angiogenesis inhibitors. And how do you start physical examination? Proper assessment of BP with accurate BP measurement with appropriate size cuff in both upper extremities, cardiovascular examination, patient who has systolic or diastolic heart function, neurological examination, and in the blood pressure, if it is maybe 220 by 120, etc., they may have nausea, vomiting, fundoscopy findings like hemorrhage, exudates, papilledema, and neurological status, headache, confusion, somnolence, stupor, visual loss, seizures, focal neurological deficits, and coma. Cardiac, prominent epical pulsation, cardiac enlargement, congestive cardiac failure, and renal findings, astrocytoma, proteinuria, oliguria, and gastrointestinal symptoms. After thorough history, after the physical examination and fundoscopy, lab tests like creatinine, blood count, urine analysis, ECG, BNP, chest X-ray, thoracic echocardiogram, thoracic contrast CT, brain CT, and renin, aldosterone, and catecholamines for secondary hypertension, and others according to the clinical presentation. Hypertensive urgency. Before starting treatment, 1 in 100 outpatients use correct technique. Let the patients in a quiet room and recheck BP. In 10 to 20% of patients, BP may come down. If there is a persistent high BP, it is preferable to admit the patient for serial evaluation and investigation for potential hypertensive emergency. Guidelines differ. Then plan management. Though people say hypertensive urgency can be treated at home, in many situations it's better to observe because they may go for hypertensive emergency. The questions to be answered: what is the BP level at which one should start the treatment? 180, 120 and above. How quickly should the blood pressure be reduced? What is the blood pressure target during this time period? How should this goal be achieved? We suggest lowering the blood pressure over a period of hours to days rather than longer periods of time. This suggestion stems from and seeks balance between two major concerns. Too rapid reduction can lead to stroke because of cerebral hypoperfusion. Too slow reduction can lead to acute coronary syndrome and acute pulmonary edema. And over this period, it is suggested lowering the blood pressure to 160 to below 160 to 100, or to level that is no more than 25 to 30% lower than the baseline blood pressure. However, the short-term blood pressure target may need to be above 160-100 if patient is presenting with very high BP. Over days, it may be brought down to 140-90. What are the drugs we give? We give clonidine, labetalol, idolizine, all oral drugs. And of course, in clonidine, you may have rebound hypertension, bradycardia. Labetalol also can produce bradycardia. You can start 200 milligram, and then maximum 1200 milligram. Don't use sublingual nifedipine and buccal nifedipine. The choice of oral antihypertensive agents should be made on the basis of the underlying cause of hypertension, urgency, patient demographics, and comorbidities. Combination antihypertensive therapy can be considered to achieve effective BP control and help with medication compliance. The most important message in hypertensive urgency: first, confirm urgency by serial BP, absence of end organ damage. Don't lower BP too rapidly or too slowly. Remember, potential for this patient to go for emergency. Prevent hypertensive emergency in urgency patients. I told you, now we go for hypertensive emergency where there is end organ damage. The goal of therapy: to what level, to what time frame. There is a general rule for hypertensive emergency. For adults without a compelling condition, the systolic blood pressure should be reduced by not more than 25% within the first hour. Not more than 25% within the first hour. Then if stable, 160 by 100 millimeters within next 2 to 6 hours, and then cautiously to normal during the following 24 to 40 hours. This is the general rule for hypertensive emergency. There are some exceptional conditions which I am going to talk to you later. This level of blood pressure control will allow gradual healings of necrotizing vascular lesions. This is the algorithm. If you see end organ damage, S means it is emergency. Exception to general rule are aortic dissection, stroke, preeclampsia and eclampsia, and pheochrosis. So these are the 4 conditions, exception to general rule. All the other conditions, we follow the same method, what we said, that is 25% in the first hour and 160, 100. And we'll see hypertensive emergency. First, we will talk about ischemic stroke, hemorrhagic stroke, and hypertensive encephalopathy. Don't increase intracranial pressure. In a ischemic stroke, you first find out whether the candidate, whether they are suitable for thrombolysis. If they are not suitable, treat the systolic blood pressure more than 220 and diastolic 120. If the patient is suitable for TPA, then treat systolic blood pressure, bring down to 185 to 110 before you give thrombolysis. And in acute intracellular hemorrhage, BP 150 to 220, nowadays there are a lot of debates going on whether it should be less than 160, 140, but practically it's better to reduce to 140 to 150 and maintain that level. Avoid BP variability, very important. You should have a smooth, pleasant BP reading, otherwise fluctuations can cause problems. And subarachnoid hemorrhage, the balanced risk of rebleeding with risk of reducing cerebral perfusion pressure. And you know, in acute ischemic stroke, patient qualify for IV thrombolysis therapy, then reduce to 185, 100, lower BP go to less than 125, 185 to 110, and then maintain BP 180, 105 for first 24 hours if you give IV thrombolysis. And if the patient is not a suitable candidate, initiate or reinitiate the treatment of hypertension within the first 48 hours after an acute ischemic stroke. Is not effective to prevent death or dependency. For pre-existing hypertension, reinitiate antihypertensive drugs after neurological stability. If the BP is more than 220 by 110, lower the BP 15% during the first 24 hours, mean arterial pressure. And hypertensive encephalopathy, in contrast to stroke and head trauma, the signs and symptoms of hypertensive encephalopathy are headache, confusion, nausea, vomiting. But these all usually abate after the blood pressure is lowered. So once the blood pressure is lowered, the symptoms will come down or reduce. In fact, hypertensive encephalopathy is most often a diagnosis of exclusion. Dramatic improvement after BP reduction. Thus, patients with suspected hypertensive encephalopathy should have their blood pressure lowered by approximately 10 to 25% during the first hour of treatment. Additional lowering should be gradual, such that compared with the initial blood pressure upon presentation, the blood pressure is reduced not more than 25% at the end of the first day. 25% the first hour, 25% at the end of the first day. And then what are the anti-parental hypertensive drugs? Ideal drug is treat underlying pathophysiology, rapid onset of action, predictable dose response, minimal dosage adjustments, highly selective, no increase in intracranial pressure, rapidly reversible, low risk of overshoot hypotension or adverse reaction, easy conversion to oral agents, acceptable cost-benefit ratio. But unfortunately, we don't have a drug which satisfy all the above criteria. Now, the parental hypertensive treatment currently available, I am giving from the faster to slower. The sodium nitroprusside, esmolol, phentolamine, nitroglycerin, felodipam, lebetalol, nicardipine, hydralazine, and enalapril. Only the felodipam is not freely available in our country, but sodium nitroprusside is a vasodilator. Esmolol is a beta blocker. The action starts in seconds and it goes up to 2 to 5 minutes. Esmolol 60 seconds and 10 to 20 minutes. And if you see enalapril, it's slower, 15 to 60 minutes and goes up to 6 hours. So depending on the condition, we prefer to use the commonly used drug in our ICU setup is lebetalol. It's an alpha beta blocker, 5 to 15 minutes action, onset of action, and 3 to 6 hours. Now, I told you acute ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and encephalopathy. What are the drugs? We give nicardipine, lebetalol in case of ischemic stroke. Treat when 220 by 120, except with non-thrombolysis 185, 110. You have to reduce it. And excessive BP decrease may worsen ischemia because of the cerebral hypoperfusion. Intracranial hemorrhage, again, nicardipine, lebetalol, esmolol. I told you reduce the BP. There is controversy, but still now 140 to 150 ideally. And precipitous BP fall may increase mortality. Subarachnoid hemorrhage, nimodipine, because of the vascular spasm, venous spasm. Nimodipine is preferred. Again, nicardipine, lebetalol, esmolol. And you always maintain the systolic blood pressure less than 160. Keep SBB more than 120 to maintain cerebral perfusion pressure. Hypertensive encephalopathy, I've already told you, decrease 10 to 25 first hour, 25% at the end of the day. Aggressive BP fall may produce ischemia. And then acute aortic dissection, maximal abrupt onset of pain, tearing pain, predominant back pain, radiating down to legs below umbilicus. Asymmetry of pulses, you must examine, clinical exam, you must see asymmetry of pulses. Acute AR, ECG may show ST elevation. If coronary dissection, thrombolysis is contraindicated. Very important, ST elevation may be there and you must diagnose clinically and confirm, otherwise thrombolysis is contraindicated. An acute dissection, labetalol, nicardipine, esmolol, nitroprusside with esmolol. Reduce blood pressure, systolic blood pressure 120 and heart rate 60 in the first hour. Needs continuous BP monitoring. And the emergency treatment consideration, I already told you, ischemic stroke, hemorrhagic stroke, encephalopathy, heart failure, coronary syndrome. Reduce BP to cardiac overload and improve coronary perfusion. The drug of choice is nitroglycerin, nitroprusside, labetalol, metoprolol, esmolol, nicardipine. In the case of ischemic stroke, hemorrhagic stroke, nitroprusside can be avoided because it can lead to intracranial edema. And acute aortic dissection, labetalol, nitroprusside, nicardipine, already I have told you. Renal failure, nitroprusside, nicardipine, and phenylodipam. In eclampsia, reduce intracranial pressure, maintain placental perfusion, labetalol, hydrazine, and magnesium. But definite treatment is delivery of the fetus. In sympathetic crisis, again, pentolamine, nitroglycerin, nicardipine, labetalol. You should avoid beta blocker monotherapy because you should always start with alpha blocker with pentolamine. And then pheochromocytoma, again, reduce the BP to less than 140 in the first hour. I told you 4 conditions, exceptional conditions where general rule is not effective. One is dissection, the second is pheochromocytoma, third is neurological hemorrhagic stroke, ischemic stroke, and then fourth one is eclampsia. So avoid beta blocker monotherapy here also in pheochromocytoma. And this is the summary slide. I already told you hypertensive emergency means that the target organ damage plus acute admit to ICU. General rule, I've already told you. Exceptions are aortic dissection, severe preeclampsia, pheochromocytoma present, reduce blood pressure to less than 140 during the first hour and less than 120 aortic dissection. And stroke, I already told you different protocols. If there is no other compelling indication, then you reduce the BP maximum 25% over the first hour and then 160, 100 over next to 2 to 6 hours, then to normal over next to 24 to 48 hours. In urgency, I already told you, reinstitute or institute oral antihypertensive therapy arranged to follow up at 160, 100 in 24 hours. So hypertensive emergencies and urgencies are commonly encountered in the emergency department, operating room, post-anesthesia care unit and intensive care units. The most important factor that limits morbidity and mortality from these disorders is prompt and carefully considered therapy. They are among the most misunderstood and mismanaged of acute medical problems seen today. Clinicians dealing with hypertensive emergencies and urgencies should be familiar with pathophysiology of disease and the principles of treatment. So the most common cause of hypertensive crisis is uncontrolled hypertension. And hypertensive emergencies are difficult to treat, complex, and mortality is still high. Control chronic hypertension properly to avoid antihypertensive crisis and for long-term benefit. So focus on hypertension clinic, hypertension registry you must maintain. You should have proper follow-up and adherence is important. Clinician inertia should be avoided. You should have 3 different cup sizes, promote home blood pressure monitoring and promote hypertension clinic. So ladies and gentlemen, I stop with this. Thank you very much. I will be available for answering questions.
Yes, all beautiful lecture. Explain the things in a very nice and simple manner. Big topic covered in a short time. So 1 or 2 questions from my side. How is the autoregulation be maintained if you reduce blood pressure from say 250 to 150 within 24 hours? How that autoregulation, which body is accustomed to the high blood pressure, is maintained if the reduction of the blood pressure is from 250 to 150 demanded within 24 hours. Can you hear me, sir?
I think connectivity is not there. I think connectivity is not there. There's lost connection.
So fine, then we can conclude this session. Very good talk. Very good deliberation on a difficult topic in a short time. Thank you, sir.
So we now move on to the next session, and the next session is also on hypertension. Nocturnal blood pressure, a new target for management of hypertension. The speaker for this session is Nikhil Motiramani. He is currently working as an interventional cardiologist at the Balaji Multi-Specialty Hospital, Raipur. He has wide experience in interventional cardiology, and he has many publications in various journals. I'll hand over the mic to Dr. M.C. Agrawal for conducting this session. The second chairperson is Dr. S.K. Parashar. Dr. Agrawal. You are on mute.
Nocturnal hypertension is most neglected topic in the hypertension management. Thanks to Dr. P.C. Manoria for keeping this topic in the conference. As far as I know, it is an abnormal circadian blood pressure pattern associated with the elevated sleep blood pressure. This may include the non-dipping and reverse dipping also. So the topic is to be done by Dr. Nikhil Motiramani. He is from Raipur, and I hope that he will do the well with the topic. Dr. Motiramani, please.
For giving me an opportunity to actually present this topic among such esteemed faculties.
Please share your slides.
Yes, sir.
Okay, sir, it is visible, sir.
Slides are visible?
Yes, yes.
All right. So basically, as sir has already told, nocturnal BP is something that is actually and it is mostly to relate with circadian rhythm. And circadian rhythm, we know.
Please speak loudly. Please speak loudly.
So the nocturnal blood pressure is something that is actually ignored a lot. And we know that nocturnal BP can actually cause a lot of issues. And most of the issues that we deal are very common. And this has to do, as sir said, to deal with circadian rhythm. We know in a normal circadian rhythm, the BP as well as the pulse rate are very high during the normal hours, but they do fall during the sleep by around 10 to 20%. So if both things can happen, like what we are talking about, where there is very less amount of fall, but there can be an excessive amount of fall also. So what can excessive amount of fall do? Excessive amount of fall can lead to strokes that are mostly ischemic, and either non-dipping or actually an increased rise, that is nocturnal hypertension, can give rise to hemorrhages, cerebral hemorrhages, can lead rise to atherosclerotic vascular disease causing death and myocardial infarction. So what do we have to understand before going further for nocturnal BP? That there are various patterns that has been classified. This was first given by O'Brien and which was changed over the period of time. So what we actually want during the nocturnal is nearly around 10 to 20% fall. But what happens and what normally do we see in a normal hypertensive patients or some of the patients, especially during the elderlies or even during young phases, that either they have an extreme rise during the sleep or the night, or they do not have that amount of fall, or they have an extreme dipping. So more than 20% dipping is extreme dipping, less than 10% is non-dipping, or reverse is when there is actually a rise. So this is what is a diagram to say that this is basically what we want, but this is sometimes what happens, and this is which is the problem area which we want to focus. So what is the BP that we actually require during the nights? So there has been a little point of difference between the Americans and the Europes. As per Americans, it is something that is more than 110 systolic and 65 diastolic. But for Europeans, it is more than 120 systolic and more than 70 diastolic. So there is a slight discrepancy, but to some extent, 120/65 is what is being taken because that is where we also follow during our ABPM. Epidemiology of nocturnal hypertension, we know that in the further we'll see that what are the major things causing it. So it is very much commonly seen in Asians and in Africans also, but to most extent it is more predominant in Asian society. And to some things to deal with it is because of the increased amount of salt and being very salt sensitive. In abroad, in the Western society, many studies have been taken, especially like studies like Jackson Heart study, which showed a high amount of prevalence in African Americans. And there has been an increased amount of prevalence seen in China also, especially in patients with CKD. So how do we see that this nocturnal BP actually goes up instead of falling down to 10 to 20%? So there are few scenarios which have been proposed. That is, mostly there is an increased sympathetic surge. It has been said that because of supine position there are increased venous return, but that is a something normal phenomena. So there has to be something that changes in the normal physiology, and for that there are associated pathological factors. We'll deal with the associated pathological. So this is a very beautiful diagrammatic representation. This was the chart which we actually saw a little before also, that this is the dipper pattern. These are the dipper and non-dipper and the riser pattern. So nighttime dipping has to deal with the associated conditions in which there is kidney diseases, heart failures, structural vascular diseases, and the nighttime surge, that is the riser pattern, is mostly seen with either disturbed sleeps, insomnia, patients who have increased amount of arousals, and that can be because of sleep apneas or obstructive sleep apnea. So OSA has been associated very much hugely with nocturnal hypertension. So as I was talking about, so we know that there is sympathetic involvement, there is renin involvement. So what are the associated conditions? So salt sensitivity is very hugely seen in such patients. So volume overload. So volume overload in conditions like CKDs, heart failures, autonomic dysfunction in terms of diabetes mellitus, poor quality of sleep and obstructive sleep apnea. These are one things which are really predominant for nocturnal hypertension. Normal hypertension, especially which is untreated or which is secondary, can be associated with it. And there are things like obesity, metabolic syndrome, and increased nighttime activity. As I said, insomnia. So how do these things occur? Because these lead to lot of sympathetic and hormonal imbalances. So this is where we come up, like what actually takes place and how do we see this nocturnal BP fluctuating rather than we following the circadian rhythm. So we can see here that we saw all those things, like salt sensitivity was one thing. There was a decreased baroreflex, that is autonomic dysfunction. So salt sensitivity is going to increase the circulating volume. Increased circulating volume is also, lead to hypertension, but what also it leads is, it causes increased glomerular pressure, which is going to increase the LV preload and causing hypertension, nocturnal hypertension. Here, the sympathetic scenario is going to increase the afterload and wall stress to the patient and is going to cause nocturnal hypertension. How does this vascular damage? Because the more amount of vascular stiffness, we know that changes in the vascular stiffness again causes hypertension. But what happens with this? So what we see is increased BP surge will lead to MI and strokes. Increased LV stress, increased LV afterload, increased LV preload is going to lead to heart failures. And the more amount of volume circulating ultimately is going to lead to kidney injuries. So the major scenarios are salt sensitivity and the hormone and sympathetic drive. So how do we go ahead and how do we actually check? So we know that BP monitoring can be done either in the clinic or at homes. So how it can be done at home? So at home, it can be either through home BP monitoring or it can be through ambulatory BP monitoring. Ambulatory BP monitoring actually has revolutionized, and the concept of nocturnal blood pressure and the amount of seeing of nocturnal blood pressure causing this amount of, morbidities and mortalities came in after with ABPM only. So definitely ABPM is preferred over HBPM, but patients who can be taught about HBPM, the difference here lies to certain extent smallly, because in HBPM usually there are 3 readings, because you don't want the patient to lack sleep, because ultimately lack of sleep is also going to cause issues. But ambulatory BP monitoring is something which will take at least 3 to 6 readings, and with home BP monitoring usually it is limited to 3 readings. So we can see along with the night fluctuations, the daytime fluctuations, also the prediction of outcome becomes useful for nighttime BPs, and it gives a very good guide to the drug treatment, which is better than home BP monitoring, and definitely in the clinic it is very limited. So this was mostly about the use of ABPM for identifying how we can actually, and how is it superior over home BP monitoring, and how does ambulatory BP monitoring actually helps us in picking nocturnal hypertension. What are the effects over the organs or the target and organ damage which is? If we remember the pathophysiology slide, so heart, so there is increased vascular stress, so there is increased atherosclerotic vascular diseases, there is increased LV preload and afterload leading to heart failure. The preloads and afterloads are going to cause increased amount of wall thickness as well as the LV mass index. How does vascular injury is being predicted, or it's being shown? It is by increased carotid intima thickening. Also, we see in the peripheral arteries, there is increased wall thickenings, and which leads to peripheral arterial diseases or ischemic strokes. Brain ischemic strokes can be seen, cerebral hemorrhages can be seen, especially with the non-dippers and risers. It is a very something predominant because because once the nocturnal BP goes, there is a morning surge, which is another phenomena that is different from nocturnal BP. But both of those, especially patients who are risers, will be associated with risk of cerebral hemorrhages. Now, if the patient's having small infarcts, like lacunar infarcts or cerebral infarcts because of such issues, what will happen is it's going to lead to memory impairment and cognitive dysfunctions in the patient. Renal, as we saw, more amount of volume, there is going to be increased albuminary excretion, and there will be increased progression to chronic kidney diseases. So this was a study. Actually, Kario has been involved in studying. This is a great scientist from Japan. He has been, there is a lot of studies from him, lot of researches, especially for nocturnal BP. This has been the recent in 2020 where this article was published. So what you see here is, you see that either the cardiovascular deaths or heart failure, they are significantly being increased in patients who are risers, as well as from when we compare them from dippers. From dippers, again, here I want to stress upon, dippers are people who have fall from 10 to 20%, which are normal range, but there is again rise in CAD and rise in stroke. One point another to note is, like you can see that the blue line is showing extreme dippers. So extreme dippers mostly is on the lower phases, but there is one area where extreme dippers are on the top, that is the strokes. The reason being, extreme dipping is associated with very high risk of ischemic strokes. So this is just another way of representations of 5 years of cardiovascular risk. The time frames have been the same, the indicators have been the same, but here you can see either cardiovascular death in risers as compared to dippers, the CADs in risers and non-dippers as compared to dippers, heart failures as compared to dippers, and strokes. So this is something where we should know that, especially in strokes, that what we need is not extreme dipping. What we need to have is two dipping phenomena. So when we talk about treatment, how do we actually manage this nocturnal blood pressure or nocturnal hypertension? So we have to make sure we just not focus upon nocturnal. It is a 24-hour BP control which is needed. So it needs 24-hour BP control followed by normal circadian rhythm control and reducing the surges. So it's a three-step strategy. We have to make sure that the systolic BP is less than 145. This was basically suggested in 2018, which has been done in that further has been dumbed down to 140s. Make sure the patient always checks, and the normal BP, this is by ambulatory BP monitoring, average daytime BP 135 by 85, and target BP is there. So in the second step, so this was the first step of managing hypertension. Second step is targeting the uncontrolled nocturnal hypertension. So what we do, we have to make sure the circulating volume is important, because we see this is more predominant in Asians. We are there, more Asia, the rest of the Asia. So salt sensitivity, less volume. As I said, sleep and OSA have been really drastically associated with this nocturnal hypertension, especially the non-dippers and the risers things. So we have to make sure we treat them properly, and we have to manage the vascular stiffness. So what we have few class of drugs. What do they show with the studies? ARBs, CCBs, and diuretics have been studied way much more and shown, including beta blockers too. But these are the class of drugs in summary that have shown benefit as compared to beta blockers. So in the renin class, we have seen ARBs being better than ACE inhibitors, and evening dose has been shown having a better benefit, especially with patients who are in non-dipper or riser patterns. Studies have been done with valsartan, studies have been done with olmesartan, studies have been done with telmisartan. Telmisartan, valsartan studies have shown same effects in the evening preferred dosing. So it is just not the drug effect, it is basically the class effects of the ARBs. Calcium channel blockers, they work along with the hyperreduction on the vascular stiffness also. That is an advantage to them. And there have been studies, especially Hamida et al. It showed that there was a benefit. He used nifedipine at that point of time because this was done in 2012, sorry. And at that evening time, with the evening dosing, the BP consideration was less, but the consistency of efficacy is a little less than the RAS agents. Diuretics are extremely good, especially with patients with salt sensitive. These actually manage the 24-hour BP much better than the other. Indapamide and torsemide have not shown any effect. Mostly it is the hydrochlorothiazide and chlorthalidone that have shown effect, basically the thiazide class. And the nighttime BP is much more better with CT as compared to hydrochlorothiazide, and it was shown with Ernst et al. In his study. Beta blockers, the study have been done. They have not shown much benefit on the circadian rhythm, but the most important point, these are very much useful, especially in the patients with sleep apnea. Now, this is one area of which we should actually be screening in patients with nocturnal hypertension, and the drugs which can be very beneficial, basically drastic changes have been shown in patients of obstructive sleep apnea or sleep apnea with beta blockers. There are drugs that have been tried. Melatonin, again, the reason being the sleep cycle. The better the sleep cycle, the less of the sympathetic activity and surges, better control. Thiazolidiodoins, basically they have been acting because they reduce the insulin resistance, because to some part insulin resistance has also been seen to be a causative factor for nocturnal hypertension. So this in summary is the nutshell. We have to target the morning BP. The next step is controlling the surges or the riser or the non-dipper pattern. Try not to go into extreme dippers, because extreme dippers will have again the risk of heart strokes. So what do? We maintain the circulating volume. In the recent mineralocorticoid receptors, ARNI as well as SGLT2 inhibitors have been, the studies are upcoming. There will be much more amount of studies which will be coming up for these and data, but they are showing huge benefits. For vascular disease, CZP helps, as I was talking about. For OSA as well as increased sympathetic activity, renal denervation is also one of the ways that we can go ahead. Insomnia, again, melatonin or melatonin agonist. So this is a nutshell of treating nocturnal hypertension and how we can actually try to reduce the CV risk that this produces. These are the basic clinical trials that were done. As I was talking about, Kario et al. And Ishikawa et al. Are the major workers. Kario et al., there are huge studies coming from Japan, and they tried to measure it with different purposes, but what they see is nighttime dosing is beneficial, effective, especially with patients with OSA. And then there will be combinations showing better times in the nighttime BPs. These are some cross-sectional studies, which, as I said, was started with Ishikawa, continued with Kario, and this Kario then took it into. So they have shown that nighttime BP has shown drastic mortality and morbidity. And once we control this, especially in patients with poor sleep or OSAs, we do a huge amount of tremendous benefit in controlling them. Thank you. I'll be ready to take questions, please.
Okay, Parasar sir. Okay.
Can I speak?
Yes.
Hello. Yeah. It is nocturnal hypertension is a complication of the essential as well as the secondary hypertension. The new We have listened the comprehensive talk over the new management over the nocturnal hypertension. I want to ask, besides the salt restriction in the controlling of nocturnal hypertension, is there any advantage of potassium supplementation in controlling the nocturnal hypertension, or giving the antihypertensive medicine in particular time, like evening time you will prefer to go, or morning time? Because Dr. Moti Ramani, you have told the beta blockers are not preferable, but what I think I've read, the evening dose of the beta blocker is protective for the nocturnal hypertension. You please elaborate too.
Definitely, sir. Evening doses of beta blocker are protective, especially in patients who have sleep disturbances, which causes high sympathetic surge and OSAs. Studies, when they compared, like beta blocker studies, not comparison with other agents, but beta blocker studies in per se didn't show as much benefit in patients with essential hypertension or secondary hypertension, which are causing nocturnal hypertension. But drugs in evening time, such as ARBs as well as calcium channel blockers, have shown beautiful advantage over morning time BP doses, especially in patients who are having riser pattern and non-dipper pattern, sir. Yeah. For your question regarding potassium supplementation, there is a salt sensitive substrate where there is hypokalemia associated with salt sensitive substrate. But those patients we have to find out, so that those patients will be useful for potassium supplementation. But otherwise, every patient undergoing potassium supplementation, it's not going to take that sodium potassium curve.
What is new have come up in the management of the nocturnal hypertension? Because the dipping is very bad. The fluctuations in the BP is a main factor for causing stroke, ISD, and other vascular complications. So what is new to manage these type of maladies?
So the first thing, like the use of ABPM should be much more higher, especially with patients who have more fluctuations, either nocturnal or the morning surges, because therapy has to be titrated, the morning doses or the evening doses accordingly. Secondly, so that is one of the things that is being shown with much more beneficial. The role of melatonin has come up much more beautifully, because it has shown a very beautiful advantage, especially with the REM sleep. So melatonin studies are showing at a good amount of advantage, especially in patients who are insomniacs or patients who are having, disturbed sleep patterns. So that is one thing that is coming up.
With this, we conclude this session. And the next talk is on lipoprotein little a, LPA not little anymore. The speaker for this session is Dr. Amit Kanare. He's Associate Professor, Netaji Subhash Chandra Bose Medical College. He's done his DM from Lokman Tilak Medical College, Sion, Mumbai. He's a member of CSI, ACC Sky. Has 5 publications in various national and international index journals and more than 10 citations, and is a reviewer at national and international journals. The chairperson for this session are Dr. Harendra Kumar. I'll request Dr. Harendra Kumar to take over the session.
Yes, Dr. Amit Kanare has been introduced by Professor P.C. Manoria. His topic is on about lipoprotein little a. This lipoprotein little a has grown up now. I remember 20 years ago or 22 years ago, Dr. Inas had exhaustive write-up on this topic of America. And I was much impressed, because he used to write that it is 10 times atherogenic than simple cholesterol, 10 times more. What is the current scenario? I don't know, but that this actually needed further research, whether this is so. I request Dr. Kanare to deliver his talk and throw light on this also.
Fine, thank you so much. I hope I'm audible. My slides are visible.
Yes.
Yes.
Thank you so much. Yes. At the outset, I thank Dr. P.C. Manoria, sir, for giving me the opportunity to speak on this topic. Well, the time that is given is obviously little, I would say. The molecule is definitely not little anymore, for that matter. So going into the biochemistry, firstly, okay. So lipoprotein A is basically a combination of two molecules. Mainly, it's an LDL-like particle. It is not LDL. Let me tell you, it is LDL-like moiety. Plus, attached to it covalently is an ApoA kind of a protein. Okay. So LDL-like particle because it has got an ApoB, and to ApoB is attached an ApoA by means of a disulfide bond. Now, the thing is that obviously this LDL-like particle has similarity to LDL, and this ApoA, this ApoA, has similarity to the plasminogen. Okay, plasminogen, as we all know, is a very important constituent of anti-thrombotic or anti-fibrinolytic system of the body, which is basically a natural kind of an anticoagulation that is present in our blood system. So looking at the similarity, the kind of homology between these two molecules, that is apolipoprotein little a and plasminogen, probably they both have probably evolved from the same gene most likely, and that particular gene has developed over the years and has given rise to these two particular molecules which are very different. At the same time, we know that LPA has similarities to LDL, but is much more atherogenic. It promotes inflammation and thrombosis. Inflammation because of similarity to LDL, and thrombosis because it is similar to plasminogen, and hence it actually acts competitively and inhibits the natural anti-fibrinolytic system of the body. LPA, let me tell you, has multiple isoforms, and these isoforms are basically based on Kringle fold repeats. I'll come to Kringle. What is Kringle basically? I'll just come to that. So this is the homology. This is just a diagrammatic representation between ApoA and plasminogen. Also, let me tell you, ApoA is different from the ApoA that is present in HDL. Okay, that is ApoA1, A2, A3. They're all capital A's. This is ApoA. This is apolipoprotein small a, and hence the name lipoprotein little a. Okay. So this is the kind of homology between plasminogen and ApoA. You can see almost the same kind of representation. The only thing is the Kringle 4 repeats, I would say. The Kringle 4 repeat part is expanded. So you do not have Kringle 1, 2, 3, you just have Kringle 4, and you have isoforms of Kringle 4, 4, 1, 4, 2, 4, 3, and so forth up to 4, 10. And then you have Kringle 5, which is represented in plasminogen. And then obviously at the end, you have a protease as well, which is responsible for the action. In terms of plasminogen, it is an anticoagulant. In terms of lipoprotein little a, it actually inhibits that particular anticoagulation. That is, it leads to thrombosis rather. So this is the basic kind of representation that we have. Special attention should be focused on this particular part. That is the Kringle 4 repeat. Part 2, isoform 2 basically, which is one that is responsible for the multitude of pathological effects that are being demonstrated by this particular molecule. So this molecule, as rightly stated, is not a new molecule. It's not novel. Probably Carl Barr is the person who's discovered this molecule in 1963, and this article by Burke, he has represented as to how he had come across this molecule in terms of electrophoresis. Probably in that time, this particular molecule was not very much in light, but over the past few years, based on whatever research that we have, we know what kind of a molecule and what pathologic effects that it tends to have on the entire cardiovascular system. So LPA is basically a carrier of pro-inflammatory and pro-calcific kind of molecules. So oxidized phospholipids is one thing that it tends to carry, and this oxidized phospholipids, just like deposition of LDLC, tends to happen subintimally. And as a result of which, it is atherogenic. It is much more atherogenic as compared to LDL cholesterol. Apart from that, because of similarity to plasminogen and the competitive inhibitive effects, it tends to cause thrombosis. So this is like a double whammy. Basically, it causes atherogenesis. Also, at the same time, it causes thrombosis. So logically speaking, this is the molecule which is much more dangerous as compared to LDLC and has got far-reaching effects. So in a nutshell, if you see, these are the multiple effects that it tends to cause. You know, there's obviously monocyte chemoattractant activity. So everywhere there's inflammation, basically. There is decreased clot permeability, as a result of which plasmin cannot enter into probably the clots that are being developed by LPA, and as a result of which thrombolysis or fibrinolysis may not be that easy to occur. So the half-life of this particular molecule is around 3 days, and it is the most common genetic dyslipidemia. The only issue is that we are not able to test it to that an extent, or we are not involved in the testing of these particular molecules. And nearly 1 in 5 individuals, that is approximately 20%, are affected in the United States, much more in the Black population as compared to whites. So this is once again the representation that you can see. Plasminogen, this is the kind of that we see, kringle repeats. And these are the kringle repeats that are present in LPA. This is the LDL-like particle represented in orange. You have the red color lining on there, which is basically the ApoB100. And then you have this ApoB100, which is connected by means of a disulfide bond to these particular kringle repeats, which are nothing but ApoA. Okay. And these repeats specifically focusing on this yellow part here. This is the kringle 4 isoform 2. Okay, you can have these particular repeats are basically in the form of, it can be 1, it can be 2, 3, right up to almost 40. Okay, you can have 40 such repeats. Hence, there are at least 40 isoforms of this particular molecule, making it much more complex. I'll come to that once again. So what are the normal and abnormal levels of lipoprotein A? So initially, lipoprotein A was being measured in terms of milligram per deciliter. We now have research papers which have come with the molar concentrations as well. So generally, when you have any particular molecule that is present in nature, it tends to have its constitution or its overall content in blood, for that matter, it tends to be in a normal bell-shaped curve. This particular molecule is unique in the sense it tends to have a skewed kind of a presence in the blood. Okay, skewed in the sense its concentration less than 50. The number of the population that you see is pretty high, and obviously less than 50. Around 20% of population only tends to have a value of more than 50 milligram per deciliter. But this is the population. The population denoted in yellow in both men and women tends to be at highest risk. So this yellow colored diagram in this particular section that has been represented under the curve is what is mostly at risk. This is a representation in a different fashion, which is referred to as a box and a whisker kind of a diagram. So these are boxes. For example, if I look at this black population, you have this box, which is in yellow. Okay, and it has got a line in between. And there are these short lines that are present at both the ends. So this is basically a box. And these are the whiskers basically that have been present and that have been depicted. So this is nothing but a quartile representation of the same data that we need to see. So this is a tableau which shows whiskers. So this is the first quartile. The lower part is the first quartile. Then we have the second quartile. Then above this white line, we have the third quartile. And then we have the fourth quartile. So the levels of LP are maximum in blacks, followed by Southeast Asians. Probably this study did not look at Southeast Asians, but the recent data shows that Southeast Asians that we represent as a community tend to have higher values after the blacks. Then you have whites, and finally in Hispanics, it is even lower. And the lowest is in Oriental population, mainly Chinese, Japanese, etc. This is the same thing that has been represented. Almost 95th percentile is what is more than 117 milligram per deciliter. And obviously the chances of having a cardiovascular disease tend to progressively increase as noted in this forest chart with a significant value. This is also the representation of lipoprotein A and then the CV outcomes that we all know. So somewhere this particular line, if you see, okay, represents somewhere around the 40 mark. So values more than 40 or 50 milligram per deciliter is where the problem starts. It is obviously advocated that this particular molecule tends to cause CV death. Apart from that, there is ischemic stroke. There is also peripheral arterial disease. So there is a panvascular disease. At the same time, there is an implication that this molecule is involved in aortic stenosis as well. So calcific aortic valve sclerosis or stenosis is what this particular molecule tends to cause. So this is the same representation of the levels. What is the prevalence in US, in Europe, and as well as globally. So this is the same representation that we see here that we saw previously, a skewed kind of a diagram with respect to levels of lipoprotein A in the human population. And this is the levels of kringle 4 repeats. This red color, if you look at this particular red color plot that was previously denoted in yellow, is the same thing that has been represented here. So this obviously means that lesser number of kringle repeats that you have, higher is the chance that you'll be affected by the ill effects of lipoprotein A. So better that you have a lipoprotein A which is having higher number of kringle repeats, that is close to 40, rather than having lower number of kringle repeats. So this is a typical Gaussian curve, the bell-shaped curve with respect to distribution of kringle 4. But with distribution to lipoprotein A, it is confounded by the levels of Kringle-4 repeats that are present. So this is an important point to be noted. So how does it lead to atherosclerosis? Obviously, it has a particle which is very similar to LDL-C, and this LDL-like moiety is responsible for atherosclerosis. Let me tell you, the glycoprotein part of LPA is being elaborated by the liver. It is produced in the liver. So as well, the apo(a) that is being produced, it's also produced in the liver. This is the same thing that has been depicted. You have pro-atherogenic properties. At the same time, you have pro-thrombotic properties. Okay, so decrease plasminogen activator, decrease in tissue factor pathway inhibition, that is the extrinsic pathway inhibition. So you can have thrombosis at will of this molecule. You're not able to control, and especially it is seen in adults. We don't have much thrombosis that tends to be seen in childhood age group, but it is very commonly seen, typically seen in adults. And this is a very important point that has been made here. The number of Kringle-4 repeats is what defines the size of LPA. This is just the same as LDL molecule, the mechanisms of atherogenesis. We know all these factors, that is smooth muscle proliferation, decrease in the synthesis of endothelial nitric oxide, you have expression of molecules which are addition molecules, which tend to attract leukocytes. Then you have plasmin-mediated inflammation, interleukin 8, so on and so forth, foam cell formation, macrophages. And this is the mechanism of thrombosis. So if you have a atherosclerotic plaque, and if it tends to rupture, and the patient is having high levels of lipoprotein a, very high chances that that patient might suffer an MI or probably a stroke or whatever kind of a lesion in that particular vascular bed. So these are representations of proof of concept as to how this molecule tends to act. Lipoprotein a obviously tends to increase the inflammation that is being noted by this radiopharmaceutical FDG PET scan. At the same time, SPECT scan also depicts the same thing. So these are all just proof of concepts at the molecular level.
Dr. Kinare, 5 minutes left.
Yes, sir. So as we know, Kringle-4 repeats obviously are responsible. The lower the number of repeats, higher the number of particles at a particular level. So it is just like you have a cardiac output, but cardiac output is based on stroke volume and heart rate. And what we need to have a lower heart rate and a higher amount of stroke volume to maintain that cardiac output. But in case a person maintains it at a higher heart rate, the stroke volume obviously goes down. So similar is the situation over here. You have a particular value of lipoprotein A, but that level of lipoprotein A is not to be taken in milligram per deciliter, but it is to be considered with respect to the nanomoles. That is, each particular particle is what is important. And hence, it is this particular case when the size matters. The size of LP is what is more important. Higher the number of Kringle repeats, better is the situation. Lower the number of Kringle repeats, smaller is the molecule. With the same level of lipoprotein A in the serum with respect to milligram per deciliter, higher is the chance that the patient will have a stroke, an MI, or probably a peripheral articular disease. So this is exactly what I just repeated right now. It is complicated by various isoforms. There are incorrect measurements because the treatment was not tailored. No one looked at this molecule. And the risk of individuals with extremely high level has not been estimated. Obviously, studies have come up right now. There are many studies like this, which have been studied in various ethnic groups. And the levels have obviously been denoted. This is one thing that we should look at. Southeast Asians, if you see, significant levels of lipoprotein a, even Southeast Asians for that matter. Okay, compared to Africans, as we compared the blacks, they tend to have a higher value, definitely a higher value of lipoprotein A, but this lipoprotein A, those particular molecules are of a really heavy mass, that is big molecules, maybe 40 repeats that you can see. Hence, the chance of having an atherogenesis or probably thrombosis is lower in these particular group of patients. This is also what we know, lipoprotein A, the causal relationship is probably, there are some risk factors of cardiovascular disease which tend to cause an increase in lipoprotein A, or the other way around, we are not sure. But this is an area of investigation and research that is going on. Lipoprotein A is basically produced by an LPA gene that is responsible for its production, and the pro-cordis cohort, what was found that you have multiple variant of alleles of these particular molecules. If the patient has one allele, the chances of his having this particular thing is approximately, the values are somewhere around, maybe around 60. The two variant alleles, almost the value goes up to 100. So such kind of values then tend to exponentially rise and give rise to complication. This is a very important short script that has been taken from the 2018 ACCHA guidelines with respect to control of blood cholesterol. So the most important that they have stated is because ApoB is a major apolipoprotein embedded in LDL and VLDL. At the same time, in lipoprotein little a, it is imperative that you measure ApoB rather than LDL-C values. This is something that probably all of us are looking at. Okay, the only reason that we are not measuring ApoB is because there are various shortcomings or maybe pitfalls in the measurement of this molecule. And obviously, it carries an extra expense. That is something that we all acknowledge, and measurement in some layers may not be reliable. So if you have a triglyceride which is more than 200, the best thing is you can go for a measurement of ApoB. As Dr. Pankaj Manoria sir in his very first talk, he stated that if triglyceride levels are very high, at times you may not be able to measure LDL-C values. So this is one thing that comes into picture in case you're not able to measure LDL-C, where triglycerides on the higher side, especially more than 200, make it a point to measure ApoB. So it is a decision that is to be made, a decision if made to measure LPA, if the value is more than this, it is better that you go ahead. So almost all guidelines have stated that you should at least measure this molecule once in lifetime. That is what ESC says. Apart from that, if you have premature kind of a history of CAD in your family members, the first degree members, or yourself have it, this is something that should be measured. These are various therapies that are available. We go through the same. And this is the typical kind of presentation that we have. So LDL-C reduction and LPA reduction. If you look at statin causes at least a 50% reduction in LDL-C, but around 0% reduction in LPA. That is, statin is good for LDL-C, but not for LPA. There are other therapies also that we look at. Okay, apheresis is one of the best therapies that is being available, but it is costly. As of now, we do not have apheresis. And this is the expected clinical benefit. At least you need to reduce LPA by a value of around 100 to have any substantial benefit. Yes, sir. Fine, sir. This is from the Odyssey trial. We have alirocumab, which is basically a PCSK9 inhibitor, which has shown significant benefit in reduction of LPA. Statins have shown no benefit. I would say PCSK9 inhibitors, both of them, the Odyssey trial as well as the Fourier trial, has shown benefit. And higher the values, better the benefit. PCSK9 obviously has got exorbitant cost effects, and as a result of which is not being used in our country as of now. As previously alluded to, I would say genetically determined values of lipoprotein A. This is an important slide from the JACC article, 2017, a wonderful article, which I went through basically. This particular thing, the small yellow triangle depicts the use of rosuvastatin, and the small round thing that you see over here is basically the placebo. This is the placebo, this is rosuvastatin. So if you note basically, rosuvastatin, in fact, paradoxically causes a rise in the level of lipoprotein A, whereas placebo tended to maintain it around the same values. So look for other therapies, antisense oligonucleotide, for example, pelacarsen is one of them that is being used, which basically inhibits the mRNA of ApoA and hence decreases its synthesis. You have galactoside N-acetylate, which is one thing that is being used, okay? And significant reduction is what is being noted. So there are a lot many emerging therapies that we know that at least 2 trials, the Horizon trial, which is basically using an antisense oligonucleotide, and another phase 2 trial that is being used, which basically is using opaliceran, which is also a kind of a small inhibitory RNA that is being used. Both of them have shown very good results, almost 90% reduction. But as of now, I would say in the current clinical scenario, it's an independent cardiovascular risk factor that it has to be taken care of. Only recently, I would say the ICD-10 code has put this elevated levels of LPA as in its particular book in 2018. In fact, just to acknowledge the damage that is done by LPA, we also have an LPA Awareness Day that is celebrated on 24th March by the ACCHA every year. So obviously, the measurement, you look at all aspects of it, is difficult to manage. Most of the reporting is done in milligram per deciliter. But what is more important is you need to look at the bigger isoforms. And the best way to measure LPA is in forms of its molar concentration. That is nanomole. That is what we are shifting towards. This is exactly the same thing represented here. At the same time, conversion is not based on these particular values. There is no specific value for multiplication wherein we get from milligram, you can straight away get a nanomole. This is once again acknowledged by the fact that there are various isoforms. So the most important thing, how do you manage this particular thing, is managing the other cardiovascular risk factors. You have nothing to do with lipoprotein A because we do not have anything as of now at hand available, unless this molecule tends to cause a really adverse effect on your cardiovascular system, or it is causing recurrent kind of MIs. But since LPA levels, as here, are primarily genetically determined, one-time testing is something that we need to do. Okay, and if the values are normal, you did not repeat it, you can just go away. So screening is something that is definitely order. It is a call for all of us. The time is right now. And apart from this, I would say LPA basically it's all about calculating the other risk factors that are involved. There are a lot many other things wherein LPA is also to be included as a risk marker and can be implicated in the 10-year calculation of the risk score, the ASCVD risk scores. There is various iterations of this risk score which include LPA as well. Thank you so much. Yeah.
Thank you, Dr. Kinare. You have given a brilliant talk on this topic, rather neglected topic. Little known about this. We don't know how to reduce this. Only we have know that it is 10 times atherogenic. We don't know how to reduce this.
I mean, as I just spoke about, statins tend to slightly increase it. There are other ways of doing it. So the only way that you can do is you have one particular arm which you cannot manage. There are other ways of managing it then. So the best thing that is you can actually pull down the other risk factors. You can control the other risk factors which are responsible for cardiovascular disease. That is the only thing that we have at hand, practically speaking, in our scenario, in our Indian scenario. That is the only way. Yes, sir.
The reason for keeping this talk is, and the reason for resurgence of LPA, that pelacarsen, which is an antisense to APOA, the horizon trial is likely to come positive because the phase 2 trial was strongly positive.
Absolutely, sir.
In the future, we are likely to have transformational therapy for LP-induced cardiovascular disease. LP-induced cardiovascular disease was considered a slow death sentence, but I'm sure pelacarsen is likely to change the scenario of this deadly disease. So with this, we pass on to the last session, and the last session is on hypertension. And the speaker for this session is Dr. Sumit Bhatnagar. He is working at the Anupam Cardiac Care Center in Central India. He's done his DM Cardiology from Jayadeva Institute, Bangalore, postgraduate cardiology through distant learning from Johns Hopkins University. He will be speaking on acute myocardial infarction in patient with thrombocytopenia, how to manage. The chairpersons for this session are Dr. Satish Suryavanshi and Dr. Abdul Rashid. I'll request Dr. Suryavanshi to initiate the session. Dr. Suryavanshi, please.
Yeah, I welcome you all to this very important session. And the topic is how to manage a patient of acute MI with thrombocytopenia. This is a neglected topic. In one of the editorial, Workington et al. Has said, we know that thrombocytopenia is bad, but we do not think we can do anything about it. Currently, unfortunately, there are no guidelines, recommendations, or consensus reports. And most of the trials, whether we talk about the Triton TME38 of Prasugrel trial, or a Plateau trial of Ticagrelor, or Champion trial, most of the studies, they exclude patients who have thrombocytopenia. But we know that thrombocytopenia, when there is thrombocytopenia, it is associated with very high mortality and MACE also at 1 year. And it's very difficult to manage patients who really have thrombocytopenia. And when there is severe thrombocytopenia, even it is very difficult. It is associated with severe bleeding, and there is severe bleeding, but there is severe ischemia also in such patients. So it will be a really wonderful talk, and we have Dr. Sumit Bhatnagar who will enlighten us how to manage a patient who is having, so there is a double-edged sword, how to manage patients with acute MI who are having thrombocytopenia. So let's have Dr. Sumit Bhatnagar.
Hello, am I audible?
Yes,
Yeah,
yes,
yeah,
I'm audible, sir.
So thank you, Satyanesh, and thank you, Manoria sir, for inviting me in this topic and giving me an opportunity to talk about on this topic. And as Satish has already told, that obviously it is a part which has been very much not been studied much, researched much. So coming to I think so we'll discuss about then. So first of all, what we need to understand is what is thrombocytopenia and how we define it. So the thrombocytopenia is defined as a platelet count who is having a less than 150,000. And generally, when we see in ACS patient, it is approximately present in 5% of the ACS patients. But when we talk about the incident thrombocytopenia, like immunological, can be expected in 13% of the patients. So incident thrombocytopenia generally seen in patients who are older, or those who have a diabetes, or those who have a renal insufficiency, heart failure, or prior cardiovascular diseases. So the major limitation what we have is as he has already told that there are many studies which has been done on dual antiplatelet therapies or whatever therapies which we are antiplatelet therapies. So they have ruled it out, means they have excluded these patients where thrombocytopenia was present, like Triton, Timi, Plateau, Champion, Phoenix. And when only the CURE trial, which has shown only 8% of the participants were there in the patients who were those who were having thrombocytopenia. And when we know about the dual antiplatelet therapy, which is the fundamental component of ACS management, and when we start the DAPT, there is obviously the risk of bleeding. But if we do not start the DAPT in patients of thrombocytopenia, then there's a chances of stent thrombosis, spontaneous ischemic events. So how the balance we have to maintain and what the data we are having, that I will be discussing upon. So when we are saying the management of antiplatelet therapy in ACS patients with thrombocytopenia, that's because it is important these patients are at high risk of both bleeding as well as paradoxically ischemic events. And currently there are no current guidelines or recommendations or reports on the management of this cohort. So these are the different papers, these are different things, and the beautiful paper by Dr. Deepak Bhatt and Kyan P. McCarthy has been shown about what they have given us a guideline and what we can say a clinical conundrum in which accordingly how we can manage these patients. So before we start, I'll just talk about the causes of thrombocytopenia. So there can be because of the increased destruction, like because of the immunological phenomena, then immunological phenomena, or because of the production, there is a decreased production. So when we have seen an increased destruction like ITP, heparin-induced thrombocytopenia, which is commonly seen with our practice as a cardiology, then you have a drug-induced antibodies in patients who are having HIV, post-transfusion purpura, connective tissue diseases, thyroid disorders, with increased destruction because of non-immune phenomenological like DIC, sepsis, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome. Then we have conditions like decreased production, like malignancies, bone marrow failure, ineffective hematopoiesis, myelodysplasia, marrow depression, infection like HIV, hereditary thrombocytopenias, pediatric population, marrow infiltration, and vitamin B12 and folic acid deficiencies. So the thrombocytopenia has been classified into 3 categories: mild, moderate, severe, based on the amount of platelet decrease in number of platelet counts. So by till 1.5 lakh to 1 lakh, it is mild. 1 lakh to 50,000, it is moderate, and less than 50,000, it is severe. So thrombocytopenia, as I've already shown that it can be defined to mild, moderate, severe. The risk of bleeding can increase even with mild thrombocytopenia. It means less than 1 lakh, the incidence of bleeding will increase. And this warrants a proactive measures to reduce the risk of bleeding. So the most important thing first which we need to identify is we need to identify and correct of any reversible cause of thrombocytopenia, which can be best done by first the basic investigation like peripheral smear, because many times there are clumpings and there are things which we can know that we don't know the exact platelet count, or if there is a small platelets or large platelets that we will be coming to know, because the large platelets are slightly at they are more thrombotic risk because they have a more adherence activities. Then the medications which are associated with the development of thrombocytopenia, like unfractionated heparin, GP2B3 inhibitors, like furosemide, NSAIDs, and penicillin-based antibiotics, these should be discontinued if patient is having a thrombocytopenia. So thrombocytopenia in ACS patients, they generally have a worse outcomes, and we have a trials, and there are some 2 trials in NSTEMI patients and STEMI patients, those which has shown that thrombocytopenia at baseline was an independent predictor of mortality at 1 year. So even the ischemic target lesion, revascularization, and major adverse cardiac events were more if patient who has a thrombocytopenia. There was no association between baseline thrombocytopenia and major minor bleeding at 30 days, but at 1 year, this risk was increased. Because the cohort which included this study, they only included the patient with mild thrombocytopenia. Then there is a Crusade registry, and Wang et al. Investigated the effect of the incident thrombocytopenia, and he found that there, even with mild thrombocytopenia, there was associated with an increased risk of mortality and bleeding. And there was 10% decrease in platelet count, which was associated with increased mortality and as well as bleeding risk. The influence of the etiology of thrombocytopenia on prognosis and treatment has not been very much investigated, and it needs further exploration. And when we see about the other diseases, associated diseases like liver disease, is generally these are the patients, those who are associated with the coagulation disorders, as well as they may carry even a more bleeding risk in the patients in the settings of thrombocytopenia. So this is like the meta-analysis, the recent meta-analysis which has been come, and it has included around 11 studies in which they have seen the patients, so those who were having thrombocytopenia and those who were started on the dual antiplatelet therapy. And in all these trials, it has been shown that bleeding events were slightly raised even when the patients were started on DAPT. So these are the all we can say. So whatever the major and minor bleeding. So in what they have found is any minor bleeding episodes were slightly raised, were raised even with SSI bleeding, any minor bleeding, any major bleeding was also raised. Bark bleeding, bark major bleeding, bark minor bleeding, like 1 and class, bark 1 and 2 classes was also raised, and 3, 4, 5 was also very much raised. Then there was a most important concern like intracranial bleeding or GI bleeding, which needs to be taken into consideration. And most common thing which they were found is most patients were having GI bleeding. So these are the things which they need to keep into consideration when we are starting a patient who is having a thrombocytopenia, who has an acute MI, and they need to be started on antiplatelet therapy. So these are the the total bleeding events were slightly more, and post-procedural bleeding. This is which is the most important aspect when we, as a cardiologist, when we start managing a patient, and we want to know that whether we, by intervening him in this, either we are going to give him some benefit or we are putting him at more risk. So these are the things which we really need to keep into consideration before we start our management of an acute MI. So in hospital bleeding events, even with when you see you can see in these graphs, even with in-hospital bleeding was slightly more in patients, those who were patients or those who were started on dual antiplatelet therapy. So there are strategies in which by which we can minimize these bleeding risk in acute coronary syndrome patients like with thrombocytopenia, and these are the beautiful guideline, beautiful, I can say, the consensus given by the paper, in that paper by published in ESC. And they say the best thing which we can, the most common problem what we frequently face is GI bleeding. So they said that it's better to avoid the non-steroidal anti-inflammatory drugs along when a patient is having an acute MI. You use a proton pump inhibitor unless it is a contraindicated. If you want to intervene, then intervene with a radial approach as compared to for primary cutaneous intervention, as the bleeding risk and those posterior side bleeding risks are less when you are preferring a radial site approach. Second generation drug-eluting stent are preferred to bare metal stent. This is as per the recent trials, which I'll be discussing in later. Then there are restrict dual antiplatelet therapy to 1 month instead of continuing it for 1 year or 6 months, what we can say. The other drugs like avoid glycoprotein 2B3 inhibitors. Aspirin should be used in low dose, whichever we are having, and triple drug therapy should be avoided in these patients. The similar thing which is been shown in the diagram is just been mentioned here also. And this is a very important thing which we need to keep into our minds, that whenever we are starting a patient, whenever we are managing a patient of acute MI, these are the things which we really need to keep in mind if a patient is having a thrombocytopenia. Then there are different studies which has come up and which has shown, and there are various meta-analysis which has shown this these things. There's a comparative study of DAPT versus monotherapy. So in this, basically, there is no single study which has been done for this. It is basically the data, the trials which already are there, in that we have to find out the subset of the patients, and then we have to find out. We have tried to see how many patients those who develop the complications. So there was a comparative study of DAPT versus aspirin or P2Y12 inhibitors. Monotherapy in HCS patients would be valuable. The sub-analysis of patients with varying degrees of thrombocytopenia determines the platelet count. So this is where we need to really define the point at which point we need to stop the antiplatelets, or where we should be continuing till what limits we can be waiting the patient if platelet counts decrease to what level. So the clopidogrel, as we know, all the studies like till now trials which we are having, the clopidogrel offers a lower bleeding risk as compared to ticagrelor or prasugrel. So that there was obviously a big study and big data came, and we were very hopeful with the this new drug, because it was antiplatelet agent which was used, and plasma half-life was very less, and it's the platelet function can be restored within 1 hour after cessation of the infusion. So we were very hopeful, but the thing which was the main limitation in this, the cangrelor, the reduced the rate of ischemic events compared with clopidogrel, but there was no significant increase in the bleeding or transfusion. This was what the trial results were. But the main problem what we had is a patient, those who were having a platelet count less than 1 lakh were excluded from this trial. So now maybe we are hoping that in future studies, if we are having a patient, those who are having thrombocytopenia, and if this drug must be, if these studies continue, then they maybe we have a better data to comment about on these drugs. As of now, whatever we are having is clopidogrel monotherapy, which should be administered to ACS patients with thrombocytopenia. This is what as the recommendation till now, as from the Capri trial, those who are not undergoing PCI and if their platelet count is less than 1 lakh and more than 50,000. So what we can say is moderate thrombocytopenia as per our classification, and if patient does not have any signs of bleeding. So this is a Capri trial which demonstrated that clopidogrel as opposed to aspirin monotherapy, significant relative risk reduction in GI bleeding with clopidogrel 75 as opposed to aspirin has been seen. So this is about again the meta-analysis which we have seen about from different studies. So in all these things, the cardiovascular outcomes following PCI in these patients with thrombocytopenia, you can see it was more in the outcomes were better in the patients those who were having control group. But those who are having thrombocytopenia, if you can go, we can go with the numbers. You can see the event rate of bleedings and all risk has increased. Only thing, obviously the the major adverse event like stent thrombosis obviously was reduced, or we can say it almost same after the patient was started on dual antiplatelet therapy. But the bleeding events or target lesion revascularization was almost the same. Coming to the in-hospital cardiovascular outcomes following PCI, so in thrombocytopenia, obviously the mortality was high because of the bleeding risk and all those things. But when we say about the other parameters, those were almost same. But cardiac death, myocardial infarction, you can see these things were almost same when the patients were thrombocytopenic patients if they started on dual antiplatelet therapy. So because of the higher association of the bleeding with the prasugrel and ticagrelor, these drugs should be avoided till we have much data on that. But there are some data which are coming on ticagrelor with its twice daily dosing regimens and reversible binding. It can be in great interest, and maybe we have a better choice. But as till now, what the data we are having and whatever the stats what we are having, the patients with a platelet count of less than 50 lakhs, 50,000 are in the setting of active bleeding, and if it is better to stop all antiplatelet therapy and avoidance of PCI in these patients. The addition of proton pump inhibitor would likely reduce the rates of GI bleeding also. Coming to the stenting part, if those who are having a thrombocytopenia and needs to undergo a PCI, initially there was a old guidelines which say that BMS has a lower bleeding risk, but now with the recent trials, the second generation drug eluting stents are preferable to bare metal stent because of the benefit of preventing a restenosis. And these are the two trials by like Leaders 3 and Zeus trial, which demonstrate the superior outcomes with a second generation drug eluting stent compared with bare metal stents in patients those who are having high bleeding risk, including the patients those who were thrombocytopenic. But the important thing which was there is they need a shorter duration of dual antiplatelet therapy. And based on the limited data from this trial, we have the patients, those who have a platelet count of less than 1 lakh, but more than 50,000 can receive a DAPT with aspirin and clopidogrel for 1 month, followed by a single antiplatelet agent thereafter. So coming to this beautiful description about the management of acute coronary syndrome with clinically significant thrombocytopenia, what the data and say. So this is important diagram which shows about the management. If a patient is those who are having a platelet count of less than 1 lakh, identify and correct any reversible cause, including medications. This is the first most prior important thing which we need to see about. Then if a patient's platelet count is less than 50,000 or active bleeding, we need to stop all the antiplatelet agents, avoid PCI in this patient. But coming to this point, we are having some case studies which are coming up. And in this case studies, if you want a patient who is very sick, platelet counts are very low, and you want to do as a measure to to save his life, cardiogenic shock, or patients, you can just go with a just balloon angioplasty, and by IVUS or OCT, you need to confirm that there is no dissection. And there are some papers which says that even in these patients, then with those management, you can continue with single antiplatelet if required, or if not, then just with keep an observation, and then maybe you can keep a watch on those things. If patient if a patient if a patient platelet count is more than 50,000 and there is no active bleeding, and you want to go for a percutaneous coronary intervention, then obviously you can give with a DAPT, in which you can give an aspirin plus clopidogrel for 1 month, followed by a clopidogrel monotherapy, no aspirin, which has to be given. And proton pump inhibitor, if not contraindicated, should be given. And if you are not going for a PCI intervention, you are managing on medicines, then clopidogrel monotherapy and proton pump inhibitors can be given along with the therapy. Coming to the same thing in the stable coronary artery disease, first you identify and correct any reversible cause. If platelet counts is the same thing. If platelet count is more than 50 and no active bleeding, you can still give a patient, you can manage on stable ischemic heart disease as per the ischemia trial, you can maintain on anti-anginal drugs. Then if patient is having, despite that, if patient is having an angina, maybe you can consider for an PCI after a risk and benefit discussion with the patient and telling them the risk and all those things. And then patient can be taken for PCI. Similarly, DAPT for 1 month, followed by clopidogrel monotherapy along with proton pump inhibitor. And if symptoms are well controlled with anti-anginals, medical management can be an option in these patients without going for an PCI. So coming to the take-home message, thrombocytopenia is always is associated with an increased bleeding risk and also ischemic events in ACS patients. And drugs causing thrombocytopenia or increased bleeding risk should be avoided. PCI in patients who are those who are having mild to moderate thrombocytopenia can be done with an explained risk versus benefit ratio, and a close follow-up with an early switch to monotherapy is preferred in these agents. Thank you.
Stop sharing. Stop sharing this one.
Yeah. Dr. Sumit, very wonderful talk. And it's a very difficult subgroup of patients to treat, actually, thrombocytopenic patients. But sometimes, like, you really have to, when you get a platelet counts on the lower side in the lab investigations, you really have to recheck and get the test, real test, on the slide test, whether the platelet counts are really on the lower side, because sometimes the test can be false also. So we had sometimes we get it. But if the patient gets an acute myocardial infarction, ST elevation, in those cases, the patient needs an angioplasty. But in that case, if the patient will die later on of thrombocytopenia, but the patient would die of acute ST elevation, myocardial infarction because of arrhythmias and all. So you really have to go and set that vessel. So in that case, like, it is the culprit is the aspirin which you give to the patient, which causes a bleeding. And most of the time the bleeding, it is occurring from the GI bleeding. So my personal take is that if you avoid giving aspirin to the patient, most of the time we load the patient with the aspirin, a high dose of aspirin, that causes the GI bleed. So if we avoid that aspirin, so that can prevent the GI bleed. So clopidogrel, or even like when we talk about the Plateau trial, which compared clopidogrel with the ticagrelor. So giving clopidogrel to the patient, and even like we can have study, because the bleeding, the incidence of bleeding was same when we compared clopidogrel with ticagrelor in that study. So monotherapy, giving monotherapy to the patient, the Capri trial which we had. So clopidogrel definitely loading dose of given to the patient, and monotherapy in DAPT trial, Twilight trial, and the Leaders trial we had. Nowadays we are talking about, because now we have more efficacious drug. So that's why monotherapy can be given in these patients, and these patients can be treated with monotherapy. And we have the Champion Phoenix trial, the cangrelon. But the problem is the patients who had less than 100 counts, platelet, they were excluded. But definitely we have the results. So in such patients, the IV cangrelon, can be tried, and the results from this study, they show that this can help us out because the effect will remain, and after 6 hours, after 3 to 6 minutes, the effect goes off. So that's why the later on the bleeding will not be there in such patients. So definitely the IV cangrelor can help us out, and later on these patients can be put on clopidogrel, and after 1 month. So monotherapy definitely can help in such patients, and that is the disease. And second is giving proton pump inhibitor and second generation of stents to these patients. So these are the few things which can help in helping out and rescuing these patients who are having really thrombocytopenia, because bleeding definitely will occur later on, and which can be managed. But if such patients, they are left alone without giving anything, without any interventions, they are definitely going to die. And these chances of dying because of this acute event is very, very high.
Dr. Bhatnagar, patient of acute myocardial infarction, underwent PCI on aspirin plus ticagrelor, as we do most of the time.
Yes, sir.
On 5th day, he develops fever, which was found to be dengue, and on 10th day, his platelet count comes out to 10,000. What will be your approach for this patient?
Sir, as you are saying very correctly, this patient found to have dengue, and we have this thing that because we have an identifiable cause, it is not an essential what we can say. So what I will preferably, I will seriously switch the patient to first to clopidogrel, and then we will start the management of this thing with dengue management. And with manage, if patient is having a 10,000 platelet count, obviously we will start him on, we will give him some platelet transfusion, and we will keep an observation. Once, because the platelet count starts improving, he can be managed as a regular patients, because these are transient phenomena. And if we can manage a condition with a what we can say the reversible cause of platelet decrease, maybe we can switch, we can continue with the same drug regimen, whatever we want to try it.
Any other questions or comments? So if there are none, we finish this cardiometabolic update. Thank you very much, all the faculties and chairpersons for making the program wonderful. Thank you very much. Bye-bye.
Yeah, can I add something? Hello.
Yes.
Yeah, the programs were very good, but the attendance was very less. So my suggestion is that if we all try.
No, this attendance which you are seeing is the faculty attendance. If
What
you go to the attendee are 470, it goes to the other platform.
Then it's wonderful.
This platform shows only the faculty persons who are on the board.
Understood.
Platform is different.
That's great.
We don't keep attendee on this platform. They make a lot of noise.
Oh, very good.
That
wonderful.
3 chairs.
Wonderful. Wonderful.